Hey guys, am I audible? Am I visible? A very good morning. Anirudh, I think the PDF must be there in the Telegram group of PW. If you don't have the Telegram group channel, I'll just see if it's there in this. Okay, it's there in the description of the video. Just go and have a look at that, Anirudh. You'll have the PDF there for you guys. So, hello guys, very good morning. I'm Dr. Anjit. I'm going to give you a brief introduction of the one shot of pathology, whatever is required from an exam point of view. नहीं है ओके अनुज मैं देख लेता हूँ ठीक है I'll ask the person to have a look. It should be there. There will be a Google Drive link where it has all the PDFs of all the sessions. Just have a look at that. If not, let us know. Fine. Others, can you just verify if you got the PDF, the pre-annotated ones? नहीं है ठीक है Okay, I'll ask them to send it at the earliest. 1 second. I'll just ping them to send it at the earliest. 1 second. Okay, fine. Perfect. I have sent a message to them. Hopefully that you will be having the PDF soon. So let's start. So how's your exam prep going? Your exam is just hardly 10 days from now, right? And I know it's a very big day for you guys. You will do well. We have ultimate confidence on you. This session, an entire marathon session, is aimed to make sure that you have a very quick revision. That's all. That's the aim. So we will be going with highlighting most important previous year topics, little bit around that, so that you will get to know even if a new question comes from that. We are not going to primarily go into the depths of conceptual learning today. So we'll be primarily going through a very quick revision, and I'll be asking lots of questions, and I want you guys to answer the questions, right? So how you're going to have the discussion is, first we'll go to general pathology, then we'll go to hematology, then to systemic pathology. For an FMGE exam, definitely. Sure, Ashik, I'll do it. For FMG exam, mostly the exam questions come from general pathology and hematology. Little bit emphasis on systemic pathology. Most of the systemic pathology questions will be integrated questions, medicine, surgery, OG, or pediatrics, right? So in that note, we'll be more focusing on leukemia, lymphoma, tips to remember, like Ashik asked, and like last minute pointers or the keywords so that you can diagnose a scenario based question. That also will go through it, right? So first thing is obviously general pathology. So I'm sure you guys know many things about general pathology. You must have revised a lots of time, right? So simple questions. I want fastest finger first. Answer them. The PDF, annotated, unannotated, everything will be there with you. Don't worry about that. But if you have an iPad with you, if you have any of the digital copy with you, please go and have a look at that as well, right? Guys, the link is there. Just go and have a look at the link for who asked for the PDF. The link is there in the comment box. Let's pin it if possible. Okay. So that's a Google Drive link with all the PDFs. Just please save them. Fine. Okay, let's start. So if you talk about necrosis, apoptosis, necroptosis, pyroptosis, right? Which of these things you think is physiological? Fastest finger first. Let's interact, then go to the discussion. We'll have a quick overview and then write as well. Definitely, apoptosis is both physiological and pathological. Necrosis definitely more pathological, right? Necrosis will have inflammation, yes or no? The answer is simple, right? The answer is yes, necrosis will have inflammation, apoptosis will not have inflammation, right? Guys, I want you guys to comment so that this becomes a dual way learning. More you comment, more you're going to remember in the day of the exam, fine? Necrosis is more pathological, apoptosis is more physiological. Necrosis will have inflammation, isliye you will have pain also. That's why it's mostly pathological, right? So if you look at necrosis, what's the most common ion? Before, let's say, before the cell dies, I have something called reversible cell injury, right? So can anyone tell me what's the most common ion in reversible cell injury? Which means the next question is implied. What's the most common ion in irreversible cell injury, right? The most common ion in reversible cell injury is definitely sodium. If you remember, the ATP will not work. The sodium potassium ATPase fails, and the sodium will be there, which takes water, causes cell swelling. Irreversible cell injury, it is calcium, right? It's calcium is the most common ion in irreversible cell injury. Fine. Okay. Okay. Perfect. So there are multiple types of necrosis. Coagulative, liquefactive, caseous, fibrinoid fat, lots of them, right? So what is the most common one? The most common one undoubtedly is coagulative necrosis, right? Great, Ashik, right? So coagulative necrosis is the most common one. So coagulative necrosis is seen in every solid organ, in fact, except Nokia is a good way to remember sodium, potassium, ATPs, right? Except brain infarct. What will you see in brain infarct? There's a very basic question. You will see in brain infarct or in CNS infarct, you will see liquefaction necrosis. Apart from that, in any infarct, I'm going to see coagulated necrosis, right? In coagulated necrosis, the most important thing is you'll have a maintained architecture, which means in the microscopy, when you look, you will see something called ghost cells. Ghost cells are nothing but the outline alone will be preserved. The cell inside will die. That's what is your ghost cell. You will see that in your coagulated necrosis, not in liquefaction necrosis, right? And one more thing, there is definitely a concept you must have read about gangrene. Gangrene is a clinico-pathological term. I look at a foot, black in color, and say, gangrene is foot. Black intestine, gangrene is intestine. Tell me which type of gangrene is coagulative, which is liquefactive. Two types of gangrene are there. One is dry, one is wet. Dry gangrene is definitely coagulated necrosis. At the same time, when you look at wet gangrene is definitely a liquefactive type of necrosis. Do remember that, right? Right? Perfect. Okay. Ashik, I'll come to that. We'll come to that very soon, the pancreatitis part, right? So the most common is by default coagulated necrosis, and the mechanism of action of coagulated necrosis, if asked, it is protein denaturation. The proteins get destroyed. That's the primary mechanism of action. A little bit of extra enzyme activation also happens, but the primary mechanism of activation is this, right? Great. So when you come to liquefactive, you guys said that brain infarct is liquefactive, right? Why? Because brain is very soft, full of fat. So to destroy a fat, protein denaturation will not work. That's why I have a separate way of destruction. We call it liquefactive. To destroy the fat, I need lipase, right? So which means the mechanism of action is very, very, very different here, which is enzyme activation. So here the mechanism is enzyme activation. It is not protein denaturation. Clear? Now let's take pancreatitis. Anirudh said that, no, yeah, Ashik said that pancreas also, right? You must have read in surgery, Sandeep sir must have taught you surgery, that he must have said that in pancreatitis, can anyone tell me what is the enzyme which you look in the blood for diagnosis? This is a very important question. The primary problem in pancreatitis is you have lots of destruction of the enzymes, right? Lots of destruction of the enzymes. Self-activation and the enzyme-mediated destruction happens in pancreatitis. Amylase is something which you look in the blood. Lipase is something which will be released. So in pancreatitis, the primary problem is there's an auto-activation of enzyme. That's why in pancreatitis also, you will see liquefactive necrosis. Not in pancreatic infarct. In pancreatitis, the inflammation of the pancreas, you will see them, right? Apologies for that. So inflammation of the pancreas, you'll definitely see liquefactive necrosis. Do remember that. Don't forget. At the same time, I want you to also remember, you don't see fat necrosis in the substance of pancreas. In pancreatitis, in the peripancreatic fat. Please read the question carefully. If it's mentioned, there's a case of pancreatitis. What is the type of necrosis in the peripancreatic fat? In the fat, obviously, I can have fat necrosis. Pancreas is not fat, na? So in the substance of pancreas, in the pancreas per se, I will not see fat necrosis. I will see liquefactive necrosis. But in your fat, I'll see fat necrosis. In omentum, I'll see fat necrosis. Please do remember that, right? Next, caseous. Caseous is kind of a mix of your coagulative and your liquefactive necrosis. Kind of a mix, because there's more of macrophage activation, and also the organism per se can cause damage, right? So caseous necrosis, most important guy is TB. If you remember TB, that's more than enough for me as a consultant. So TB, don't forget. Apart from TB, if it's an foreign person, South American, histoplasma, coccidioidomycosis, because they are possible in few pockets of the world, not everywhere. Think about that. There also I want you to think first about TB only, right? So TB, histoplasmosis, coccidioidomycosis, and few forms of leprosy, not all forms of leprosy, especially it's in pure neuritic. You must have read about lots of classification of leprosy, right? In pure neuritic leprosy, I can see liquefactive necrosis. Great, perfect. Fibrinoid. This is my famous thing. Oid means like. Never ever forget it. Oid is equal to like. Fibrinoid is fibrin-like, so which means anything in the vessel, because fibrin will be seen in the vessel. That's all, right? So anything in the vessel, whatever I see, anything in the vessel will have fibrinoid necrosis, which includes every single type of vasculitis. Can anyone name me one vasculitis apart from PAN? I'm sure everyone knows polyarteritis nodosa, everyone knows PAN. Apart from PAN, any vasculitis? Any vasculitis? Vaginous granulomatosis, Struck-Stoss syndrome, SLEs have vasculitis. Every vasculitis will have that, right? Perfect. You have vasculitis, like SLE is important. Type 3 hypersensitivity is important. Any type 3 hypersensitivity will have vessel wall involvement, vasculitis will be there. Like you said, rheumatic heart disease is important. In rheumatic heart disease, there's one finding which is Aschoff bodies. Aschoff body is a change in the heart. Heart is the biggest vessel. So obviously when you have vasculitis, same inflammation of the heart considered to be the biggest vessel will also have that, right? And malignant hypertension. Because in malignant hypertension, when the BP is around 190 of 200, obviously there'll be rupture. Rupture of the blood vessel, same thing. Whenever blood vessel is getting destroyed, this happens. That's it. Anything when blood vessel is getting destroyed, I'll have fibrin-like necrosis, fibrinal necrosis. If there's a marker, it has not been asked till now, but if they ask what is the marker for fibrinoid necrosis, microscope may there's a stain, PAS. PAS will be positive in fibrinoid necrosis as well. Fine, done. The last but not the least, guys, fat necrosis. Like I said, to have fat necrosis, the organ or the tissue should be made of fat. Otherwise, I cannot have fat necrosis. Skin cannot have fat necrosis because I don't have fat in the epidermis. Right? Liver cannot have fat necrosis. I don't have fat there. Only when the organ has fat, it has fat necrosis. Fat, I have two types. One is traumatic fat necrosis, which can happen in the breast parenchyma, rich in fat, any trauma, right? Falling down, injection, any trauma can cause it. Gluteal region. A simple injection of an IM, you have a paracetamol or a diclofenac injection, that will cause damage because it's damaging fat. You must have read in insulin, lipodystrophy, right? Fat injection, that's all. And like I said, I'll also have an omentum. In case of pancreatitis, which will release lipase, which will go to the omentum and the peripancreatic fat. Okay, PP is peripancreatic. In the peripancreatic fat, I'll have that, right? Simple. So have one is traumatic fat necrosis. This we call it an enzymatic fat necrosis example. Fine, done. Okay. So fat necrosis, there's one more thing. Calcification is a possibility in every necrosis in the earth. But if I say that the word calcification or saponification, right? We go with terms. Saponification is nothing but it was told in fat necrosis, but please do remember this seen in every necrosis, which is fatty acids plus calcium, which is the most common ion seen in irreversible surgery, which happens in your omental calcification, or peripancreatic fat calcification, which can happen in chronic pancreatitis, right? So these are simple to start with 5 different types of necrosis. You guys are superb and you are able to answer things. Only thing is in an exam, try to correlate with the question and there will be 4 options, answer them, right? Next, we'll go to apoptosis. Apoptosis, programmed cell death. Everyone knows that. Apoptosis, physiological and pathological. Very, very important. The questions in apoptosis, there are 2 places where questions keep on repeating. One is the caspases. The other one is the pro and anti-apoptotic genes or the factors, right? So it's a caspase dependent cell death. When you take and talk about caspase, there are few caspases which I want you to remember. Caspase 8 and 10 are for extrinsic pathway of apoptosis. Caspase 9 is for the intrinsic pathway of apoptosis. Caspase 3 and 6 are for your execution phase of apoptosis. I'll write one more number of caspase. I want you guys to tell where you see them, right? Caspase, let's say 1, 4, 11. Not all, sometimes 1 or 2, sometimes only 2, sometimes only 1 and 11. Where do you see them? Where do you see them? We see them in one more caspase dependent cell death, which is pyroptosis. Fine. You see them in pyroptosis. Some books say 4 won't be there, only 1 and 11. Some books say 4 and 11. Right? 1, 4 and 11 is seen in pyroptosis. It's important. You have to remember. This came in the last exam. I think NEET PG or FMGE. You should know all the recalls of NEET PG as well as FMGE can get repeated. Right? Okay. Now let's come to pro and anti-apoptotic genes. So pro-anti-apoptotic genes, like one important thing is anti-apoptosis. It's not going to cause cell death. So the life will be longer, right? Whenever I have longer life, anything with L in the name, BCL, MCL, BCL, XL, right? It is most likely an anti-apoptotic agent, right? Both of them will be seen in the inner mitochondrial membrane. That's a location of both of these proteins, both of these genes, fine. That's what you have apoptosis, anti-apoptotic factor as well as pro-apoptotic factor, right? Baxan back is a pro-apoptotic factor. That's the only thing which I want you to remember. But if to avoid confusions, do remember this BCL-XL, because this also has L, right? We went through the template, so this also has L. If it's A here, I have S also. S for shorter. So remember, anything with L Without an S is going to be longer life, anti-apoptotic, and backs and back are the primary pro-apoptotic factors. Fine. Okay. Beyond this, I don't think you require much in apoptosis, but there's one question which came long back in NEET PG exam. I'm sure you know that. If I'm going to say, let's have a DNA electrophoresis. Can anyone tell me the pattern of DNA electrophoresis in necrosis as well as in apoptosis? I'm sure you know that. Necrosis, apoptosis, DNA electrophoresis pattern. Come on, guys. What do you see in necrosis? You know that in necrosis, there's a complete destruction of the cells. When there's a complete destruction of the cells, we end up in having we end up in having a smearing pattern. You have a smear-like pattern, a smearing pattern of DNA electrophoresis, agrostil electrophoresis in case of necrosis. And you must have seen in apoptosis, you have broken DNA. So you have something called a step ladder pattern of DNA. Okay. You have step ladder pattern of DNA, which is seen in case of an apoptosis, and a smearing pattern of DNA, which is something seen in case of a necrosis. To remember both of them, right? Both of them are important for us. Done? Okay. Now we know about a little bit about necrosis and apoptosis. Fine. Let's go to the stains. Stains are something which keeps on coming, maybe as in one-liner or maybe as a scenario-based question. Let's say I have an iron stain of Pearl's Prussian blue. Liver biopsy, Pearl's Prussian blue is positive. What is the diagnosis? That's how we apply them, right? So that also can come in the exam, right? Great, Parul. Fine. So first we'll go with the normal stains. I want you to tell me what will be the color of these stains or these products in H&E first. Then I'll tell you, we'll talk about the stain and we'll talk about the use case. What's the melanin's color in a biopsy? Normal histopathological examination, what will be the color of melanin? Melanin is not black. Melanin is a brown color pigment. Fine. Right? So Masson Fontana Schmorell stain. Schmorell stain is something which we don't use much. Masson Fontana, yes, it's a pretty commonly, routinely used things in the lab, right? Masson Fontana stain is for melanin. The last NEET PG exam, they had a twist. Everyone knows that Masson Fontana is melanin. Have you also heard some fungus called as black fungus? You might have, right? So I do have some fungus which can be pigmented. In my college, Anishama must have definitely taught you about that. So these pigmented fungus also have melanin, which can also be positive, right? It's not only in melanoma. Obviously, I'll use them in melanoma. I'll use them in nevus. Nevus is nothing but moles. Normal moles we have. These are tumors of melanocytes. At the same time, I can also use them in pigmented fungi. Okay. When I have a pigmented fungus, that pigment will also be positive for Masson Fontana. This was a previous year question. Please don't forget it. Because I always say, melanin, melanoma. Anything with pigment of melanin can be positive here. So I can say in vitiligo, the stain will be negative because it's depigmentation, right? It differs like that and the use case goes like that. Fine. Perfect. Next is hemosiderin. What's the microscopic color of hemosiderin? Normal microscopic color. Hemosiderin is a pathological iron deposit. Physiological iron deposit is always ferritin, not an hemosiderin, right? There's a pathological iron deposit. It's never physiological, right? So H&E color as usual is brown in color. It has to be a brown color. Like iron, the rust what you have in your home is brown in color. Same color will be hemosiderin also. The stain is world known. Everyone knows it. It's Pearl's Prussian blue or Pearl stain or Prussian blue stain. Anirudh, blue color will be after being positive. After doing Pearl stain, yes, in microscopy they change blue in color. Before Pearl stain in a normal light microscopy, it will be brownish in color. Fine, right? So definitely this is how it looks when it's positive, right? Where all I can use this? If I say in a liver biopsy it's positive, can anyone tell me what's the answer? Liver biopsy, Pearl's positive. The answer is simple hemochromatosis. That's all. Liver biopsy is positive, that's it, right? Next, we have lung. In lung, there are two things which for an entrance exam is must. Last year, there was a question saying that a patient with a heart failure had something brown color in the lung and the name of that is heart failure cells or hemosiderin-laden macrophages, right? So we have something called in heart failure cells. Do remember that these are nothing but hemosiderin-laden macrophages which is seen in the lung biopsy, not in the cardiac biopsy. That's one. Second clue I will tell you, you will tell me the answer for sure. This patient was working in a cement industry, had something of respiratory difficulty, respiratory distress. Biopsy was taken. long threads of brown color tissue was seen. What is the diagnosis? You guys know it. What's the diagnosis? It's a simple one. These are also called as ferruginous body. That's the last clue which I can give you. In lung, I can have two. One is heart failure cell, which can be Pearl's positive, and the other one is asbestosis or your ferruginous body, where it can be seen, right? Both of them, I'll have the same brownish color. You have to remember them. These both are important PYQs, don't forget. So you can ask, see, asbestos body, ferruginous body is an old PYQ, right? So if I have to change it, I'll say that there's a brown color pigment, Pearl's positive. You have to correlate and say it is an asbestosis, fine? Perfect, right? Next is lipid. What's the color of lipid in H&E? You know the color. That's where we start every lecture of pathology with. Lipid is always clear, right? It's always clear. The reason for clearing is lipid will be washed away during processing. They'll be washed away, they'll be emptied during processing. So which means when I see a biopsy, I don't see anything. It's an empty color. It's an empty thing. It's nothing is there, right? So for me to demonstrate that, the first of all requirement is I need a section called as a frozen section. Only in a frozen section you can do a lipid stain. Otherwise you can't do a lipid stain. It's very important. Routine H&E you won't be able to see because routine H&E is processed and is empty. If it's empty, stain cannot work. Two stains, oil rideau, Sudan black, and you can see the images how it looks. Red color for oil rideau and obviously black color for Sudan black. I can call Sudan black as SB, SBB, SB4. Lots of Sudan blacks. All of them are Sudan blacks, right? So Sudan black looks like this, the blackish color, and your oil rideau looks reddish in color. Use case of lipid is very rare with respect to diagnostic pathology. I don't take a biopsy of fatty liver these days, right? We don't do it at all. Very, very less use case. One of the real use case in diagnostic pathologies, this lipid in frozen section, oil rideau can be useful for theca cell tumor. Which organ does it come? I'm suspecting some random tumor of the ovary, and if it's positive for fat stains, we call it theca cell tumor. Most likely it can be useful. Please do remember, if at all someone wants to ask a difficult question in OBG, last time OBG was less, right? This time they'll flood with more and more questions, right? If it's there, it might definitely help you guys. Fine, perfect. Next, guys, glycogen. Glycogen as well as your, yes Gautam, you're right, glycogen as well as protein, both of them are PAS positive. But there's a slight difference. In microscopy in H&E, glycogen has two colors. It can be lighter shade of pink in color, or it can be even clear. It's based on the amount of accumulation of glycogen. Here it is PAS positive, but it is diastase, which is an enzyme which is sensitive. The meaning is diastase is an enzyme with digested sugar. So when PAS is put, it will be positive. And when we use diastase, glycogen is sugar, no? It will be digested, it will be removed, it becomes negative. That's how it is, right? So normally you see this PAS positive glycogen in a liver. In liver, you will normally even see this because liver is a storage form of glycogen. Organ, muscle and liver, you will see glycogen even normally, right? Okay. Now where I can use this is, this will be positive in every glycogen storage disorder. Any glycogen storage disorder, von Geerk's, it will be positive. Pompey's, McArdle's, right? Hers, lots of glycogen storage disorder. Everywhere it will be excessively positive. One. Second, have you heard about this? This was also an old PYQ. Let's see if you can tell me where do you see this condition? Armani-Epstein lesion. Does it ring a bell? Where do you see Armani-Epstein lesion? There also this positive. Armani-Epstein lesion is nothing but excess storage of glycogen in the proximal convoluted tubule of diabetes patients. Lots and lots of glycosuria. PCT simple function is they reabsorb. They reabsorb, they store as glycogen, right? This is seen in PCT, proximal convoluted tubule of diabetic kidney. Okay. In these both, I can use glycogen as a diagnostic pointer. Yes, it will be positive by default, right? Next, when you go to protein. Protein is not sensitive for diastase because I cannot digest protein with diastase. Nah? So it is PAS positive, which is diastase resistant. Okay, it's diastase resistant. It is not diastase sensitive, right? The two things, not just protein. One is protein for an example. There's one more condition where you'll see PAS positive, diastase resistant required for an undergraduate. One, which is protein is alpha 1 antitrypsin deficiency. In alpha-1 antitrypsin deficiency, obviously in a liver biopsy, you will see PAS positive diastase resistant. Second thing is PAS positive diastase resistant, you will see in intestine. There's an infection in the intestine. We call them Whipple's disease. Okay, Triforema whippula is the organism. In Whipple's disease of intestine, what you'll see is PAS positive diastase resistant, okay, organism in the lamina propria of the intestine. This is an old question. If it repeats, you have to know it's a perfect integrated question. I can ask a clinical scenario, make it a microbiological question by an organism, and a pathological question by a biopsy, right? Yes, you will see pan-acinar emphysema and alpha and antitrypsin. You are absolutely right, Gautam. Fine. Okay, that's about protein. Calcium. The well-known mnemonic of calcium is KAL, right? Everyone in pathology PG, the first of the few mnemonics they read is like this. You must have read in your first year, she looks too pretty, try to catch her, right? Like that, calcium is a mnemonic known for everyone in the pathology lab. Right? It's one COSA for, which is the most commonly used one. Not that great of it. Okay, they're not that great, fine. But the alizarin red, AL for alizarin red, which is very, very, very specific. If a question comes, which is the most specific stain for calcium, the answer has to be alizarin red and not von-COSA. Von-COSA can pick up calcium salts, cannot pick up elemental calcium. Alizarin red can pick up elemental calcium. The only problem with alizarin red is it's a bit expensive. And the name says red. It's red in color. This also came in the recent exam. Alizarin red color biopsy. This is von-COSA. Von-COSA, it will be blackish color deposit of calcium, which will be seen there, fine. So whenever we are in calcium, it doesn't make sense for us to leave this guy, Samoma body. Fine, Samoma body is the hallmark of calcification, right? Dystrophic calcification, not a metastatic calcification, it's a dystrophic calcification. I'm sure you know the mnemonic. I'm not going to go with the mnemonic because that's not important for me and for you as well, right? Any tumors with papillary tumors, serous tumors, right? And tumors with whorls, which is meningioma, leiomyoma. These two have it, right? So these are two things which has Samoma body inside them. Fine. Okay. Done. Perfect. Now let's go to the next guy, copper. Copper, again, the microscopic color is here also is brown in color. The multiple thing in copper is rhodonine, rubionic acid, orsine. There are lots of things. There is shikata stain. There are multiple stains of copper. The one which I like primarily is orsine, right? And I don't want to go into mesothelioma and stomatostatinoma because they don't have much. Very few of them have. It was asked once in a PGI exam. From that time, it's been repeatedly banged, right? So we'll ignore that for now, but we'll look at these parts alone now, right? Orsine is a beautiful stain compared to rhodonine or rubionic acid, right? So there's an orsine stain, brownish orange color of copper will be seen, and the only use case of copper is Wilson's disease. Okay, that's something which I want you to remember by default, fine? Right, Wilson's, you have your KF ring, you have the tremor, very early onset, you'll have copper deposition in the basal ganglia. Can anyone tell me what mutation you have in Wilson's? ATP 7A or 7B? You have to comment on that, right? It's an autosomal recessive disorder with some mutation. We use the drug trientine D-penicillamine, all those things. Whenever you read a disease, now is the best time for you to recollect everything related to disease. You will know most of the diseases, right? Let's go to mucin. Mucin is perfect. CFTR, no, not CFTR, no. CFTR is cystic fibrosis, right? It is ATP 7B, it's a transporter, right? It's a transporter. It's fine. Making a mistake, it's completely fine. Okay, perfect. So I have multiple types of mucin. Mucin can be seen in esophagus. Mucin can be seen in stomach. Mucin can be seen in colon. Mucin can be seen anywhere, right? So PAS is positive for a neutral mucin. Alcian blue is positive for an acidic mucin. Fine. And musicarmine, right? It will be positive for salivary gland mucin. Salivary gland also produces mucus, right? But different mucin, I'll have different positivity. Once Ames asked a question, what's the stain for acidic mucin? Please go only for Alcian blue because PAS might not stain it better, right? We have to remember that, right? You're completely right, Farouk. ATP7A is Menkes-Kinki's hair disease. There also is a copper problem, right? If you see this image, it has two colors. This is the color for PAS. PAS positive color is magenta. Fine. And this is the blue color for the Alcian blue. There are parts of intestine where both acidic and neutral mucin will be seen, which will be positive for both PAS as well as Alcian blue. Fine. Remember them. Okay. Perfect. Done. Right. So this is about mucin stain. Mucin alone, please do see the question. What type of mucin is asked based on that given answer. Right. When you say Barrett's esophagus, might be positive for Alcian blue as well as PAS. Okay. Perfect. Now let's go to last guy, amyloid. Amyloid normal H color is, it's a protein, right? It will be pink in color, right? So amyloid is going to be pinkish in color. So once I do Congo red, there are two things which happens. Microscopic color of amyloid in Congo red, in light microscopy will be salmon pink. See, please remember, it will not be apple green by refringence. This apple green by refringence comes only in polarized light. When I use a polarized microscopy, it becomes apple green. After applying Congo red, if I see in a normal light microscope means what you see in your hospitals. Simple, the binocular microscope, what you see in the lab, right? Simple one. Only when I add a polarizer, the color changes. Fine. As you go right, it will have restricting cardiomyopathy. Yes, a common one is always PAS is much better in eyes. If it's not mentioned, I would prefer PAS because PAS stains quite a good number of mucin. And I hope they will be logical enough to not to give Alcian blue as also PAS in the options. They won't mostly. Fine. Okay. Let's go back to this. So here you said restricted cardiomyopathy. Yes, that's one of the presentation of amyloid, right? So amyloid is an important question. We'll see about amyloid very soon, near future. Fine. There's one more stain for amyloid. Remember them. There's an older stain, but if it's asked, you should be able to know. Thioflavin S as a stain for amyloid. Amyloid can also be positive for PAS. It's a protein stain, right? Same way PAS dash is. It's also positive here. Fine. Okay. Let's go to the next one. So we've done quite a few things with respect to the first chapter. A little bit about necrosis, apoptosis, a little bit about all the stains required, in where we also read about fat a little bit, the calcification a little bit, what are the related topics we have covered, right? So inflammation is something which is a basic. So inflammation, if you understand, if you know, you can apply in lots and lots of systemic pathology. Few things I never want you to forget. Whatever acute inflammation it is, I'll have the same hallmark. Be it a mosquito bite, there'll be a swelling, increased vascular permeability. To meningitis, acute inflammation lab, increased intracranial pressure. Why? Increased vascular permeability. To pneumonia, sputum production, frothiness, pulmonary edema, same increased vascular permeability. Whichever organ it is, it will be the same. There are only two cells of acute inflammation, not one, two cells. If it's allergy related, I will look at a eosinophil. Rest everything, I'll look at a neutrophil, always. Chronic is always dates to months, right? Chronic has two important cells. The cell of chronic inflammation is macrophage, not lymphocytes. I will see lymphocytes if it's an autoimmune disorder or a viral disease like COVID pneumonia. I'll see lymphocytes, right? Autoimmune pancreatitis, it's chronic. I'll see lymphocytes. If it's autoimmune or viral related, it will be lymphocytes. Atherosclerosis, chronic, macrophages. TB, chronic, primarily macrophages. Macrophage is cell of chronic inflammation, right? And this, never forget. The hallmark of any chronic inflammation is tissue destruction and healing by fibrosis, right? So what we are going to quickly look at inflammation chapter is the events of inflammation. You guys have to be mentally ready to answer the questions you're going to ask. What's involved in rolling, addition, diabetes, everything. We look at the diseases which will be seen when selectin is absent, when integrin is absent, when the enzymes don't work. Then we'll go to chronic inflammation. What is the microscopic structure? How to differentiate types of granuloma? And what are the giant cells which you have to remember, right? Because these are just which are must to know. I'm not talking about inflammatory mediators, though they are important. But in pharmacology also it comes. In multiple subjects it comes. So for now, I'm ignoring it. Fine. Let's go ahead. We'll start the first, margination. As the name says, the WBCs normally will be in the center. That's how normally WBCs will be, in the center. From the center, the WBC is going to the corner is what we call it as a margination. Okay, that's margination. Margination is a vascular phenomenon. It's a vascular event. Because of vasodilatation, the turbulent increases. That's why we have margination. If someone asks us which molecule helps, please remember selectin helps in margination. Selectin is not going to do complete margination. It helps in margination. That's all. Crosses, and it helps in margination. Fine, that's one. Now let's go about rolling. After it marginates, the cell will roll, right? Rolling is based on two things, one on WBC, one on the endothelium. Can anyone tell me what is the molecule which is present on endothelium which helps rolling? There's a molecule in endothelium which will be coming up only when there's an inflammation. We call them selectin. We have P-selectin, we have E-selectin, right? Both selectins are there, which will be there here. Selectin is on the endothelium, not on the WBC, right? What do we have on WBC? In WBC, we have one more molecule, which is your Cialis X receptor, right? And if you are perfectly right, I would just want to ignore L-selectin because L stands for leukocyte. As a leukocyte selectin, not primarily involving in inflammation. It has a different role. We'll ignore it for now. Here we have Cialis X receptor, and this bond is a weak bond. Since it's a weak bond, that's why the push of the blood kind of rolls the WBC. Rolls the WBC till a place where there's an endothelial gap, because only in that place they can exit outside. That's your addition, where it will stop. For addition also, I need two guys. Can anyone tell me what is there on the WBC here? What is there on the endothelium here? In endothelium, we have in endothelium your ICAM, your VCAM, which is cell adhesion molecule, intracellular and your vascular cell adhesion molecule. In WBC, we have your integrins. Okay, we have integrins here. Selectin's CD marker name is CD62. If you want to know, integrin CD marker name is CD11. I have 11A, 11B, multiple of them, right? I have VCAM and ICAM, which binds with integrin, which makes them, and this bond is a very, very, very strong bond. The strong bond, so it stops, it adheres. Next is diapedesis. Diapedesis, in a simple word, if I have to tell in a single word, it's transmigration. Moves from the vessel outside. It is transmigration, that's all. For diapedesis, again, it's a two-step process. The first thing which all of you know is PECAM1. Can anyone tell me the CD marker of this? This is an important MCQ. Gauri Saha, you already told about PCAM1. Can anyone tell me the CD marker of this? Second step, which most of them forget is, which is non-specific collagenase. The non-specific collagenase release, which happens from the WBC, neutrophil has that, which will be released, right? That will destroy the basement membrane, because endothelium is given way, basement membrane is still having there. It will put holes so that the WBC can go outside, right? This is very, very important to kind of, I won't say completely destroy, but lack of words, I'm using destroy. They'll put holes, right? You are absolutely right, everyone, guys. CD31 is the other name for PCM1. Perfect, right? So that's what happens. Two rules in diapedesis. Once diabetes is done, the WBC is outside. The WBC has to go to the site of infection or inflammation. For that, I need a chemical mediated movement. We call it chemotaxis, right? First thing, chemotaxis is based on only one molecule, which is actin polymerization. Actin helps me move muscles, right? Only actin moves. So actin polymerization helps in the movement here. Fine. I have two types of molecules in chemotaxis. We label them exogenous chemotactic mediators and endogenous, which is produced inside the body, which is coming from outside the body. Most of the exogenous are your bacterial products. Bacteria's virulence factor, your lipopolysaccharide, bacterial wall, your peptidoglycan of the bacterial wall, right? Perfect, right? What are the endogenous? Can anyone tell me what are the endogenous chemotactic factors? Endogenous is come in exam, because exogenous, it differs based on the organism. Any virulence factor in the organism can attract WBC, but endogenous has already come in exam. Interleukin 8 super, LTB4 super, right? And complement proteins. All three are classical chemotactic factors. Leukotriene B4, interleukin 8, as well as your complement factor A. It all are endogenous chemotactic factors. With the help of these chemotactic factors, I reach the site of inflammation. The moment I reach the site of inflammation, I have to engulf, destroy, eat. That's what my goal is, right? After this, what happens is, it ends up happening in phagocytosis. After phagocytosis, we go into an oxygen-dependent mechanism called as respiratory burst. Just to quickly look into respiratory burst, what happens? It's oxygen dependent. It happens inside phagolysosome. So it's based on oxygen. I have a big and a most important enzyme, NADPH oxidase. With the help of NADPH oxidase, I produce O2 minus, which is superoxide anion, and I have SOD, superoxide dismutase, which will make it hydrogen peroxide. And based on the enzymes availability, if it's MPO plus chlorine, I produce HOCl minus, which will destroy bacteria. Extremely powerful bactericidal. It will kill the bacteria without a trace. Dettol has it. Lysol has it. Extremely powerful bactericidal, right? Then, based on one more structure called as major basic protein plus iodine, I produce hydroxyiodide, which destroys parasite. Fine. This is what happens ultimately in your oxidative burst, right? Oxygen, NADPH oxidase, right? And H2O2 is important for us here. And your HOI is important, HOCl is important, right? This is a very powerful bactericidal ion. Dr. Nice, I'll be completing somewhere around 2:30 to 3, hopefully. Fine. I'll give you a break around 12:45, right? We'll go for a 10-15 minutes break, then we'll complete. Fine. You have your Derma session by Jesse sir around 3:30. Done. You'll have a gap in between that. Fine. Okay. Or you might guys want a bigger lunch and then continue with Derma class. I'll leave it with you. We'll discuss that at the once we come for a break. Fine. Let's go to the disorders. So we know about normal inflammation. The moment we know about normal inflammation, our goal is only one thing, to learn about the inflammatory disorders. What will happen if integrin is not there? Right? If integrin is not there, I'll have a defect of addition. If addition has a defect, I won't have good immunity. That's your LAD1. One looks like I, right? So it's actually a beta 2 integrin ka defect. Fine. Integrin is also something which is very helpful in wound healing. So wounds don't heal properly. The first scar you and me have got is umbilicus. So umbilical scarring will be a problem. So there'll be a delayed separation of umbilical cord stump. Don't memorize. Integrin is involved in wound healing, right? So there's a delayed separation of umbilical cord stump. Okay, that's a very important characteristic feature which you know that for sure, right? Anirudh, that's the mistake I don't want you to do, because always we read select integrin for one, we mind by default says selectin. It's a leukocyte adhesion deficiency. It's a leukocyte ka problem. In leukocyte, you don't have selectin. Selectin is on the endothelium. So this is yes only, but it is Cialel-Lewis-X. It's a Cialel-Lewis-X defect, not a selectin defect. Please do remember them, right? And here, the classical finding here is Bombay blood group. See, both of them H group. In both of them, you'll have recurrent infections. You'll have recurrent infections by default. One important thing which is common to both is, in both of them, you'll have elevated WBC count. You'll have neutrophilia. This is very unlikely and very unique, because in most of the in immunodeficiency disorder, we end up in having cytosis. It reduces, right? Here, neutrophilia, because the problem here is not production, it's the exit ka problem. Everything is produced properly. No one is going outside. Imagine no one leaves India. India will burst because we produce a lot, right? So I'll have neutrophilia. That's a unique finding of LAD1 and LAD2, right? Both of them are autosomal recessive inheritance here, right? Chronic granulomatous disease, I have autosomal recessive as well as X-linked recessive inheritance. It's a defect in your beautiful enzyme of NADPH oxidase, which will be gone. Once NADPH oxidase is gone, you will not be able to produce H2O2. You will not be able to produce any anion, so I will not be able to kill properly. One unique finding is here you'll have recurrent infection with catalase positive organisms. For now, we will not read why. We have already read about that. I hope you will remember that. There's a final rapid revision. So for us, it is catalase positive. Recurrent catalase positive infection, I think of a chronic granulomatous disease. Any infection, both catalase positive as well as catalase negative, I'll think of an MPO deficiency. Autosomal recessive, here I'll have both catalase positive as well as catalase negative infection. Okay guys, hope I'm audible and visible. Sorry, these days I don't know if it's my tech issue or the YouTube's tech issue. It stops for some time and it comes back again. Fine. So what I was saying is there are few investigations which I want you to remember for chronic granulomatous disease, which is your NBT test and DHR test. Both of them are doable. NBT is a bit widely available, or I can even assay the enzymes. Fine. Okay. Now let's go to Chidiakiashi. So Chidiakiashi, it's also an autosomal recessive defect. There's a mutation in a gene called as LYST. It's an LYST gene defect, lysosomal transporter defect. So I will not have a phagolysosome formation, right? There'll be no or reduced phagolysosome formation. When there's no phagolysosome, there's no oxidative burst. Nothing can be killed. But what is unique about Chidiakiashi is not the infection. It'll have other findings. Other findings make it worthwhile for an MCQ. Patient might have albinism, problems in migration of melanocytes. Patient will have thrombasthenia, problems in the function of platelets, that's thrombasthenia, right? And patients might also have peripheral neuropathy, problems in the migration of Schwann cells. It's a migratory problem. Fine. So if it's a migratory problem, I'll have other findings also. That makes it an important question for an MCQ point of view. I can easily create a 3-4 line question. Recurrent infections, albinism, think of this. Recurrent infection, glove and stock anesthesia, peripheral neuropathy, think of this. Fine. Okay. Guys, am I visible and audible? If so, give me a hi. Let's go to the chronic inflammation. Yes, all good. YouTube has a glitch once in half an hour to 45 minutes. It's stopping like this. Okay. Yes, I'm audible. Fine. So let's go to chronic inflammation. Chronic inflammation hallmark is TB and TDHF, right? Perfect. So in chronic inflammation, we need to know how the chronic inflammation happens. And there are a few important molecules or the interleukins required for us. And how to differentiate necrotizing, non-necrotizing granuloma. And there's one big catch which I don't want you to forget at any cost. So chronic inflammation, this is how a granuloma looks like. In the center of a granuloma, what we generally have is, we'll have your macrophages. We'll have your activated macrophages. The periphery of the granuloma, we have your lymphocytes. This is how a normal granuloma looks like. In the center of this, there might be necrosis, there might not be necrosis. Here I don't have necrosis. Maybe there, maybe not there. There are very important things for granuloma. Granuloma is mediated by the cell which takes care of the entire process of granuloma is the CD4. In that, the TH1 or 2. Which subtype? 1 or 2? 1 or 2 TH. You guys have to tell me. I'll come to that very soon, right? So this TH subtype 1 or 2, whatever it is going to secrete interferon gamma, right? So this secretes interferon gamma. This interferon gamma converts my normal macrophage into activated macrophage. This activated macrophage secretes interleukin 12, okay? Primarily interleukin 1, interleukin 2 also. This interleukin 12 again converts the CD4 into this subtype. Okay, have you guys answered? I have TH1, I have TH2, I have all the answers available. Okay, in which place do you see asthma? Which subtype you see in asthma? TH1 or TH2? Because that will help us answer which will be seen in your granulomas. What do you see in asthma? Okay, let's come back to that. Fine. So one question which I want you to remember here is the activated macrophage. This activated macrophage are the principal cells of a granuloma. As the most important, the principal cell of granuloma is activated macrophage. Please do understand, granulomas are not in the principal cell is not giant cell. It's the activated macrophage which is the giant cell, right? TH2 subtype will be for your asthma, so which makes TH1 subtype come for your granulomas. Fine, perfect, done. Okay, see if you remember one other thing is very easy to remember. You can exclude it and write it, right? It's not, please write, not giant cell. The most important cell of granuloma is an activated macrophage, not a giant cell. Giant cell is a combination of activated macrophage, that's all. So I have necrotizing, non-necrotizing. Necrosis is there in center, not there in the center. How do I differentiate? How do I remember? Simple. What is necrosis? Cell death, na? So if a cell dies Or if my granuloma can kill, necrotizing. Can't kill, not necrotizing. TB, I can kill. Leprosy, I can kill. Especially the pure neurotic variant, I can kill. Granuloma is necrotizing. Histoplasmosis, I can kill. Coccidiomycosis, I can kill. Most of the infectious granuloma, I can kill. It's necrotizing. Most of the non-infectious granuloma is non-necrotizing. As simple as that. Here I can't kill. Here also I'll write TB first. Please remember this. Don't forget. Please, please. Question says fever, loss of weight. Lymph node shows non-necrotizing granuloma. Answer is TB unless proven otherwise. Granuloma is equal to TB unless proven otherwise. Please don't write sarcoid. I rule out TB, then I think of sarcoid. But first and the foremost, always TB. Other non-necrotizing, foreign body granuloma. Suture granuloma. You leave a suture material inside without noticing, silk, granuloma will happen, right? You have your occupational lung disease. We read about asbestos, right? That might have. Coal workers pneumoconiosis, silicosis might have for sure, right? Then your sarcoid might have for sure. Hodgkin's might have for sure. Also non-infectious. But when I see granuloma, always look for TB first. But if the question says that AFB, acid fast staining, is negative, then I can rule out TB. Before that, first and foremost thing, always TB, right? So it's simple. I can kill necrotizing. I can't kill non-necrotizing. There's no more confusion at all. Fine? Done. Now let's go to few important giant cells. Okay? Is there a lag? Is there a lag? For me, it looks good, Anirudh. Others, please let me know. Okay. So now let's go to giant cells. There are few giant cells which I'll show you and you're going to tell me what it is. Fine? Okay, there's no lag. Great. So tell me what giant cell is this? Where do we see them? Giant cells are combination of activated macrophages, right? So we'll have more nucleus. Based on the shape of the nucleus, we divide them into different groups. So this is an horseshoe shaped, right? When I have an horseshoe shaped nuclei, we call it Langhans giant cell. Where do you see them? We see them in tuberculosis. Perfect. It is Langhans, not Langerhans. It's okay, Anirudh. Fine. So here I have cell, the nucleus arranged in the form of a circle or wreath-like. Wreath is what you have in when a person dies in a funeral, right? Wreath-like arrangement, right? We call them a two-tone giant cell. Two-tone giant cell is seen in a condition called as xanthoma. Xanthoma is lipid-rich, right? Look at the image. You can see the whitish color here. Clear lipid vacuoles are seen all surrounding the giant cell, right? Two-tone giant cell, wreath-like arrangement seen in xanthoma xanthelismas. Vipin, what I said was, let's say I have a question which says non-necrotizing granuloma, acid fast staining is negative. Then I can rule out tuberculosis, which means I can eliminate TB and look for other causes. Before that, don't rule out tuberculosis. Is that clear, Vipin? Okay. Now this. So here also I have multinucleated giant cell, right? This giant cell, I'm going to call it an Warthin-Finkelday giant cell. Can anyone tell me where do you see Warthin-Finkelday giant cell? Though it's not that common, it's seen in measles, especially seen in measles pneumonia. I might not see Warthin-Finkelday giant cell in your oral Koplik spots of measles. I might see them in the measles pneumonia, right? Multinucleated giant cell with intranuclear and intracytoplasmic pink inclusions, right? More than one nucleus is giant cell. That's it. Okay. This guy is again multinucleated. If you look at this cell, I hope it's visible for you guys. I'll zoom it a little bit. I have a nucleus here. I have a nucleus here. I have a nucleus here. Right? So this also is multinucleated. This has a 3M characteristics. Margination of the nuclear chromatin, multinucleation, and molding. Molding means one nucleus is sitting on the other and changing the shape. That is molding. This 3M is classical for herpes. Previous repeated MCQs, Zank smear, like Gautam said. That's a repeated MCQ, but doesn't mean that it's seen only in Zank. Herpes can cause herpes simplex virus labialis. Herpes can also cause genitalis. I can also see them in pap smear. That's why I say please don't be fixated only on PYQs, little bit away from that also. It's herpes simplex, that's all. I have two types of herpes simplex. Herpes simplex 1, herpes simplex 2. Zinc smear is seen for oral cavity and pap smear is seen for external genitalia. Please do remember that, right? Perfect. And this classical diagnosis, owl's eye. Doesn't look like an owl's eye, but owl's eye inclusion. If the owl's eye is blue in color, I have a diagnosis which is cytomegalovirus. If the same owl's eye is pink in color, I have another diagnosis which is RSL. Can anyone tell me the answer? It's Hodgkin's lymphoma, right? It's a classical case of Hodgkin's lymphoma. The diagnosis is based on what color you see. If color is not clear in an exam, please go with history. Hodgkin is a lymphoma. You'll have generalized lymphadenopathy as a symptom. CMV will cause hepatitis or retinitis or chorioamnionitis. It's not going to cause generalized lymphadenopathy, right? Perfect. That's how you should be able to differentiate them, right? So these are few giant cells. Then few classical types of granuloma. Can anyone tell me what's the first type of granuloma? I'm sure you know that. What is that? The first granuloma here. You know that is your donut-shaped granuloma or donut-shaped granuloma, which is seen in two conditions, in two organs, liver and bone marrow. It's a little bit more common. Okay. It's seen in, perfect. You see them in allopurinol toxicity. Okay. Fine. One more fever. We see them in Q fever. Yes, you see them in Q fever. You see them in allopurinol abuse or toxicity, and also you see them in Q fever. Great. Next year, it's not exactly a granuloma. You don't see this also these days. We call them Druck's granuloma. Okay. Was seen in case of cerebral malaria, more like a vasculitis kind of an involvement. Vessel may all the bacterial related WBCs, RBCs will be attached. So it's a Druck's granuloma seen in your cerebral malaria. We don't see them almost always these days, right? This one. This is a granuloma. This granuloma is actually a very important difference which we generally ignore. We always focus on the shape and then we say, stellate granuloma hai. Stellate granuloma, we memorize stellate granuloma. We know that I see them in one condition. Actually, there are two conditions. We'll see both of them. Stellate granuloma, the shape is not important. In stellate granuloma, along with Th1 cells, I'll also have Th17 activation. That is important. The pathogenesis is totally different. The moment Th17 happens, here you'll have acute on chronic inflammation. Which means if you look at the microscopy in a higher power, you'll see both neutrophils as well as your lymphocytes. That's very, very important, right? Catch scratch, I'm not denying it at all. You will see them in catch scratch disease. Actually, I can see stellate granuloma in one more condition, which is not been asked, okay, in exams. If it comes, do remember LGV. The chlamydial infection, like lymphogranuloma venereum. I see them in both lymphogranuloma venereum and also in catch scratch disease, stellate granuloma. For a pathologist, real life, this is characteristic. For an MCQ exam, the shape doesn't look like sharp. Irregular shaped granuloma is characteristic. Fine. The last but not the least, microgranuloma. Tiny, chota granuloma, right? So if you have less than 25 epithelioid cells, I call them a microgranuloma seen in toxoplasmosis. This has also not been asked, but if it's asked, you should be able to answer, right? Toxoplasmosis, toxoplasma lymphadenopathy, classical condition you see is microgranuloma. Fine, done. So we know quite a few things about inflammation chapter as well. We saw about acute inflammation, the steps of acute inflammation, the diseases caused by acute inflammation, what happens in chronic inflammation, the cell of chronic inflammation, the types of granulomas, and also the image-based questions. Most of them is sorted, except for inflammatory mediators. You should be able to read them, recollect them before the exam, right? Now let's go to genetics chapter. Done. So in genetics, I'm going to concentrate on only one guy, which is pedigree. Every alternate exam, one pedigree comes. Please read this before the exam. Before going into the exam hall, read how to solve the pedigree. 2 flowcharts. If it comes in the exam, vomit it, forget it. After that, not required unless you're going to practice pediatric genetics or genetics. That's all, right? Simple. Any pedigree from today onwards, you see, first rule is simple. Rule out mitochondrial inheritance. How do you rule out mitochondrial inheritance? When the mother is affected, this is what I want to see in every pedigree. Mom affected, what will you look for? How many kids will be affected? If mom is affected, you will have 100% kids affected, right? If dad affected, 0% kids affected. For every pedigree from now onwards, look for that. If it is not mitochondrial, go for my flowcharts. If it's mitochondrial, sorted already. I know the answer already. If it's not mitochondrial, I have two flowcharts, one for AR, autosomal recessive, one for autosomal dominant and recessive, not AR, recessive and dominant. Fine, perfect, done, great. It'll be great even now also, Anirudh. Fine. Now let's go for the pedigree. So let's say if you've seen a pedigree, you must have solved pedigrees for sure, right? You must have drawn, you must have solved pedigrees. In every pedigree, whatever you have solved, what you must have noticed is, you must have noticed in the corner 1, 2, 3 or A, B and C, right? That's my generation. First generation, second generation, third generation. Any pedigree given, ask yourselves whether all the generations are affected, which means at least one every generation. For example, you and your cousin is a generation. If one of them is affected, that's enough. Sure, Gadam, I'll tell that as well. Fine. If one of them are affected, that means this generation is affected. If the answer to the question is no, all generations are not affected, I'm dealing with the recessive inheritance. Only two types of recessive. If only men are involved, X-linked recessive. If both the genders are involved, autosomal recessive. As simple as that. You cannot make mistakes here. Fine. As simple as that, right? If only one is involved, both men and women involved, you can easily make a difference here, right? That's it. Autosomal and X-linked. Now let's go to the second one. Second one might be a little bit difficult. I'll tell Anirudh for sure. Second one now. Same question starts with all generations affected or not. The answer is yes. I'm dealing with a dominant disorder. So the moment I'm dealing with the dominant disorder, the next question I ask is there a dad to son transmission? Imagining I'm a dad, can I transmit the disease to the son? If it is an X-linked dominant disorder, I'm talking about dominant, right? I have X chromosome and Y chromosome. If you have to give birth to a son, I should give Y chromosome, right? In my sperm. If I give X chromosome, the zygote will become a girl baby because mom has only X chromosome. So the sperm decides whether the zygote is a male or a female. So there's no way a dad can give my X chromosome to my son. I have to give Y chromosome to form a son. So it is never possible. Dad can never transmit the disease to the offspring. If it's an X-linked dominant, son. If it's there, autosomal. But here it's not confirmed. I have the second question. That's why I said there are two questions here. Same. I'm a dad with a faulty X chromosome. I'm giving that X chromosome to the zygote. I have only one X. That is also gone. Every zygote which I form after giving X chromosome will be a female because mom gives X chromosome. Which means every zygote which I form will always have a faulty X because I have only one X and that's faulty. So all the daughters, 100% of daughters of the dad will be affected. Then it's X-linked dominant. Yeah, I'll repeat once again. All generation affected, dominant, dad to son, no, X-linked, yes, think of autosomal. If it's X-linked, next ask one more question. All the daughters affected of the dad, yes, X-linked, no, goes back to autosomal. Clear? I'll definitely go with the symbols. Now let's try to apply these. Just two flow charts. You will be a boss of pedigree. These are not my rules. These are Gregor Mendel's rules, the father of genetics. He cannot go wrong, right? Okay. Fastest finger first. All generation affected or not? All generation affected or not? No, the first generation is not affected, right? Not affected, right? No. If it's no, I think of a recessive disorder. If it's recessive, only men, both men and women. Both men and women, right? It's both the genders, So it is autosomal recessive. As simple as that. You will not make a mistake. All generation not affected, it's recessive. If it's recessive, here both men and women are involved, it is autosomal recessive. Fine. Let's go to the next guy. All generation affected or not? No. Obviously, I think of recessive. Only men, both men and women. Only men. Has to be X-linked recessive. You will never make a mistake if you follow the rules properly. Got it? Simple. Fine, let's go to one more pedigree. We'll make it easy for you. All generation affected or not? No. So then I think of recessive. Only men, both men and women. Both. So I think of autosomal recessive. Right? Clear? Easy? Will you be able to solve a pedigree? Absolutely yes. If you're confident, I have to do something to break your confidence, right? Just for joking. Please don't skip rules. Because if you skip rules, you will make mistakes like this. There's an error. Because what's the first rule? What's the first rule? First rule is always first. First rule is rule out mitochondrial. Please don't make the mistake. Mom affected, all kids affected. Mom affected, all kids affected. Dad affected, none affected. What's the inheritance? It's mitochondrial. Don't skip rules. This is not a traffic signal. This is your life, right? Do not skip rules. The first rule is always mitochondrial. Purposefully, I dragged you to a mistake so that you will never make the mistake in the exam. The goal is exam. This is not the exam. First, mitochondrial. Because mitochondrial is non-Mendelian. That's why I said that it will not follow Mendel's rule. These are Mendel's rule, right? It will not follow Mendel's rule. That's why it's a difference. So first mitochondrial, rest everything will automatically sit in place, right? Okay, clear? Please don't forget this. Mitochondria is the first one. My rules are very clear. These are the rules. Mom, dad. That's first mitochondrial, then recessive, then dominant. Last, if the examiner is nuts, they may ask about Y-linked. Only men affected, and then every man in the family affected. There's mitochondrial. Say there's Y-linked. Unlikely to have because Y-linked, you know what's the disease? Growth of hair in the ear. You must have seen grandfathers having big hairs, right? If your grandfather has, your father will have. If your father has, you will have. Shave. Don't go to doctor. Baldness, mitochondrial. Sorry, Y-linked. Azoospermia, Y-linked. There's no family for a pedigree, right? Let's ignore that. But we'll make sure we'll be able to answer the rest as well. Fine, perfect. Pedigree last day before going to the exam, along with the hall ticket. Take a printout of these two flowcharts. Keep it. See, throw it outside the exam hall. Go inside. If it comes, you get 1 mark. Happy. That's it. Fine. Now let's go to the symbols. Since symbols were asked, try to cover the symbols as well. I'm not going to go with the basic symbols. Male, female, you know. Mating, marriage, you know. Offsprings, you know, right? So if something is double line, what is that? If something is completely black, what is that? If something is a dot or a half black, what is that? If something is very tiny dot, what is that? Just for comparison, this is a normal size. If something is diamond, what is that? If something is like this, what is that? These are different symbols, right? Right? Perfect. We'll look at all of them. This is consanguineous marriage. Sanguineous is blood. Sanguine. You must have heard about some drink, right? Red color drink. Sanguineous is blood. Consanguineous is blood related. Okay, consanguineous. This is the affected individual who is having the disease. This is carrier state or trait, right? Happens only in recessive disorder. That's why most of the time you don't see that in a pedigree, right? If I put dot or half shade, I'm telling you exactly it's a recessive disease. There's no fun in diagnosing that, right? If it's a tiny dot, it's a stillbirth or an abortion. Stillbirth or an abortion is a tiny dot. If it's a diamond, right? You skip diamond. Diamond is an unknown gender, right? This is unknown gender. Please listen, it's not hermaphrodite. It is not an intersex. It's an unknown gender, which means as per the Indian law, I cannot tell the gender of the baby before birth. So you shouldn't even put a pedigree properly. Because if you put a pedigree, you're conveying it's a male or a female, right? So till the baby is born, it's always diamond. After the baby is born, it changes. Or even a hermaphrodite will have an unknown gender only, fine? Okay. If there is no line, but there's just a bifurcation, it's a dizygotic twins. Okay. It's a line in between joining to them. It is monozygotic. It's not conjoined twins. It's monozygotic twins. They are connected genetically. They are identical twins connected genetically, not a not an conjoined twins. Do remember that, right? And last but not least, which came in the last exam was your adoption, right? Adoption is a very old question which came before. Okay. If something has a brackets, it's an adopted kid. Fine, that's an adopted kid. So these are few basic terminology which you have to know. If you want one more, if there are two lines drawn, this is an infertile family. They will not be able to give, this couple will not be able to give naturally babies, right? That's an infertility. That's how two lines at end of the pedigree chart. Fine, perfect. So these are few symbols. We know how to solve a pedigree. We know how to solve symbols as well, right? Second problem in genetics is, which I feel is a concern, is they ask a random question, random syndrome, and say, tell me what's the type of inheritance, dominant or recessive. These days, luckily, those questions are not coming. Previously, it used to come and we used to go gaga behind it. We used to go and memorize and have useless mnemonics, right? There's a mnemonic called as A, B, C, D, E, F, G, H. It's alphabets, not a mnemonic. We cannot read like that. We go with rules. If rules are there to learn the rules and remember the exceptions. Don't remember everything. The rule for a dominant disorder is only this. Every cancer syndrome you know on earth is a dominant disorder. There are exceptions you'll remember. Every structural protein error like collagen, fibrillin, spectrin, structural protein error, dominant disorder. Presence later in life, adolescents or adults, dominant disorder. Can anyone name few cancer syndromes? Can you name any few cancer syndromes which comes to your mind? You will be able to, right? Familial adenomatous polyposis, dominant. Leaf-Romney syndrome, dominant. Congenital retinoblastoma, dominant. BRCA, dominant. Neurofibromatosis, von Hippel-Lindau, dominant. And last but not least, if you have criteria for diagnosis. Neurofibromatosis criteria, Marfan's criteria, Ghent criteria, dominant. It has to be dominant. I'm not telling autosomal or X-linked, it's dominant. X-linked is chota. Bigger is autosomal dominant, right? Polycystic kidney disease. This is a table from Robbins. It will fit into these criteria. Polycystic kidney presents 40-50 years, later life presentation. Cancer syndrome, spectrin mutation, anchoring mutation, structural error, von Willebrand, later in life, present during puberty. Later in life, it's not at birth, right? Marfan, fibrillin, structural, egg-Leiden loss, collagen, structural, osteogenesis, collagen, structural. That's all. Structural protein, cancer syndromes, and later in life presentation, criteria for diagnosis has to be dominant. Rules are rules. Again, Mendel's rules, not my rules. Read the rules, right? Same for us. So, early in life presentation, congenital, during infancy, during childhood, recessive. Because recessive means there are two allele mutated. No normal allele will have to present at birth, right? Inborn errors of metabolism, enzymatic errors, recessive. Carrier state is there, recessive. Again, X-linked or autosomal, no. These are recessive, right? Let's look at the table from Robbins. Cystic fibrosis, presents at birth, meconium-ileus, recessive. Enzyme, early in life, enzyme, trait, enzyme. That's it. The rules are there for us to remember. So remember these rules, 3 or 4 for dominant, 3 or 4 for recessive. If something is not fitting into this rule, memorize that. Rest everything is enough for me. It's more than enough. Go with less memory. Go with more logic. Logic any day supersedes memory, especially in an exam. Fine. Okay. Then last but not least, we'll have a look for few investigation of choice. Sometimes they'll give you a random history and say, tell me what's an investigation, genetic investigation of choice. If I have a chromosomal disorder like aneuploidy or a translocation, aneuploidy ka matlab, okay, great Gautam. Aneuploidy is trisomy is aneuploidy, monosomy is aneuploidy, right? It is aneuploidy. Any aneuploidy, any translocation, how do I diagnose? There are one important questions for this. Do I know the translocation or it is an unknown translocation? Do I know the aneuploidy or it is an unknown aneuploidy? I'll tell you this. What do you mean by known? Let's say you suspect a patient with CML, chronic myeloid leukemia, right? Can anyone tell me what will be the translocation? Simple. Translocation 922. I need to look only at that. I don't want to look at every other chromosome. Specific. Ewing sarcoma 1122. Burkitt's lymphoma 814. I know what to look for. If I know what to look for, my answer should be fish. Much better than karyotyping. Because fish is extremely specific. It's specific. Right? Karyotyping sensitive. But let's say one of the important cause of abortion in the first trimester is chromosomal abnormalities. You will accept that, right? Let's say you have an abortus. I don't know which chromosome has a problem. I cannot specify it. That place, I don't know what it is, but I know it's genetic, like an abortion. I know a kid who came to the OPD looking like a genetic disorder, but I'm not able to say which chromosome is involved. Unknown. In that condition, karyotyping is better or superior than fish. I have only two things for both aneuploidy and translocation, fish and karyotyping. Known fish, unknown karyotyping. This basis has been asked multiple times. They give a history of Ewing sarcoma. They also give translocation, tell you what it is. CML, translocation, what diagnosis? Very specific fish, then karyotyping. Other way around, vice versa. Fine. If you have chromosomal or an exon deletion, one disease you should never forget for this is DMD, Duchenne muscular dystrophy, and the test name is MLPA. Just memorize the name, nothing is required for now. Once you finish your FMG, get back to me, I'll tell you how to do an MLPA. For now, deletion duplication, I do this. Point mutation, sickle cell anemia is a point mutation, right? Investigation of choice, PCR and its variants. I can do real time, I can do RT-PCR, anything PCR. Point mutation, gold standard has to be your sequencing. The sequencing name is Sanger sequencing. Sanger is the first person who sequenced your insulin gene, right? Frederick Sanger. Sanger sequencing is the gold standard for any point mutation, right? Quantitative, if I have to measure something, how many BCR-ABL is present in CML? How many? Measurement. How many HIV virus is present in the blood? How many hepatitis virus is present in the blood? For that, it's always qPCR. qPCR stands for real-time PCR. That's quantitative PCR for Q. RT-PCR is not real-time PCR. Please remember, there's a common mistake done. RT is reverse transcriptase PCR. Reverse transcription का मतलब it will push RNA to DNA. So where can I use it? I can use it for every RNA virus. HIV, I'll use RT-PCR. COVID, I will use RT-PCR. Hepatitis, not required. Hepatitis B is a DNA virus, not required. Right? Whenever it's an RNA product, protein product, I'll have to reverse transcriptase, I use that. qPCR is real-time PCR, fine. So these are few investigations. So what we saw in genetics was just 3 tiny topics. We went through the pedigree, we went through the rules of pedigree, we saw the symbols of pedigree, we had logical ways to remember and extrapolate the genetic disorders, dominant or recessive, and also we read about the investigation of choices, fine. Okay, that's about this. Now, let's quickly go through amyloid. Amyloid is an important topic. It might come in an exam for sure because amyloid keeps coming. Alternative exams, either one of the exams in a year, it might come. Not primarily from pathology. I can ask you a history of Alzheimer's from medicine and link it to amyloid. Something or other way, amyloid might come, right? Amyloid is a non-branching beta pleated sheets. Is important. It's 7.5 nanometer in size. Very, 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 very tiny, right? Very tiny nanometer. So 75. It's okay. It's nanometer. And there are different types of amyloid, right? AL is the most common amyloid light chain seen in myeloma, which is a problem of plasma cells. Everything is written here, right? I want you guys to comment where do you see each of them. AA is chronic inflammation induced amyloidosis. Any condition with chronic inflammation, I'll see them. Rheumatoid arthritis, tuberculosis, bronchiectasis, any chronic inflammation, you'll see them. Where do you see A beta to M? A beta to M is seen in beta 2 microglobin in renal, in chronic hemodialysis induced amyloidosis. Okay, in chronic hemodialysis induced amyloidosis, you will see them. Fine. ATTR, you see them in senile systemic amyloidosis. That's one. And also I have a congenital condition called familial amyloidotic polyneuropathy. It's a familial condition where you'll see them. Fine. ACAL, it's CAL actually, not CA. ACAL is calcitonin. You see them in localized in medullary carcinoma thyroid. Okay. Next is A beta, not B. Where do you see A beta amyloid? Seen also in localized the brain in your Alzheimer's disease. It's actually A beta 42, if the number makes sense. If not, just A beta also good enough for us, right? AIAPP. IAPP is islet amyloid polypeptide. It's islet. Islet means it's going to be seen in pancreas. It's pancreas specific and it's seen in type 2 diabetes and also in insulinoma. You might make a mistake here. I'll tell you why. Because type 1 diabetes, no, diagnosing that gives us euphoria. So whenever you see type 1 MCQ, I like go tick it. Not always. In type 2, I'll have more insulin production. More insulin production, I'll have more protein deposit. Type 1 is no insulin, insulin dependent, right? No insulin. So you'll not even have amyloid. Fine. Type 2 and insulinoma, I'll have that, right? Perfect. The most common organ involved is renal, kidney. What's the most common cause of death in amyloid? You know that. It's cardiac amyloidosis. In gross, every organ increases in size. But there's one organ which has two named findings. That is spleen. Spleen has something called an lardaceous spleen. One more name of spleen is sago. Sago is millet seeds, like the sabudana, right? Sago spleen. Tapioca, right? Sago. This will be involved in red pulp of the spleen. When red pulp is involved, when the white pulp of the spleen is involved, I'll have sago-like appearance, like a sabudana, tiny, tiny, tiny dots. Fine. Okay. The best is abdomen fat pad biopsy because it's easy to do, easy to repeat. Even if I fail, I'll do it again. No problem at all. The moment you do an abdomen fat pad biopsy, where do I look at? Always, always, always perivascular. The first place getting deposit is perivascular deposit. In normal light microscopy, we already saw pink in color. After congruent, in light microscopy, we saw this is the color. That's your salmon pink color. Okay. In polarized light, we have the color. We know the apple green birefringence color. Fine. After congruent, the microscope changes the color. Either a salmon pink in the second image. The first image is normal light microscopy. It's a normal pink color. Salmon is a flesh color, orangish pink color. That's what is salmon pink. And the other one is apple green birefringence. Fine. Polarized light is used in other places also in pathology. Can anyone tell me the other use cases? One obviously is amyloid. Where else I can use polarized light? You can use in gouty arthritis. You'll have needle-shaped crystals and it will be negatively birefringent. Okay, that's where I use it. And also in one lung disorder, which is silicosis. You'll have positively birefringent silica particles in the lung. Okay, that's what you'll have there. Fine. Okay. Great. So that's about amyloid. Amyloid can definitely come in an exam. Please do look out for it. Fine. Done. Okay. You guys want a 5-10 minute break? If yes, we can take a 5-10 minute break. Yes, or we'll continue. 5-10 minutes. Go just relax. Come back. We'll start by 12:40. Is that fine? I think it's 12:26 now. We'll start by 12:40. We'll come back. Is it okay? You don't want a break? I'll be happy if you say you don't want a break. Ah, you don't want a break. Great. Let's continue. Step by step. Okay. I'm okay with anything. We'll go. I'll come back with 12:40. I'm not leaving anywhere. I'm just hiding my image there. That's all. I'll come back with 12:40. I'll start sharp by 12:40. Water, empty your bladder. Come back soon. Bye bye. Hey guys, am I audible? Am I visible? Welcome back. Yes, I really want a break. Throat was getting dry. Ready, Krishna Kant? Others ready? Let's start. So we had completed a little bit of quick revision of general pathology
Hey guys,
topics.
am I audible? Am I visible?
We saw about inflammation, cell injury, adaptation, and also a little bit about genetics. And one thing in immunology about amyloidosis, right? Now we'll be going to start with cancers, neoplasia. There are few areas where the topics or the questions keeps on repeating. Those are specifically the genes, the places where it has been involved, and how to diagnose them. That's one important thing. Hi, Anamita. That's we'll see. And also we'll have a quick look about the clinical features, the paraneoplastic syndromes, how to diagnose them, how to nail them. So these are two places which will be primary focusing with respect to neoplasia. Because as you know that neoplasia is a very, very vast topic. The same pathogenesis, the same genetics will also kind of relook when you come to hematology part of WBC disorders as well, right? So let's go with that. Few things to go before neoplasia. So neoplasia, the pathogens can be divided into molecular hallmarks like proto-oncogene, tumor suppressor gene, evasion of immune response, and multiple things, right? In that, the first table, what you're going to see here, everything is about something called proto-oncogenes. The first thing to remember, proto-oncogene is something normal. Any gene which helps in normal cell division, we can call it a proto-oncogene. Can you name any one growth factor which comes to your mind? Can anyone tell me what's a growth factor for RBCs? A simple one. Growth factor for RBCs? You know that it's your erythropoietin, right? So erythropoietin ka gene is definitely a proto-oncogene, or the receptor of erythropoietin is definitely a proto-oncogene. That is normal. When this proto-oncogene is mutated, the mutated proto-oncogene is what we call it as an oncogene. And almost always this mutation is gain of function mutation, has to be remembered. Every proto-oncogene mutation is gain of function mutation by default. Normal function to divide. When I have to have cancer, definitely more function. That's gain of function. Every proto-oncogene mutation or every oncogene is nothing but a gain of function mutation of a proto-oncogene. Never ever forget. So these are few proto-oncogenes which I want you to remember because each and every one of them has been asked in one of the other exams. Now multiple more in Robbins. Let's ignore that. We'll read whatever has been asked before. Not miss this at least, right? In EGF receptor family, I have two things. One is ERB-B1. The other name for this is EGFR, EGF receptor, right? Epidermal growth factor receptor. The second is ERB-B2. This ERB-B2 term was asked once in exam. I keep on saying that they will ask it sometime because the other name everyone knows. HER2/neu. Where is HER2/neu elevated or mutated? Amplified in case of breast cancer, right? So since everyone knows HER2/neu, the only way to make it difficult is change the name. ERB-B2 is the other name for HER2/neu, right? So here, this is your mutation seen in lung adenocarcinoma. Never forget. And this is one of the most common mutations seen in Asians. In lung adenocarcinoma among Asians, it's the most common one, right? Okay. ERB-B2 or HER2/neu, as you know, it is seen in breast cancer. Why this is important? I'm sure you know by this time that no breast cancer will be treated without knowing ERP or HER2 status. Very important. And I have a targeted therapy called as trastuzumab. You know that for sure, right? So it's theoretically useful for diagnosis as well as for patient management. So a doctor should know it. So definitely there's a possibility it can come in MCQ. All these words written there are useful real life. That's the only reason we are reading them, right? ALK receptor, right? ALK receptor is seen in a lymphoma called as ALCL, anaplastic large cell lymphoma. The ALK is also called as anaplastic large cell kinase, right? As anaplastic lymphoma kinase. Okay, and it's also seen in case of one lung adenocarcinoma. KRAS is the most common proto-oncogene mutated. Throughout the body, if you take all the cancers, the most common gene mutated is KRAS. And KRAS mutation, it's in multiple tumors, but don't forget these three tumors. It's must to diagnose pancreatic carcinoma, adenocarcinoma. It's must to diagnose in lung adenocarcinoma, It's must for diagnosing colonic adenocarcinomas. All the adeno-CA without KRAS, we don't start the management. We have to do a KRAS till it's positive or negative, only then start the management. And unfortunate thing is, if KRAS is positive mutated, it most of the time signifies poor prognosis. Not a good mutation to have. And look at that, that's the most common. The most common mutation is bad. It's difficult, right? These three cancers, never forget. Without doing these three, we'll never start the treatment. Very, very important for us, right? ABL, I'm sure you know ABL as a part of BCR, right? BCR ABL, in that ABL is the oncogene. Okay, this is seen in chronic myeloid leukemia, and I'm sure you know the treatment also. It is imatinib. Right, imatinib is the treatment, which is tyrosine kinase inhibitor. JAK2, anyone, which tumor? The most commonly it is seen in polycythemia vera, but it can also be seen in any case of chronic myeloproliferative disorder, like your essential thrombocythemia, myelofibrosis, right? It can be seen in any chronic myeloproliferative disorder, but the most common occurrence comes in your polycythemia rubra vera or polycythemia vera. Fine. c-Kit. Any disease you know in c-Kit? I'll give you a clue. c-Kit is a tumor which happens in the GIT. That tumor arises from a cell which is also called as pacemakers of intestine. c-Kit is seen in great. It's seen in quite a few tumors. Something not to forget, just gastrointestinal tumor, we see them. Let us see them in mastocytosis. Again, something you should not forget, right? So a few tumors where c-Kit is very prominent. They can be seen in seminoma, dysgerminoma as well. Okay, it's commonly seen in these three conditions, which an undergraduate should know. Fine, perfect, great guys, amazing, done. So these are all very commonly used proto-oncogenes, which has been repeatedly asked in exams. Next class is Jesse sir's class, right? Dermatology. In dermatology, not only in dermatology, it can be seen in quite a few conditions as well. There is a marker called a gene called as BRAF. It will be generally written BRAF V600E. Can anyone tell me in which all tumor do you know where BRAF is involved? Anything which comes to your mind? BRAF. BRAF is involved in? Perfect. You can see them in melanoma. You can see them in one more condition called as an hairy cell leukemia. Fine. 1 second, guys. Okay. It can also be seen in Langerhans cell histiocytosis. In all these places, I'll be able to see BRAF mutations, right? Something which is very common, and BRAF has a targeted therapy which is called as vemurafenib, or the newer one is darafinib. Darafinib is a drug which is useful for BRAF mutated cancers. It's very, very efficient. Like imatinib, it's a very, very efficient drug, right? Perfect, right? So these are the commonly used proto-oncogenes, like you guys already know, right? So proto-oncogenes, everything is gain of function. Every normal proto-oncogene functions to help in cell division. So it's either a growth factor or a growth factor's receptor or a transcription pathway. Fine, perfect. Now let's go to the next group of genes, which are your tumor suppressor genes. Tumor suppressor genes is also very, very important for us, right? Tumor suppressor genes, as the name says, normal functions to suppress tumor formation. If the normal function is to suppress tumor formation, when do you think you'll have tumor? Gain of function or loss of function? Normal job is to say tumor don't come. It's gone, tumor will come, right? Almost every tumor suppressor gene will have loss of function mutation only, or the entire gene will get deleted. Deleted gene, obviously no function. That's first. So remember, I have in every gene 2 allele. If one allele function is lost, will this still function? Normally 2, 1 is gone. This will still function. So this will still prevent tumor. In other words, for me to have cancer, I need to have one allele mutation or both the allele mutation. Both the alleles are must, right? So it's loss of function, and for us to have cancer, there should be an biallelic loss. Very, very, very important. Okay, I need a biallelic loss. This was given by the hypothesis by Knutson's 2-hit hypothesis. Very, very important. Do remember that, right? This is true for every tumor suppressor gene, though it was discovered in retinoblastoma. Clear? And there are lots of tumors here, right? Lots of genes. There might be a question saying that, tell me it's tumor suppressor gene or proto-oncogene. How do you remember? Again, memory has to be least involved in learning. Simple, na? Congenital retinoblastoma syndrome, Lee-Romney syndrome, congenital gastric carcinoma syndrome, von Hippel-Lindau syndrome, familial adenomatous polyposis, Peutz-Jeghers syndrome. What is common? Everything can be inherited. So if a gene has inherited cancer syndromes, mostly, not always, mostly there'll be tumor suppressor gene. Again, rules. Rules help me to save memory. There are exceptions. I'll come to the exception very, very soon because exceptions make us do mistakes. If there's a cancer syndrome, the gene is tumor suppressor gene. You don't memorize it's tumor suppressor gene. It has to be tumor suppressor gene because normal proto-oncogenes rarely cause cancer syndromes. Fine. Now let's go to retinoblastoma. Retinoblastoma, like Gautam said, it's also called as a governor of cell proliferation or cell cycle, right? Whatever it is. Okay. Retinoblastoma normally acts in the G1S gate. That's where it acts. In the G1S phase is where it acts normally. When it's a loss of function, I'll have retinoblastoma. If it's congenital, see, there are lots of cancer syndromes, right? So many. I can create any number of MCQs. I'll give you that 10-year-old person, 20-year-old person had this cancer, this cancer, this cancer. What do you suspect? So I need to know all these. Okay. Should be normal, should be fine. Okay. Perfect, guys. So what I was saying is, whenever I see this combination, I have to think of that cancer. Fine. Okay. Retinoblastoma plus osteosarcoma, I think of congenital retinoblastoma syndrome. Like that, we are going to see for every cancer here. What combination will help me to think of Peutz-Jeghers? What combination will help me to think of von Hippel-Lindau? These combinations help me in a scenario-based question, right? Perfect. P53, like someone said, is the guardian angel of a genome. Okay, P53 is there in normal chromosome 17p13. The chromosome 17p is important here because in multiple lymphoma leukemias that becomes a prognostic significance, right? So do remember that it's a guardian angel. It can stop in any cell cycle. It's like your mother, right? P53, if it's mutated, the congenital syndrome is called Lee-Romney syndrome. When will you suspect Lee-Romney syndrome? If you see a combination of breast cancer, leukemia, CNS, sarcoma. This combination, any sarcoma, could be an angiosarcoma, could be an osteosarcoma, any sarcoma, breast, leukemia, and CNS, this combination, suspect Lee-Romney syndrome. And Lee-Romney syndrome has definitely a poor prognosis. P53 in general, any cancer, if it's lost, it has a poor prognosis. And overall, if you see what's the most common mutation is P53. In every cancer, the most common is P53. RAS is the most common oncogene mutation. It's not overall the most common. The most common oncogene is RAS. The overall most common is P53 mutation. Great, Gaurisha. Fine. Okay. CDH1. CDH1 actually codes for a protein called as E-cadherin. Okay. It codes for a protein called an E-cadherin. You know that E-cadherin is a cell cycle adhesion molecule, right? A desmosome, hemidesmosome. Once it's lost, it'll get a spread. E-cadherin mutation has very good characteristic features. One, it's seen in few tumors. When you see this combination, lobular CA of breast, not ductal carcinoma. It should be lobular carcinoma of breast. And not any gastric cancer, diffuse gastric cancer. A diffuse gastric cancer and a lobular carcinoma of breast, by default, think of a CDH1 mutation. And the most important thing is cells are spread. No cell-to-cell addition. So what do you guys think? The tumor also will spread early or spread later? Spreads very early. Because of this only, these both can go to ovary. We call them Krukenberg. Right? Everything in pathology will be related. Krukenberg's tumor, the ovary, because they already spread. They are already separate, they already spread, and they already go early, right? Early metastasis is a classical finding of lobular carcinoma, classical finding of diffuse carcinoma of breast. Sorry, diffuse gastric carcinoma, right? Von Hippel-Lindau, seen in chromosome 3, right? You will think of an von Hippel-Lindau syndrome if we have this combination. Clear cell RCC, not any RCC. There are multiple types of RCC. In that, clear cell RCC is more related to von Hippel-Lindau with your pheochromocytoma, with your hemangiomas, especially in the brain. Cerebellar hemangiomas. Think of an von Hippel-Lindau. Retinal angiomas. Think of an von Hippel-Lindau. Fine. Hemangioblastomas to be very specific, right? Okay. The most important thing is all of these syndromes associated with von Hippel-Lindau can have a paraneoplastic syndrome, which is polycythemia. Because von Hippel-Lindau gene, it is involved something related to hypoxia. Because of that, I end up in having a polycythemia. Clay cell can have polycythemia. Phaeochromocytoma, cerebellar hemangiomastoma can have polycythemia, and PNS is for paraneoplastic syndrome. Fine. Next, APC. APC is chromosome 5. APC beta catenin, right? So you see them in familial adenomatous polyposis. How do you identify familial adenomatous polyposis? I should have minimum of 100 polyps in the colon. Minimum 100 polyps, I call it familial adenomatous polyposis. In your surgery, you must have definitely read this. Sandeep sir must have definitely told this. There are multiple subtypes of FAP, right? One of the subtype is, okay, Gardner. The other subtype is Turcot. Okay, Gardner syndrome, Turcot syndrome. Gardner also will have polyposis. Minimum 100 polyps will be there. In addition to that, I used to generally remember like gardening person get pricked in your hands and fingers. Might have related tumors to skin and bone, osteomas, right? Gardner, osteomas, skin tumors along with colonic tumors, Gardner syndrome here. Turcot, right? Turcot is forming like turban, CNS tumors, right? Medulloblastomas, gliomas, along with colonic polyps, I think of Turcot and Gardner. These are variations of FAP, fine? Only your colonic tumors, no other variation, just simple normal FAP, fine? Okay. STK11, the other name is LKB1, the gene's name, fine? So STK11 is seen in a condition called as Peutz-Jeghers syndrome. See, this came in an exam last time. Quite a few of your seniors made a mistake because they only read the previous year questions. That is not alone enough for me. Peutz-Jeghers syndrome, what all comes to your mind? Everyone will know few findings. Colonic polyps, everyone know. Something in the oral cavity. Now, what is that? You guys definitely know that. Oral hyperpigmentation. You must have seen the tiny girl cell with lots of black dots in the oral cavity, right? In the lips and the mucosa, right? So one thing which you'll never forget, most of them won't forget is, colonic polyps will be there, Peutz-Jeghers syndrome, hematomatous polyps, and also you'll see oral hyperpigmentation. These both, no one is going to forget, right? What generally they forget is, it's a syndrome. It's not restricted to the colon. Leaf Romney is throughout the body. FAPC, bone, CNS, and also colon, right? This syndrome also has increase in risk of breast cancer. What most of them missed is this increased risk of pancreatic. Okay, it will come back now. Got it. Fine. Okay. So the pancreatic cancer is the most important thing in Peutz-Jeghers syndrome. More than 50 times risk compared to a normal person, right? Okay. This frame irritating, lagging is cutting our flow. It's fine. Whatever hurdles happen, we'll still read. Okay. So do remember them. Most of your seniors missed it. Don't miss it, right? So the main purpose here is to remember all the concepts required for an exam thing. Now, I taught you about a Hello? I'm audible, right? Am I audible? I think I'm audible. Okay, perfect. So now I taught you about genetics, right? So now tell me, if you can apply that, can anyone tell me what do you think will be the inheritance of all these syndromes? What do you think will be the inheritance of all these syndromes? Vipul, can you just refresh once, Shekhar? Inheritance has to be dominant. Every cancer syndrome is a dominant inheritance. Every cancer syndrome, every structural protein mutation, every criteria for diagnosis has to be dominant inheritance. Everything here is dominant. Most of them are autosomal dominant. Need not memorize, right? So if you go with basic concepts, you will not be required to memorize at all, right? I told you all of the cancer syndromes inherited will be tumor suppressor gene. But I also told you there are few exceptions. There are few exceptions which I don't want you to forget. Exceptions which can be which can be proto-oncogene also. For example, there's a gene called as MET proto-oncogene. Okay, MET proto-oncogene causes renal papillary carcinoma syndrome, which is an inherited syndrome. RET proto-oncogene. Can anyone remember what syndrome does it cause? You must have read about MEN 2A, MEN 2B, medullary carcinoma thyroid. This also is inherited. Exception, right? These are exceptions for inherited syndromes, which can be proto-oncogene. Rest everything is tumor suppressor gene. Insulin-like growth factor is actually seen in WT2 gene, which is actually seen in your Wilms tumor. Beckwith-Wiedemann syndrome. Okay, these are the only 3 syndromes for an undergraduate I want you to remember, which can be proto-oncogene. Rest everything will be tumor suppressor gene. And these have been asked before also, do remember them, right? Every syndrome is tumor suppressor gene. Every inherited genetic syndrome is autosomal dominant, and do remember the basics. Fine, perfect. Now we know about tumor suppressor gene, we know about 2 proto-oncogenes, right? These 2 are the major genes which comes in an exam. Fine. Next, let's look at the clinical features. Of the clinical features, I am not going to say there will be mass lesion. Breast cancer will present with the mass. Every cancer will present with the mass. You know that by default. Goal is here to compile the paraneoplastic syndrome. There are 3-4 tables of Robbins, which are very high yield for pathology. With respect to Neoplasia chapter, we are going to cover everything of that, right? Tell me what comes to your mind when you think of Cushing syndrome. Which cancer comes to your mind when you think of Cushing's? Cushing is the most common endocrinopathy in paraneoplastic syndrome. This is the most common overall paraneoplastic syndrome. When you think of Cushing's, you will see in the same condition where there's a possibility of one more syndrome called as an SIADH. Both are pretty commonly seen in small cell lung cancer, small cell CA of lung, where you see both Cushing's and SIADH. Syndrome of inappropriate ADH secretion is very, very common in case of a small cell carcinoma of lung, right? I hope SCC is small cell carcinoma of lung. Squamous cell carcinoma of lung, on the other hand, will present with hypercalcemia, right? This will be seen in squamous cell carcinoma of lung, and also it will be seen in few cases of breast cancer as well. The reason for Cushing syndrome is these both tumors secrete ACTH-like substance. So it increases the corticosteroids causing Cushing's, right? And also SAADH by default secretes ADH-like substances, right? The reason for hypercalcemia is this came in exam. It secretes PTH-RP, not PTH, not parathormone. It secretes parathormone-related peptide. Both the squamous cell carcinoma, breast cancers can secrete parathormone-related peptide. Hey guys, can you see me? Am I audible? Am I visible? Sorry guys, the YouTube is glitching a lot from yesterday. I hope I'm audible and visible. Okay. We might have lots of disturbances on YouTube throughout the day. From yesterday, it's not so clean. Let's see if we'll be able to correct it. Fine. Thank you, sir. Thank you. Let's start. So we were in the paraneoplastic syndrome, right? So polycythemia vera, clear cell RCC, and cerebellar hemangioblastomas will have polycythemia vera, right? Then acanthosis nigricans. Acanthosis nigricans, the brownish discoloration in the nape of the neck. You will definitely think of your diabetes and insulin resistance as the first, right? Next, what you'll think of, if it's a cancer, any internal organ malignancy, right? Colon, GIT, right? And also your uterine malignancy. The reason for this is both of them have increased amounts of epidermal growth factor. When the epidermal growth factor is a part of the pathogenesis, by default, it will also result in the thickening of the epidermis. That causes the thickening of the skin here and the blackish discoloration, which results in acanthosis nigricans. If not cancerous, insulin resistance is the first thought, right? Trossius phenomenon is, it's a migrating thrombophlebitis. Fine. It's migrating thrombophlebitis throughout the body, multiple tiny thrombus in the veins throughout the body, right? Psoriasis phenomenon, the older MCQ or PYQ was, it is seen in pancreatic cancer. I'm not denying that. It is definitely seen in pancreatic cancer. But later on, we found that it is seen in every cancer which can secrete mucin. Colonic adenocarcinoma, ovarian adenocarcinoma, pancreatic, appendix. In other words, it is seen in mucin secreting adenocarcinoma. Very high quantity of mucin, whichever secretes, I will see Psoriasis phenomenon, because mucin is something which will directly activate factor 10. So if factor 10 is activated, by default, you can have thrombus throughout the body. Any mucin secreting, if the same older PYQ comes, yes, pancreas is something which I'm going to look for first. But every mucin secreting adenocarcinoma can have this, right? Red cell aplasia, as well as one more guy, myasthenia gravis. Can anyone tell me which tumors do we have red cell aplasia and myasthenia gravis? We'll have that in thymoma. Right? In case of thymoma, we'll have both red cell aplasia and myasthenia gravis. Both of them are immunological phenomenon. Okay? Both of them are immunological phenomenon, where thymoma has a most important role to be playing immune system, right? So when there's a thymoma, I'll have altered immune response, which destroys my own RBCs, which destroys my own acetylcholine receptors. Fine? Great. So we know few of the classically known paraneoplastic syndrome, which can come as a part of a question, right? Last but not least, how do I diagnose with tumor markers? Tumor markers, as a theory, it can come just as like CA125 seen where. Last time in a NEET PG exam, the same tumor markers was integrated in one more question. 40-year-old person having an ovarian mass, CA125 is 1000. Adenoma or adenocarcinoma. Any tumor marker going thousands is definitely an malignancy, not a benign. That's the first thing. Tumor marker is not an substance which is used alone for diagnosis. I'll combine with radiology, I'll combine with clinical symptom, then yes, I can diagnose. With one tumor marker alone, I can't diagnose. But there are exceptions. Like I said, alpha fetoprotein, 1500, 2000, most likely cancer. Though I said most likely, though the confidence of calling it cancer is a bit less, whereas crossing 1000, undoubtedly malignancy, take a biopsy, prove it malignancy, because it's not a proof, it's definitely a way or a direction, right? So tell me, there are lists of tumor markers, everything in Robbins, you're going to tell me where do you see them? Where do you see HCG? HCG is pretty simple, right? Okay, HCG is pretty simple. Human chorionic gonadotrophin. You see HCG in your choriocarcinoma. If it's non-carcinomatous, I'll think of a molar pregnancy. A high dentiform mole, partial molar pregnancy, also you see HCG, right? Perfect, nice. Where do you see calcitonin? Calcitonin, we just now read in amyloid as well. Calcitonin is classically seen in case of an elevated case of an medullary carcinoma thyroid. You see calcitonin in excess. Catecholamine and its metabolites. Where do you think catecholamine comes from? Catecholamine comes from ganglia, right? Sympathetic parasympathetic ganglia, catecholamine comes. One of the biggest sympathetic parasympathetic ganglia in our body is adrenal medulla, right? So any tumor coming from adrenal medulla, like your pheochromocytoma, will have excess catecholamines, right? Neuroblastoma will have excess catecholamines. So these are tumors coming from the ganglia which will have, right? Perfect. Okay, right? Among ectopic hormones, we'll ignore this for now. Alpha fetoprotein, there's a heading and the subheadings are these. Fine. Alpha fetoprotein, we see them in hepatocellular carcinoma. I'll write one important thing here. Please look at this. Hepatoma is the older term for hepatocellular carcinoma. It's not benign hepatic tumor. It was a confusing terminology. That's why we removed the term hepatoma from books. But even if an old question repeats, hepatoma is equivalent to hepatocellular carcinoma. Please don't forget that. Hepatic adenoma is benign. Hepatoma and HCC is same. Fine. And also we see alpha fetoprotein in non-seminomatous germ cell tumor. Your yolk sac tumor, you see elevated alpha fetoprotein. Fine. Perfect. Carcinoembryonic antigen. This is a product of mucin. So this also is same like your Trosia syndrome. Any mucin secreting tumor, I can have it. That's why it's a bit non-specific. Cervical adenocarcinoma also can secrete mucin, right? Salivary adenocarcinoma also can secrete mucin. Lung can, colon can, ovary can. Any mucin secreting adenocarcinoma, CA will be elevated because it's a byproduct of mucin. But like Dr. Nice said, it's more commonly learnt in your colonic adenocarcinoma. Though not specific, any mucin secreting tumors can have it. Fine. PSA, need not write about that. Prostate, in your surgery you will read about lots and lots of variations of PSA, might be important, right? All these CA markers, fine. Okay, CA 125. The most important thing here is the first word, epithelial ovarian tumors. I don't see them in every tumor. I see them only in epithelial tumors of ovary. Will it be elevated in dysgerminoma? No. Mucin secreting adenocarcinoma, serous adenocarcinoma? Yes. Not just ovary, only epithelial tumors of ovary. Please do remember that it will be elevated in your serous adenocarcinoma, mucinous adenocarcinoma, clear cell carcinoma, yes, but not in dysgerminoma, teratoma, no. Not in germ cell tumors, not in sex chromosomal tumors, only epithelial tumors of ovary, right? And this is a mnemonic from your Instagram influencer of med school, bro. Something which sticks in the head will not go away, right? 9 looks like a pancreas, seen in pancreatic carcinoma. I see this in, I tell this in every class. Thanks to him, right? 3 for him looks like breast parenchyma. So I used to say seen in breast cancer. Not great, but helps to remember us for a longer time. Good for us, right? 9 looks like a pancreatic adenocarcinoma. 3 looks like a breast parenchyma. So breast cancer. These have been asked. Quite a few of the questions here has been asked one or the other time. Very, very important high yield. There are 4 tables which are must in Neoplasia to read in the last minute, right? The first, a talk about proto-oncogenes. The second, a talk about tumor suppressor genes. Combination of the things what we have seen, exceptions of the tumor suppressor genes, paraneoplastic syndrome, and your tumor markers. Because going forward, the questions of cancer will not be isolated only to cancer. It will be a clinico-pathological correlation only, related to surgery or medicine or pediatrics or gynecology, where these are the topics which help me. I'll have a history, one gene, what cancer. Or I'll have a history only asking to tell what gene it is. Or a paraneoplastic syndrome diagnosis, marker diagnosis, right? So it will help you fair enough to solve quite a few questions which comes in Neoplasia. Fine, perfect. So at last, with lots of difficulties, we have completed one topic, which is general pathology. Fine. Now let's go to hemat. So in hemat, I'm going to go with image based. We'll look at the image. We'll try to first understand what is there in the image, then read topics relevant to the image, whatever is relevant and relevant to the topic also. The goal is diagnosis, because in hematology, especially in RBC, lots of image comes. That's the base of RBC. What we'll be doing for WBC is go with keywords. Lymphoma, RSLs, everyone know. But the keyword is what helped me to differentiate, this is this type of lymphoma, Hodgkin's or non-Hodgkin's. We will go with keywords and also with genetics and markers. Fine. Ready? Okay, let's zoom it. Let's zoom it. Before going to this, can anyone tell me what's a normal shape of an RBC? Start with the basics, na? What's a normal shape of an RBC? RBC is biconcave disc-shaped structure, right? So the biconcave disc-shaped structure, the corners of the biconcave will have the hemoglobin. The center mein, hemoglobin will not be there. That's why when you look at a microscope, a normal RBC will always have a central pale area. This is how the normal RBC looks like, right? It will always have a central pale area. The central 1/3 will always be pale in a normal RBC. This is normal, right? Let's look at this. Can I tell you this is normal? 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 Sometimes very small pale, sometimes 1/3 pale, right? I'll show you one more cell. Normal or abnormal? This cell, normal or abnormal? Are you having central pallor? This cell has a central pallor, right? This cell has it. These don't have. This, yes, not there. Yes, not there. Yes, not there. Yes, right? So when you look at this cell, this is smaller than this RBC, little bit darker and no central pallor. What is that? Tell me what is that? That's your classical spherocyte. An RBC which is smaller, which is darker, and no central pallor. Okay, a smaller, darker, no central pallor. Always think of a spherocyte. That's how a spherocyte looks in a light microscopy. That's the first way to diagnose a spherocyte. We can be as simply as an image, this is spherocyte. The next question is, whenever you or me or anyone sees a spherocyte in a light microscopy, what's the first diagnosis? Or what's the most common, right? This is how a spherocyte looks. So I can call it an spherocytic anemia. The most common cause of spherocytic anemia is autoimmune hemolytic anemia, then hereditary spherocytosis. I don't think of hereditary spherocytosis first. Please remember, never forget. If you remember this, it's much easier to answer the next question. Please remember, tell me one, then you can memorize this also. Autoimmune hemolytic anemia is genetic or acquired? What do you guys think? Autoimmunity, genetic or acquired? Acquired, है ना? Hereditary spherocytosis is there in the name. It's always genetic. Anywhere in the body, whatever subject it is, whatever system it is, which is common? Acquired disease is common or genetic disease is common? Type 2 diabetes is common or MODY is common? MODY is genetic. Acquired is any day common, right? Definitely acquired is common. So by default, autoimmune hemolytic anemia acquired is much more common than hereditary spherocytosis. Remember this always, right? Now, let's say you are a pathologist who saw the spherocytes in the microscopy first time in a patient. You want to rule out acquired, which is more common, or you want to go to the genetics, which is rare? Acquired, na? So there's a question which came. The next step in case of an spherocytic anemia, or next step when anyone sees a spherocytosis to rule out autoimmune, that is Coombs test. I have to do Coombs test to rule out autoimmune hemolytic anemia, not to diagnose hereditary spherocytosis. That's important. That's first MCQ. Next step, right? So next step, let's say it's negative. If Coombs is negative, then I can suspect HS. HS is hereditary spherocytosis. Fine. I'll suspect. If Coombs is positive, my diagnosis is sorted. Negative, I suspect HS. If I suspect HS, what I can do is, the way to confirm the investigation of choice for HS is flow cytometry. I have never included a test which is called an osmotic fragility test. It's theoretical, not practical. This is how we diagnose. Spherocytes hai, rule out Coombs, do Coombs test, rule out autoimmune hemolytic anemia, suspect HS, do a flow cytometry. Enough, that's all. If you want to be specific, there's a flow cytometry name is EMA flow cytometry. It's an eosin dye, it's an EMA flow cytometry, right? This is how we go and approach a case of spherocytic anemia. Now, let's slightly look at HS as a disease bit. HS is the most common mutation is in ankyrin, but I can have mutation in many proteins. Ankyrin, pectin also can have, band 4.1, band 3, lots of them can have, right? Ankyrin is the most common. Can I call ankyrin as a structural protein? Yes, it is. Right? It's definitely a structural protein. So as a structural protein, what will be the inheritance? Dominant recessive. Perfect. Autosomal dominant inheritance. Most common is autosomal dominant inheritance. If it's an autosomal dominant, let's go back to our basics. Presence early in life, later in life. Later in life. Presentation also I know. Presence in adult time. It's autosomal dominant. One gene is normal. Only one gene will be destroyed. So anemia will not be severe. It will be subtle. Majority of the destruction of the RBC happens in the spleen here, because spherical RBCs get stuck in the spleen. Sorry, the spherical RBCs get stuck in the spleen. That's where majority of the destruction happens. So an adult who presents with splenomegaly, okay, that's first. Second, a very mild anemia, okay, that's second. And having pigmented gallstones. Okay, that's the classical presentation of spherocytosis. Adult splenomegaly, pigmented gallstone, spherocytosis. You will not have any symptom of anemia because the anemia is generally pretty mild. You'll have a pretty mild anemia generally. That's what happens here. Fine. Done. All these are required for spherocytosis enough. Mutation, inheritance, presentation, you see spherocyte and do one flow cytometry to confirm. Treatment is simple. Treatment is, if required, remove the spleen. If required, splenectomy is a treatment because everywhere the lysis happens in the spleen, extravascular hemolysis only. Fine, done. That's about spherocyte and its discussion. Now let's go to the second image. We'll go with image base. Image is much comfortable for us to learn. Everyone online, comment what is this? What is this? Normal, abnormal? Tell that first. Definitely, Dr. Nice. Spectrin can be recessive. Spectrin can be much more severe. You're absolutely right. It's normal, right? Perfect. So what is this guy? Maybe partly this guy also. That's a bite cell. Looks like summer's bitten off, right? Great, Gautam. You think you have a bite cell by default, right? Can anyone tell me what this is? Can I call that guy spherocyte? Looks like, na? So, not only hereditary spherocytosis, G6PD also can have spherocyte. But the diagnostic point is bite cell, like what Gautam said, right? Perfect. So now we are going to talk about G6PD deficiency. It's an enzyme deficiency. So dominant or recessive? Always think of recessive when it's an enzyme. But here the inheritance is X-linked recessive. If it's X-linked recessive, one clue is men will be more commonly affected compared to women, right? G6PD problem is now it's a enzyme of the pentose phosphate pathway. So I won't have NADPH. So the major pathogens of G6PD deficiency is there'll be less recycling of glutathione peroxidase. Okay, I'll not be able to recycle glutathione peroxidase. So what happens is there excess of reactive oxygen species induced damage. That's the problem. So more reactive oxygen species is there, the damage will definitely be more. So tell me, in which condition your body, my body will have more reactive oxygen species? When I'm having fever, simple. Infection, yes, definitely. G6PD is always a trigger-induced hemolysis. If the question has a trigger, that's the most important clue of G6PD than bite cells. Right? What all can be trigger? Infection is the commonest trigger. Drugs can be common. In pharmacology, we read about primaquine-induced hemolysis. Very common. Last but not least, a type of bean called as fava bean. Not that common, but do remember. See, Dr. Nice, first we'll remember what is rare for us, right? Fava bean does cause, but infections, drugs are much more common than fava beans. Whenever this happens, what happens? You'll have intravascular and extravascular hemolysis. Both will happen in this patient. And how do I diagnose? You do a peripheral smear. You see the exact classical bite cells. I will also see spherocytes. Not looking into that primarily now, but bite cells is diagnostic. But still I have to confirm now. So I have one more stain. There's a stain. We call this an NMB stain or the new methylene blue stain. Actually, this is a stain for reticulocytes. In this new methylene blue stain, you can see a tiny blue dot here. Can anyone tell me what this is and what's the name of this? It's a tiny blue dot. All the bluish green RBCs are the ones which are, these are RBCs, the blue, round bluish green one, because the new methylene blue stain. In that, there's a tiny blue dot. That's your denatured globin. It's actually hemoglobin's globin, which has been destroyed. And this body is called as an Heinz body. This also is an MCQ. Heinz body is again a diagnostic part of G6PD deficiency. But if you have to confirm, confirmation is G6PD is deficient. How do you confirm? Analyze the enzyme. That's all. Confirmation is by default an enzyme analysis. Analyze the enzyme and take care of that. Treatment is nothing much. I cannot definitely cure it. I cannot replace the enzyme. Try to avoid the trigger. Whenever there's a fever, they have to go to the doctor. Symptomatic treatment is what is required. Fine. Perfect. Done. So we know G6PD, we know spherocyte. Let's go to the next guy. This is spotter, na? Again, we'll go with the normal one. What is this? That's your, maybe looking like a normal RBC. Yes, it is. Smaller, darker, no central pillar, spherocyte, sickle. Can anyone tell me what this is? That's also a classical one, right? What is that? That's a target cell. Target cell is primarily diagnostic of a thalassemia, but can also be seen in severe case of sickle cell anemia also. Not denying that, right? Okay, it's about sickle. So now let's read a little bit about sickle cell anemia. Sickle, again, the important keywords. There's a confusion between whether it's in 6th portion or 7th portion. Till the standard books change, we'll keep it to 6th portion. Is your right drepanocytes, right? Sickle cell anemia is an autosomal recessive inheritance where this change has been asked multiple times. Glutamic acid to valine in the beta chain of hemoglobin. Okay, the 6th portion is what we are sickle cell anemia. Valine is an hydrophobic amino acid, does not like water, so it will not dissolve. The primary problem of HbS, that's hemoglobin sickle, is reduced solubility. It will not be soluble, right? It will not be soluble, it's reduced solubility. That's the biggest problem of sickle cell anemia, right? Next, sickle cell anemia, it's actually more than anemia. The presentation is not as anemia. Presents primarily as an painful crisis, painful vascular crisis, because most of the sickled RBCs, which are reversibly sickled, they get stuck with each other and they block the blood vessel. The most common symptom is your dactylitis. You'll have pain in the fingers. End artery occludes pains, like someone is blocking the entire artery, right? You might have non-healing ulcer. You might have priapism. You might have unexplained abdomen pain. Randomly, suddenly, there'll be an abdomen pain. Nothing will be seen in ultrasonogram anywhere because there's a very, very, very tiny infarct which might happen in the spleen over the period of years. What will happen to the spleen? Can have autosplenectomy also. They might also present with anemia if it's a homozygous case. But first presentation will always be the painful episodes, right? So then you suspect sickle cell anemia, you do an CBC and your peripheral smear. You can see sickled cells, sickled RBCs, or like Gautam said, we can call it an drepanocyte, right? That's enough for confirmation. But still, if someone asks, what is the investigation of choice? Can anyone tell? What's the investigation of choice for sickle cell anemia? If you had to go with investigation of choice, for both sickle and thal, only one, I go for HPLC. Hemoglobin electrophoresis is actually good enough, but HPLC is slowly replacing everything everywhere because it's much easier to do compared to an hemoglobin electrophoresis. Fine. For any hemoglobinopathy, I'm going to prefer HPLC. If it's not there in the option, I go for hemoglobin electrophoresis. Clear? Done? Perfect. Okay, that's about sickle cell anemia. Next, let's go to this image. Can anyone tell me what this is? No, Dr. Nice, I don't want a globin gene sequencing. Globin gene sequencing might be required for alpha thalassemia primarily, not even for beta. Unless and until because only in alpha thalassemia, it's a bit difficult to identify the mutation. Beta thalassemia also can be easily picked up by HPLC. Okay, that's a classical target cells. Target cells, or the other name for target cells is codocytes. Actually, in electron microscopy, these cells looks like a hat. So it looks like this. That's how the target cell looks like in electron microscopy. It looks like a hat, so they call it a codocytes, right? Perfect. So we'll primarily look at beta thalassemia, which is the commonest one. Alpha thalassemia also is there. Maybe few salient points. We'll look at alpha thalassemia. Fine. So when you take beta thalassemia, which chain is absent? Beta gene is absent or alpha gene is absent? Which chain is absent in beta thalassemia? Absent or reduced, whatever you want to call. Because in major it will be absent, minor may it will be reduced. In beta thalassemia, beta chain is absent. But it's a very important thing. But all these symptoms of beta thalassemia is not due to absent beta chain. It's due to excess alpha chain. I don't have a problem if one chain is absent, but the entire problem was the other chain tried to overcompensate. That was the problem. Excess alpha is the reason for almost every symptom of beta thalassemia, and excess beta or gamma is the reason for every symptom of alpha thalassemia. Fine. Okay. Now, in beta thal, we have beta thal major. I'll ignore intermedia for now, and beta thal minor. Thal minor is almost similar to iron deficiency anemia. Presents a little bit later, mild anemia. You can only pick it up when you do a peripheral smear where you can see the tiny target cells. Thal major presents around 6 months of age. Classical symptom is failure to thrive. You'll know what is failure to thrive from pediatrics. Divya will definitely talk about that. It is not growing properly. Dr. Nice, symptom is 1. Characteristic pain crisis will not be seen in thalassemia. 2nd, severe sickle will have target cells. So when you have target cell sickle, definitely you'll see sickle cells. That's diagnostic for me. The primary factor is diagnostic for me. The other one is not diagnostic for me. Fine. Only target, I think of a thalassemia. Okay. Next, there's a classical phasis called chipmunk phasis or a hemolytic phasis, where there'll be a prominent zygoma, prominent frontal bone and everything, right? That's also seen in beta thal major. Presents very early, very severe hemolysis. How do I know it in microscopy? Whenever you see target cells, that is common, na? Common for both. But when I see target cells plus NRBCs, nucleated RBCs, which means it's a severe anemia. That's when I know, this is severe anemia. I'm going to think of a thal major. Thal minor is like an IDA. Presence like an IDA, symptom like an IDA, everything like an IDA only, right? Thal minor, what will happen is, you will have in CBC few clues, right? This, I have told you the reason for the RDW and the Menster's index in the normal class. Here, I'm going with short forms. We always look thalassemia, right? So RDW will be narrow, less, and your Menster's index will be less than 13 for thalassemia. 13 is the number for Menster's index, will be less than 13. RDW will be narrow in thalassemia. This helps me to differentiate from iron deficiency anemia. And when I do microscopy here, I'll see only target cells here. I will not see NRBCs. No NRBC, only target cells. Microcytic hypochromic anemia is common for both. I'm not writing that here, right? So when you do HPLC, what will I see in thal major and thal minor? HPLC here, HbA will be 0. HbF will be very, very, very high. Hemoglobin F will be very high here. Hemoglobin A will be 0. A is the adult hemoglobin. It will be 0 because there's no beta chain. 0 beta chain. I cannot form an adult hemoglobin. Here, I have a marker called as HbA2. It's alpha to delta 2. It will be more than 4.5. Indian adult male, this is a value. Slight elevated HbA2, I'll think of a beta thal minor or beta thalassemia in general, right? Here, HbA also will be present. HbF will be very marginally elevated because of mild anemia. Fine. A present, A2 present, thal minor. No A, A2 and F very, very high, thal major. Very simple to diagnose, right? Treatment is simple. Repetitive transfusion till I can get a bone marrow donor for bone marrow transplantation. Fine. That's about thalassemia. We know thal, we know sickle. We quickly read about spherocytic anemia and J6PD deficiency, right? Now let's go to the common ones, the iron deficiency anemia, right? So we calculate or we divide anemia based on MCV. MCV of less than 80 microcytic, 80 to 100 normocytic, more than 100 macrocytic. Okay, got it? So now you know the mnemonic of Sitama, right? I am not going to fiddle with the mnemonic. Go with Sitama. But my only concern with Sitama is first I should not remember S. S is sideroblastic. That's the last one to remember, right? First, remember this guy. Two things which I want you to remember. 95% iron deficiency anemia only. Then maybe thalassemia. then maybe sideroblastic. Actually, anemia of chronic disease, that's a Sita mark A. It's not microcytic, it's normocytic, right? So anemia of chronic disease is normocytic, and your anemia in CKD is also normocytic. In CKD, why there's an anemia? In CKD, why there's an anemia? CKD, there's no erythropoietin. So how do you treat it? This came in an exam. Treatment is give erythropoietin. That's all. Kidney is chronically failed, cannot produce erythropoietin. Give erythropoietin, automatically come back to normal. That's all. As simple as that. Fine. Macrocytic, in that we have megaloblastic. That's your B12 folate deficiency. And your other macrocytic, I can see in liver disease. You can see them in your alcoholism. You can see them in hyperthyroidism, right? Hypothyroidism. Everywhere I can see your macrocytic anemia, which is not megaloblastic. Fine. How do you confirm iron deficiency anemia? With something classical called iron studies, right? Yes, there'll be history of bleeding or like a menstruation or poor nutrition or worm infestation. All those are there. Microscopy is microcytic, hypochromic. Fine, done. Confirmation is based on iron studies. Iron studies is a very important topic, especially when you have to compare between these two, right? So these are the 4 basic parameters for iron studies. I've told you again how to remember that. We'll read it once again so that you don't forget. Again, read this the day before exam. There's a very likely chance one question might be dependent on this. 2 findings only. Serum iron and transferrin saturation. These both are directly proportional, which means when iron increases, saturation increases, vice versa. Ferritin and TIBC are inversely proportional. One increases, other reduces, vice versa. Done? Perfect. Okay. So in IDA, what happens to serum iron? I want you guys to comment. What will happen to serum iron in IDA? Serum iron will be not rocket science, will be reduced. Saturation reduced. Ferritin in IDA, storage form of iron. That's the most sensitive test, It's obvious is the most sensitive test for IDA. Will be reduced. So TIBC elevated, inversely proportional. That's it. If a question comes on iron profile, please don't memorize and write it. Iron and saturation are directly proportional. Ferritin and TIBC are inversely proportional. If I know that, rest everything can be sorted. Let's go to anemia of chronic disease. Chronic disease ka matlab chronic inflammation. During COVID time, we did ferritin. Ferritin is an acute phase reactant, right? Every inflammation, ferritin is like CRP. It will be very highly elevated. So we'll start with this. Because ferritin is an acute phase reactant. That's why in inflammation, it will be elevated. Because that is the change in the equation. If ferritin is elevated, what will happen to TIBC? Will be reduced. If ferritin is more, I have more stores. You have lots of money in the bank. Everything in the bank. Wallet might not have it, right? So iron reduces, saturation reduces. That's all. Link it here. If you know this relation, you need not memorize any iron study. One is directly proportional, other is inversely proportional. This is a trick. To understand what does real TIBC means, you will need to do when you do a post-graduation related to that topic, you will learn more about that in depth, right? For now, it's more than enough for you to apply to any disease available. Fine? Done. Classical finding. What's the answer? Just few spotters and few diseases where you see them, and then we'll go to WBC. What's the answer? It's classical. Hypersegmented neutrophil. Right? 3 to 5% of them with more than 5 lobes, or even a single neutrophil with more than 6 lobes is enough for me to call it hypersegmented. It's a classical diagnostic finding of which guy? Classical diagnostic kind of megaloblastic anemia. In megaloblastic anemia, there is two problems. It can be either a B12 problem or a folate ka problem. How do I differentiate them history-wise or clinically? B12 problem, one clue is vegan, not vegetarian, vegan. No milk protein and animal protein. Vegetarians might have milk protein that can give enough B12. Or there's a history of neurological involvement. There's a history of neurological involvement. I think of a B12 deficiency. Folate. There are few important things for folate. When there is less amount of greens and fruits, it's a problem with folate. See, folate is there in milk. Folate is there in meat. But when you cook the milk or cook the meat, folate dies. That's why fruits are very, very important for folate. Less fruits, less greens, which I can eat raw without cooking. It's a good source of folate. Then there's a possibility of folate deficiency. Remember, pregnancy. There's a possibility of folate deficiency. Do remember them as well. That's why we give folic acid for every woman who's pregnant. Right? Perfect. So these are clues for me to say clinically as B12 or folate. Obviously, blood test to say B12 is reduced or folate is reduced is the way to confirm. Fine. What is this guy? Irregular spikes. Irregular spikes. What is that? It's blunt irregular spikes in an RBC. It's diagnostic of acanthocytes. Right? Acanthocytes are also known as spur cells. Okay? They are acanthocytes or a spur cell. Right? Perfect. Acanthocytes, I'm sure you know, where do you see them? First, every student says is, A beta lipoproteinemia. It's an MCQ, that's all. But the first thing I want to know is liver failure. And also, yes, A beta lipoproteinemia. We always memorize things, right? We are not used to asking questions. I don't know why. We as a community should ask questions. Why in A beta lipoproteinemia? Because the name says there is no beta lipoprotein. If there is no beta lipoprotein, the membrane, which is made of phospholipid bilayer, will become weak. So, spikes. Liver fails. LDL, HDL, VLDL, nothing will be normal. Again, same problem. Lipoprotein will be abnormal. Will result in spikes. Both the conditions, there's an abnormal lipid, which is going to cause the membrane becoming weak. When the membranes become weak, automatically it will spike. It will be irregular. It will not be a perfect biconcave shape because biconcave shape requires lots of sturdity. Becomes weak, becomes irregular. That's the reason you have acanthocytes in your A beta lipoproteinemia and in liver failure, right? Next, if you look at this guy, compare this to this. This is irregular. His spikes are very, very, very regular, right? Very, very, very regular spikes. We call it an burr cell. The other name is echinocytes. Okay. Echino is porcupine. Sea urchin. Urchin looks like a porcupine, right? So this we see in CKD. Uremia CKD is a very classical finding, a pretty common finding seen. Echinocyte or CKD. Fine. Or burr cells. Okay. Next. What is this guy? This is classical, na? How does it look? Looks like a water drop or a tear drop. We call it a teardrop cell. The scientific name of tears and the tear gland is dacrocystitis. You must have read about dacrocystorhinitis and dacrocystitis, right? Dacro is tear, right? So we call them dacrocytes. You see dacrocytes in myelofibrosis. Imagine the bone marrow is fibrosed completely like a meshwork. Normal RBC cannot squeeze, so they squeeze, come out as a droplet of water, right? Dacrocytes or teardrop cells is classical, right? We know drepanocytes, we know dacrocytes. I think one side, codocytes also we know. One side which I missed here, degmacyte is bite cell. Fine, tegmental is by cell, to remember that as well. Okay, because you already know about bite cell, you have been acute for sickle cell, teardrop cell, everything. How do I make the exam difficult? By changing the name, that's all. Okay, so these are few things for an image based thing. Fine, so we know few images, we know about few major anemias. We'll had a tiny look at iron deficiency, megaloblastic, sickle, beta thal, spherocytosis, and G6PD deficiency, right? That's with respect to RBC disorders. Now let's quickly go to a little bit of leukemia, lymphoma analysis, WBC. Fine, okay, ready? I'm not giving you break because I think the tech glitch in between caused a break, unfortunately, forcefully. So I'll run maybe for maximum an hour more and we'll try to complete that. Is that okay, guys? I think you guys can stand longer than me for in a class, right? So I hope it's okay. Let's start with WBC disorder. In WBC, I have leukemias and lymphomas. This and next maybe half an hour to 45 minutes, the goal is to approach leukemias and lymphomas, not to confirm the diagnosis, right? See, because to understand the concepts and everything, you know how to do. If a question comes, how do I approach? How do I diagnose? How can I solve the question is our primary goal here, right? Unfortunately, leukemias as well as lymphomas don't have very classical clinical symptom. I'll have non-specific symptom or the same symptom. Every lymphoma is going to have lymphadenopathy, right? Leukemias will have cytopenias, that's all. Except for few places, I don't have a classical clinical clue. That's why there's more reliance on the markers and the microscopy, right? Now let's see, this is a blast. So whenever I see a blast, okay, in an image, my first question is, how do I know it's a blast? That's the first question. Then how do I confirm what blast is, lympho or myelo? Second question. Then obviously I can say, yes, the diagnosis. First, in a microscopy, how do I know it's a blast? It should be more than 2 times size of RBC. That's the first and the foremost clue. RBC is here, easily more than 2 times. It's a blast. High NC ratio, not required. First is size. If it's bigger, it will have high NC ratio by default. So now I know it's a blast. The next question is, lymphoblast or myeloblast? Myeloblast is coming from neutrophils, let's assume. Neutrophil is a granulocyte or agranulocyte? What do you guys think? Neutrophil is a granulocyte, right? So if a blast has no granules, okay, no OR rods, I generally think of a lymphoblast. If a blast has granules or OR rods, I think of a myeloblast. Very simple. Done. Now I know it's a lymphoblast, but you might not accept me as it looks like it has granules. Someone will say, sir, it does look like granules, so it's not a lymphoblast, it's a myeloblast. I'll have to prove. That's where my marker comes. The first stage is called an ICC or a cytochemistry marker. Here it is PAS positive, especially dot-like positivity. When you do it, there'll be like a dot positive. It's a lymphoblast. Then comes my CD markers or IHC. IHC is much more better than ICC, but ICC also is decent enough, right? How do I know it's a lymphoblast with IHC, right? So CD marker, what we do is, so I know it's a lymphoblast. CD34 is positive. It's a stem cell marker. The purpose of doing this is, it will tell me and confirm me it's a blast, not a lymphoblast. This is just confirm it's a blast. The same way what I did in microscopy. Next, like Dr. Nice said, TDT. TDT will be positive in a lymphoblast. I know, it's not just a blast, a lymphoblast. What are the types of lymphocytes you know? Because I need to diagnose them also. Because treatment varies. We have 2 types of lymphocyte, B lymphocyte, T lymphocyte, right? So, next what I do is, CD3 is positive for T cell. CD1920 positive for B cell. This is what I do in flow cytometry. A random question came with a flow cytometry finding of the below. I think of an BALL, not just ALL, BALL. How do I know that? If I see a leukemia or a blast being positive for CD34, it's a blast. TDT, it's a lymphoblast. CD1920, it is a B cell ALL. The most common subtype of ALL. 85% of them are B cell ALL. I see a leukemia, CD34 positive, it's a blast. TDT positive, it's a lymphoblast. CD3 positive, it's a T cell ALL. Rare, 15% only T cell ALL. But there are clue for me, clinically also to tell it's a T cell ALL. Clinically also have a clue. This is confirmation. Clinically also have a clue. We'll come to that very, very soon. This is what happens in the lab, right? Now, what will happen in the clinical way? I also need to know a little bit. Though I said clinical symptom might not help me to confirm, few clues will be there. Remember this, always, never forget. The only leukemia which happens in a child is ALL. Lymphoma in a child is Burkitt's, right? Age is a clue. If it's a child and the options are leukemia, it is ALL. A child and the options are lymphoma, it's Burkitt. No other leukemia or lymphoma happens in a child. Exceptions do there, but this is how it is. Age helps me. Okay, 5-year-old kid with so many findings. Think of ALL. Don't even think of AML or CML or CLL. Will not happen. Only ALL will happen, right? Then, if there is a lymphadenopathy in the history, right? Generalized lymphadenopathy. I generally think of an BALL. But if there's an thymus involvement, if there's an mediastinum widening, T stands for, in T lymphocyte, what does T stand for? T stands for thymus. Hai na? So these two are suggestive of PALL. Okay, it's a clue clinically. So child with this clinical symptom, I suspect this. So what will I see in CBC? CBC will have leukocytosis. WBC count will be skyrocketing. 50,000, 1 lakh, 2 lakh. It will be elevated, right? And the others, there will be reduced hemoglobin. There might be reduced platelet. Will happen for sure. Because the entire bone marrow is producing only WBC. No space for RBC, no space for platelets. Might be reduced, might be normal, right? This is enough for your TALL, right? So what we have done is, we know the final leukemia status, we know the microscopic approach, we know the clinical approach. These are the components of understanding leukemia. Clinically, microscopically, marker-wise. Either be strong in one. If you want to be strong in one, I would say be very strong in this, because this is the final way to diagnose markers. Or know all. Knowing all makes you very comfortable. Knowing one, which is like a bullseye, less investment, more outcome, right? I would be preferring that be strong on the markers, be it PAS or CD markers. That's where the entire way of diagnosis is there in real life as well. Fine. That's the same way we look at AML also. Fine. Clinically, AML, how many variants of AML are there? Does anyone know? Different types of AML. How many variants of AML are there? Variants of AML? You have AML M0, M1, M2, M3 till M7. Hai? There are very classical clinical symptoms for few variants of AML, not for everything. When I say AML M3 or I say APML, this is the only leukemia which can present as DIC. Classical. M4, M5 can present with gum hypertrophy, can present with leukemia cutis, skin. In other words, they present with chloroma. Extramedullary involvement, classical for M4, M5. It's with a reason, but it's very, very classical for M4, M5. M7, seen in patient with Down syndrome. It will be in a child. Rare, but it will be in a child, right? These are the clues which I can get from clinical. Otherwise, most of the AMLs are like, you will have non-specific history of fever, petechial rashes. That's all. But these are few classical clues for me. Let's say I had this clue. I'm going to go and diagnose it on microscopy. Same routine. right? But here there'll be one more involvement here, the CBC. The CBC will tell me the percentage of blast. It should be more than 20%, more than or equal to 20% blast. That's required for me to call it acute leukemia. If the blast is 15%, it's not acute leukemia, it's chronic leukemia. Acute and chronic here, na, it's not based on duration. It's based on the percentage of blast. In peripheral smear or in bone marrow, doesn't matter for me. It should be more than or equal to 20%. That's important for me, right? Then I go to PS. In peripheral smear, same. Blast and A. It should be more than 2 times size of RBC. Okay. Next, I go with granules. If granules are present and if OR rods are present, I confirm that it's a myeloid lineage ka blast. Right? Can you see the line here? 2 lines are there. That's your OR rod. OR rod is diagnostic of an myeloblast. It's very important for you. OR rod is exactly diagnostic of a myeloblast. It's a myeloid lineage. But again, like I said, you might accept it's a line. Some might say, sir, it's a microscopic reflection, right? So I need markers. I need to prove, right? Same, I have markers. MPO is a better marker than SBB, cytochemistry wise. MPO is a pretty decent marker, but SBB is also a decent marker. But MPO is much more specific. If not, I go for CD markers. In CD marker also I have MPO, by the way, right? Same routine. What's the stem cell marker? Anyone, can you tell me the stem cell marker? Stem cell marker? Same CD34, na? Right? Then marker for myeloid lineage, I have 2 markers, CD13, 33, but still better than this guy is MPO. MPO is by default the specific marker than 13 and 33, right? MPO is still the boss, MPO is still the most important. Then monocyte. Because if you look at M4, M5, na, that is monocytic leukemia, myelomonocytic, pure monocytic, right? 14, 64. Erythroleukemia. It's M6 is erythroid leukemia, right? Erythroid leukemia, you need not go for high-fi things. Hemoglobin A. Hemoglobin is erythroid leukemia, right? Not a difficult thing at all, right? Okay. Then megakaryocytic. Okay. Do you guys remember the protein mutated in Bernard-Solé syndrome? Do you guys remember the protein which is mutated in Bernard-Solé syndrome? Yes, no, maybe. You might have, right? What are the proteins? You have glycoprotein 1B9, 2B3A. In Bernard-Solé is 1B9. In your Glanzmann thrombocythemia, it's 2B3A. The same glycoprotein is positive in megakaryocytes because that's also a platelet ka problem, na? But in the name of CD marker, we have CD41 and 61. There's nothing but the glycoprotein. The glycoprotein 2B3A's other name is your CD41 and CD61, right? These are markers. So what I do is, if in a, let's say in a flow cytometry, how do I diagnose leukemia? Okay, simple. The most unique one here is AML-M3. This is the only CD34 negative leukemia. Never forget, exceptions are very, very important for MCQs. Okay, the only CD34 negative leukemia. Rest every leukemia CD34 positive. If you have to say, it's AML-M4. M4 is myelomonocytic. So 34 positive for blast, MPO positive for myelo, 14, 40, 64 positive for your monocyte. Monocyte has one more marker called as NSC. That also you can add. Okay. Now let's say AML-M7. Again 34 positive, maybe 41 positive, 61 positive. Right? It's the combination. It's the same mix like ALL. We do it for AML also. Fine. The same way, clinical, few salient clues. Blast percentage is must. Peripheral smear exception. Your approach is must. Markers is must. Again, like I said, exceptions are always MCQ. Exceptions for 20% blast, which means if I see any of these mutations or translocation, like translocation 821, translocation 1517, okay, or inversion 16. If I see any of these three, right, not all of them, any of these three, I don't want a 20%, which means, let's say I have a patient with a leukemia, translocation 821 positive, even bone marrow has only 15% blast. Still, it's acute myeloid leukemia. I don't call it chronic, still it's acute myeloid leukemia only, right? Okay, I'll still call it an acute myeloid leukemia if any of these is present, even if 20% is not met with. Exceptions are important for us, fine? Okay. Diagnosis. What do you guys think? Whatever comes to your mind, tell. Maybe right, wrong, doesn't matter. We'll start with a very simple one. Do you think it has more WBCs, less WBC? What do you guys think? Definitely, the amount of WBC is more, right? Is everything a mature one or immature? I do have some neutrophil-like looking, some good amount of cytoplasm, some with very thin cytoplasm like a blast. So can I say this patient is a mix of all these cells? Yes. Great, Dr. Nice. Something diagnostic or looking like a CML, chronic myeloid leukemia, right? Since here in this peripheral smear, you have lots of cells, neutrophil, bandiforms, myelocyte, metamyelocyte, even blast, also basophil, lots of them. That's why the famous name is there, right? Like Dr. I said, garden party. Though I hate the name, garden party and your college girl appearance, right? So peripheral smear, you'll have lots of WBCs, which is classically described as neutrophilic left shift. Okay, neutrophilic left shift, that is one. And the most important thing is basophilia. Basophilia is a big clue. Because of the neutrophilic left shift, we have two terms, the garden party. Many types of people are there. Many types of WBC is there. Same with college girl. Lots of color dresses are allowed, right? Compared to a convent girl, where it's uniform, looks the same. That is for CLL. This is college girl appearance, right? Okay. CML's approach starts from the age. Let's say you have a patient with an adult with massively enlarged spleen or a pain in the left hypochondrium on examination as a massive splenomegaly. There are two options here. I want you to look at both the option. The moment you see an elderly patient, 45, 50-year-old, massive splenomegaly, please don't jump to CML. CML is the cause, one of the cause, right? So look at CBC. If CBC has leukocytosis, very high WBC count with basophilia, very important, then my peripheral smear like this. CML is mostly CML, right? If the CBC has pancytopenia, if the CBC has monocytopenia, which is very classical of this disease. Can anyone tell me what disease I'm talking about? Monocytopenia or pancytopenia? What disease I'm talking about? Classical for hairy cell leukemia, and peripheral smear have hairy cells. I think of an hairy cell leukemia. Okay. Very classical, both of them as classical, same clinical symptom. Anumita, CLL will have lymphadenopathy. They might not have splenomegaly. It's a lymphoid tumor, right? Every lymphoid tumor has lymphadenopathy as a presenting symptom, right? Think of an hairy cell leukemia here. Okay. Hairy cell leukemia, the marker, couple of them not to forget. One is TRAP, tartrate resident acid phosphatase positive. Other one is annexin. Okay. Annexin A1, annexin B, anything positive. Fine. Okay. Obviously, when it's a CML, right? The way to confirm the diagnosis, there's no marker for CML. There's no need for bone marrow in CML. Go directly with BCR-ABL. Do a FISH or a cytogenetics or a PCR. That's all. I need to prove it's genetic diagnosis directly. Translocation 922 or your BCR-ABL translocation. You can do with whatever method you want. And qPCR or a PCR and fish both has same yield but less than karyotyping. Okay, you don't want a bone marrow, no need markers at all, right? That's enough for me to diagnose and confirm and go ahead and treat with imatinib. Okay, treatment is based on imatinib. Fine, done. Next we'll go with lymphomas. See, what I'm going to go with lymphomas is I'm going to give you keywords for almost every lymphoma and look at the image relevant to it. Fine, because almost every lymphoma has the same symptom, generalized lymphadenopathy, if or minus few plus few minus symptom, but there are few subtle clues in history and markers. I'm going to tell you one marker to remember and one genetics to remember. I'm not going to say CD19 is positive. 19 is positive in every B-cell lymphoma, not important for me, right? Cyclin D1, seen in only one tumor, important for me. We're going to go with the specific marker, not the everything all around, right? So let's say you have an adult with generalized lymphadenopathy. Okay. Presenting with autoimmune hemolytic anemia. These are important keywords here. Splenomegaly, Anamita. One could be a clinical splenomegaly. Because of reduced monocyte, there could be opportunistic TB or an atypical mycobacterial infection. That can also be there as a clinical presenting symptom. Fine. Got it? Okay. Autoimmune hemolytic anemia. And in your peripheral smear, you have something called as smut cell. Can anyone tell me the diagnostic? And in CD marker or IHC profile there are lots of markers here. CD5 is positive, not denying, but something which is important for me is CD23 being positive is important. Flow cytometry CD200 being positive is important for me. Fine. These clues are diagnostic of only one guy, CLL bar SLL. NHL is a very broad terminology, right? Non-Hodgkin's lymphoma is right, but it's a very broad terminology. I want a very specific. Smut cells are diagnostic of CLL. These are like basic minimum you'll have to know, right? Okay. Next, adult with lymphomatoid polyposis. Again, it's a very important clue. Very rarely, lymphomas present as polyps. Lymphomatoid polyposis might not have a peripheral smear finding, right? Marker wise, this is cyclin D1 positive and translocation 11-14 positive. Classical findings of mantle cell lymphoma. Fine. Okay. 11th chromosome has the cyclin D1. Classical for mantle cell lymphoma, right? Next. Adult, very slow growing tumor. The history might be of 5 years, 6 years, 7 years. Slowly lymphadenopathy, very slow growing tumor. Okay. BCL2 positive, marker wise. Translocation involving 14th and 18th chromosome. 18th chromosome is the chromosome for BCL2. Can anyone tell me the diagnosis? See, everywhere 14 will be common, right? The other one will be the one which is involved in the pathogenesis. It is follicular lymphoma. Okay. Adolescent or an adult, right? Just lymphadenopathy. Hodgkin's can be seen in adolescent as well as adults, not only in adults. Do remember that, right? Okay. With microscopy of an RSL, I have two outputs here. CD15-30 positive is one output. CD20-45 positive is the other output. CD20-45 positive is NLPHL, nodular lymphocyte predominant, in which the type of RSL is called as an popcorn variant of RSL. 15-30 positive is a classical RSL. Okay, that's diagnostic of classical Hodgkin's lymphoma. Fine. Okay. Anumita, again 1920 is positive. I'm not denying, but I'm going for the keyword. One marker to remember, because every B cell lymphoma is positive for 1920. Fine. Okay, this is again classical for your Hodgkin's lymphoma, NL, PHL, and classical RSL, right? Okay. Can anyone tell me what is this? What is this? That's a classical smut cell, right? This is how smut cell looks like. It's written, right? So smut cell is a classical finding for CLL. Please don't forget it. These are very, very important images. Should not forget. What is this image? Everyone knows that. What is this image? This is starry sky. Starry sky is something which you start to learn even before wanting to prepare for entrance exam, right? Starry sky appearance, something which you'll never forget, because you know that from second year. Only image which you might remember from second year is this and RS cells. Starry sky is bucket. Always I call it bucket. So it's a bit easy to remember translocation. Translocation involving 814, translocation of 28, translocation of 822. 8 is the problem. It's bucket, right? Bucket, the most important clue is child. A child with a lymphoma. Remember, African child, jaw swelling. Child with a lymphoma is bucket. Okay? Bucket is very aggressive, very fast growing. EBV positive. Both sporadic, endemic, both are EBV positive. Okay? Child, EBV positive, Bucket's lymphoma, microscopic starry sky appearance. And the gene involved is the marker also for me is CMYC. This is the marker, CD marker, as well as the gene involved. Chromosome 8 as c-MYC, that's the problem here, right? And one more important marker is Ki67. This is a proliferation marker close to 100%. There's no other lymphoma on earth which will have close to 100% Ki67, which means it is dividing every single day always. This is a proliferation key marker. Fine, that's your Burkitt's lymphoma. Okay, all the important keywords are here. You are right. Jaw swelling seen in African child, sporadic can be seen anywhere, right? If you want, see, mostly the African or the endemic ones will present with jaw or an mandibular swelling. Sporadic can present as lymphadenopathy, but a very unique presentation of sporadic is intussusception. Okay, they present as intussusception, the telescoping of intestine as classical in intestinal Burkitt's. Very important, a unique way of presentation, so it should trigger the thought process of Burkitt's lymphoma. Fine. What is this guy? Unfortunately, to draw the popcorn, only then you will be able to identify popcorn variant of RSL. Otherwise, it's not difficult. Popcorn variant of RSL, like we already saw, it is seen in NLPHL, nodular lymphosis, brown Hodgkin's lymphoma. We know the marker. Marker is a bit different compared to the rest. Okay. I don't think I have a classical RSL's image. Classical RSL we saw in the Jane cells. Binucleate outside the classical RSL. I'm sure you will never forget it. Fine. Okay. Few more important with respect to T cell lesions. Because T cell lesions, we don't focus it much. But if you see an adolescent person, okay, with microscopy, you have something called an hallmark cell or an embryo shaped nuclei. Looks like an embryo, very folded nuclei. That's an embryo shaped nuclei. IHC as well as the genetics involving ALK gene. We read this in the Proto-oncogene also, which is anaplastic large cell lymphoma. Second, I'll tell you clues. You're going to tell me the diagnosis. I am sure you know this diagnosis, right? Skin involvement is present. This disease has epidermotrophism. Okay. Can you tell the diagnosis? Attempt? No. I'll give you one more clue. If the disease is systemic, in the blood or in the bone marrow, you might see a cell which is called which has an cerebriform appearance or nuclear convolutions. Any clue? Any diagnosis? Perfect. This is your mycosis fungoides or your Shachari syndrome. And the cell is called as Shachari-Lutzner cell, right? It's also CD4 positive tumors. Fine. Classical. Jesse sir will definitely talk about this in the next class, in the next session, right? Next, a cell with a flower shaped nuclei or a clover leaf shaped nuclei. You must have seen, definitely must have seen the image of this in Instagram or in many sessions. The nucleus will look like this, like a flower, right? A flower shape or a clover leaf shaped nuclei is classical for an adult T-cell leukemia lymphoma. Okay, it's a classical for adult T-cell leukemia lymphoma, and this, okay, this is positive for one more as HTLV1. It's HTLV1 positive. That's diagnostic, and that's also an important MCQ point as well. Fine. Very aggressive disease, not that great of a prognosis. Fine. Okay, that's something about WBCs. We saw about approach to two leukemias. We had keywords for every lymphoma, few salient important markers, genetics, and also few important images for us. Fine. Now the last few words about systemic pathology. Systemic path is not that great important as a standalone for FMG. It's important. It will be combined with other parts of nephropathology or GI surgery or gynecology. It will be combined mostly with that. It will be a scenario-based question only, right? So now what we are going to do is we're just going to look at few classical images and few points respective to that. We will have to talk about the valvular vegetations. That's first. Then little bit about emphysema and related points. Little bit about your occupational lung diseases, GI tumors, polyps, and obviously about your kidney. That's all, right? So just few half an hour more, we'll definitely wind up very, very faster. Okay, ready? Okay. So first thing is about systemic pathology, the vegetations. Vegetations are nothing but irregularities on the leaflet. The irregularities on the cardiac surface or on the valve is called as vegetation. Have four different types of vegetation. Can be rheumatic heart disease, NBT, non-bacterial thrombotic endocarditis, infective endocarditis, and Lipman Sachs. How do I differentiate each of them and the classical clues? Remember, of this, only one is infective. That's there in the name. Rest everything is sterile. This is very unique. Only infective vegetation. Okay. Only vegetation which damages valves. They can destroy the valve completely, and they are very, very, very fragile, and they can break and become an embolus. All these are very, very classical only for infective endocarditis. Rest everything will be subtle. It will be there. Rest everything is sterile. Rest everything is seen on the valve edge, right? This seen on the valve edge, this seen on the valve edge. Lipman Sachs is seen on both sides of the valve, right? This is sterile. Okay. Which seen on the edge of the valve. Okay. This. Hey guys, I hope I'm back. Can you see me? Okay, let's come back. Where were we? Yeah, I was in NBT, right? So the only vegetation, as the name says, is thrombus. So anything which causes thrombus will cause this problem, right? So thrombus you can see them in any case of DIC. You can see them in any case of APLA. You can see them in any case of cancer, especially in the terminal stage. In terminal stage, cancers can have thrombus throughout the body. That's what I see. And microscope is thrombus. If it's thrombus, obviously it is to be sterile. This is also seen on the edge of the valve. Okay. The older name for this, though it's not required now, is marantic endocarditis. We thought that it's seen in marasmus patient. Actually, not marasmus. Terminal cancer patients are called as cachexic patients. They look like marasmus patients, very thin. So we call it marantic endocarditis, right? Lipman Sachs, SLE. It's nothing but an antigen antibody complex. You see them, like someone said, it's seen on the both the surface. Like Hussein said, it's seen on both the valve surfaces. That's very classical of SLE, Lipman Sachs endocarditis, which is also diagnostic. It is also obviously sterile. Since antigen antibody complex, SLE has nothing to do with infection. The only infective, only destructive endocarditis, infective endocarditis. Fine. Quite a few variations of questions come with respect to this. You should be able to know. Fine. Then let's go to emphysema. See, emphysema is a COPD every COPD, the mechanism is same. The only difference is the place. Bronchitis, bronchiectasis. Bronchiolitis, lung emphysema, alveoli. The anatomy changes, that's all. It's a chronic destruction, that's it. The primary etiology is smoke. I have three different types of emphysema. We call it centri-acinar emphysema. We call it pan-acinar emphysema. Or we have distal acinar or bullous emphysema. It's based on anatomy completely, right? Distal acinar or a bullous emphysema. And look at centri-acinar emphysema. What you see here is how to identify it grossly. See the name centri-acinar. Let's say this is the acini. Okay. In centri-acinar emphysema, you know what will happen? The center part of the acini alone will become bigger. That's centri-acinar, which means I'll still see normal acini on the sides, which means emphysema normal. In a lung, if you see normal parts as well as emphysematically dilated parts, it's centri-acinar. Seen primarily in upper lobes. Again, don't memorize it because smoking is the cause. Smoke obviously goes and involves the upper lobes more common, right? Smoking is the cause. This is the most common subtype. That's what you see grossly, both. Pan is complete, right? There is no normal lung at all. Completely dilated. So the acini here will look like this. Completely gone, completely ballooned. Seen primarily in alpha-1 antitrypsin deficiency. Not sure why, but it's seen in the lower lobes of the lungs. How to diagnose? One, family history, because it is a genetic disorder. Plus, you'll have lung involvement plus liver damage. 2 organ involvement and pan-acinar. Fine. Microscopy and the history. Rheumatic heart disease, you'll have the classical history of RHD, right? And Marantic or NBT, you'll have the classical history of prothrombotic state. Anything prothrombotic state will cause NBT. Fine. Grossly, nothing much. Microscopy might help us a little bit. Okay. Then distal acinar. Distal acinar bullous, again, this also is primarily due to smoking, especially seen in heavy smokers, where the distal part of the acini is destroyed. So we end up in having a bullae. The only problem with the bullae is the bullae can rupture. This is much more severe. Other two are COPD, breathlessness, lifelong. That will be the presentation. Slowly you will deteriorate and have failure. But here there will be rupture. Because of the rupture, what will have is you will end up in having tension pneumothorax. I am sure everyone must have seen the Good Doctor's first scene, right? Tension pneumothorax, that's what will have. Okay, so when you have tension pneumothorax, the way to treat is you put an intercostal tube, IC tube drainage. Okay, Sandeep sir will tell how to put it and which intercostal space, exactly how to drain it and how to follow it up, everything you'll be talking about, right? Bullous, the problem is sudden presentation, sudden breathlessness. An easy way to identify tension pneumothorax is a clinical symptom of or auscultatory finding of no breath sounds. If there's no breath sounds seen in one side of the lung, always think of a tension pneumothorax as the easiest one to pick up tension pneumothorax. Fine, perfect. Okay, this is better lung. Few things about your occupational lung diseases. The most common occupational lung disease is silicosis. Okay, the clue for occupational lung disease is the occupation, right? Silicosis, anything related with the sand blasting or the glass industry. All these are manufacturing places. If I'm going to use glass, I won't have a problem. Everything is manufacturing, factory related disorder. If I'm going to use asbestos fiber, I won't have a problem, right? Okay, silicosis involves upper lobes. Okay, silicosis will have the silica nodule, which is a completely fibrosing, non-necrotizing granuloma will be there. NN is non-necrotizing granuloma. That's what you will have. One more clue of silicosis apart from your working is X-ray. Can anyone tell me one X-ray finding of silicosis? Which one, Ashik, which one is histological means? See, for emphysema, for every emphysema, histologically, you will have only destruction of the alveolar spaces. X-ray, a classical eggshell calcification of the hilar node. That's what we'll have. And like we saw, since all of them will have non-necrotizing granuloma, the only way to say there is a sand available there is you will see the birefringent crystals, right? When you see birefringent under polarized light, which might help me to say is exactly there is a sand deposit or a silica particle deposit. Fine. Okay. Next is your asbestos. In asbestos, there are two types of fibers. This has been asked multiple times. We have something called serpiginous fibers. As the name says, they are like a snake. They are more wavy, right? And then amphibole fibers. Amphibole fibers are more sharper fibers. They are more wavy, and they are commonly used in the industry. Cement industries, asbestos roof manufacturing, shipwreck yards. All of the places have asbestos, right? They are commonly used. These are very sharp fibers, so they are rarely used as well. But fortunately for us, this is more pathogenic. Very sharp, they destroy, they don't escape outside. This is actually less pathogenic. The commonly used asbestos fiber is less pathogenic. That makes the disease also less importance, incidence wise, right? And this fiber is your ferruginous body. You can see this is an image from Robbins. You can see the brown color beaded appearance, which is ferruginous body, which is nothing but a fiber. Along with that, iron particle is being coated. And if you do a Pearl's Prussian blue, they are definitely Pearl's positive, telling to me that exactly these are iron coated asbestos fibers. Some books say dumbbell shaped. Dumbbell might not be always seen, but yes, there's a possibility I can see beaded appearance or a dumbbell shaped appearance also. Fine. Okay. That's your ferruginous body, and these are Pearl's positive diagnostic of asbestosis, right? Most important question, asbestos and lung cancer. Can anyone tell me what's the most common cancer associated with asbestos? And also the most specific cancer? Most common, what's a cancer? It is lung adenocarcinoma. It's not mesothelioma. Most specific is mesothelioma. Incidence wise, adenocarcinoma is definitely much more common than mesothelioma. Do remember them. Okay. Done? Perfect. Okay, let's quickly go to few images of GIT. So very classical images. These are like spotters. You can, like I said, it will be a clinical and surgical correlation only, right? So you have this appearance. This we call as an leather bottle appearance or linitis plastica. Fine. So what happens here is, in a type of cancer which we read as diffuse gastric carcinoma, even in your Neoplasia chapter we read, right? So here there is CDH1 loss. There is no E-cadherin. When there's no E-cadherin, by default, I cannot form a gland. Every cell will be separated. So the cell goes along the walls of the stomach. Because of no E-cadherin, the cells are free. They are free to move. They are free from one another, right? This, because of that, it goes along the walls of the stomach, and that makes desmoplastic reaction along the walls of the stomach, which makes the stomach thick. That's linitis plastica. Because the cells are free, microscopy there'll be no glands. To form a glands, I need cells to be united, right? There's no glands here, right? And you have a classical appearance called a signet ring appearance. Okay, signet ring cells and signet ring appearance is classical for your diffuse adenocarcinoma. Where the nucleus is in the corner, it looks like a ring, right? This is what we call a signet ring cells. Signet ring cells is diagnostic of a diffuse adenocarcinoma of stomach or diffuse gastric cancer, not for the other variant. Other variant is called an intestinal type of adenocarcinoma. It's not positive there. It's seen only in your diffuse type. Fine. A very important image, a very important spotter. Do read them. Done? Okay. Next, two more images. This is how a villous adenoma looks. There are few adenomas in the colon which you have to know: tubular, villous, pute sugar, and your juvenile polyp. Fine. A villous adenoma will have more than 75% villi in microscopy. See, look at this. These are all villous lesions. Villi is finger-like projections, right? Throughout villi. It has a very high risk of malignancy. It's a benign tumor, but they do have a very high risk of malignancy. At the same time, they also have an increased risk of recurrence. They do recur also more. Okay, that's about your villus adenoma. Fine. Simple thing to remember. How will I correlate this? When a patient comes to me with like 4 or 5 villus adenomas, the frequency of colonoscopy should be a little bit early, like once in 3 years, once in 4 years, so that I will pick up the lesion early and treat the patient before it becomes cancer, right? This is your famous Peugeger polyp. Peugeger polyp is an hamartomatous polyp, and Peugeger polyp is an arborizing polyp. It arborizes. What does arborize means? It's like a tree, right? Perfect. Obviously, I have STK11 mutation, right? How do I say it's like a tree? If you look, there's a muscle here, na? Muscle is like the branches of the tree. Muscle is going between the glands. It's like a branch of the tree, and glands are stuck to the branches, right? So arborizing meaning is nothing but the muscle is seen between glands. Normally, I don't see muscle between glands. Normally, muscle is each, right? Muscular puppy is very low, glands are on top, right? His muscle is seen between glands, so that makes it a Peugeger polyp. And syndrome we already saw. This is a polyp. The most common location of Peugeger polyp is in jejunum. Peugeger syndrome is different from polyp, and both of them will have the same mutation. Syndrome may you'll have the oral mucocutaneous hyperpigmentation, increase of breast cancer, pancreatic cancer. Polyp may will not have that. Okay. Sorry. Okay, that's about your Peugeger polyp. Fine. Okay. Now, last but not least, let's have a quick look about all the nephrotic syndromes and your glomerulonephritis. Fine. Fine. Done. So we already know about nephrotic. Just a quick look. I want you guys to tell me, when do you call it nephrotic? When do you call it nephritic? And there's a base for us also to understand, which will have massive selective proteinuria. Nephrotic. Nephrotic, right? So whenever I have a massive proteinuria, more than 3.5 grams of urine loss per day, okay, I think of an nephrotic syndrome, nephrotic range proteinuria. It's albumin only, mostly it will be albuminuria, right? Massive selective proteinuria. There are non-selective causes also, but for an undergraduate, selective is more than enough for me, right? In addition to that, you will also lose antithrombin 3. Because of antithrombin 3 lost, there might be incidence of thrombus formation. You might also lose transferrin. Transferrin will be lost. So you'll have iron deficiency anemia. You'll also lose lipid. There'll be lipiduria also. All these are classically seen in nephrotic syndrome, right? But massive selective proteinuria is very, very important for me. Two things must for nephritic: hematuria, hypertension. These two are very, very important for nephritic syndrome, not for nephrotic. Nephritic also will have proteinuria, but not massive and selective. Nephrotic will never have hematuria or hypertension, right? That's how we define nephritic and nephrotic syndrome. We don't separate them based on the renal failure. Renal failure can be there in both, might not be there in both. Creatinine might be elevated, urea might be elevated in both, might not be elevated in both also, fine. But massive and the hematuria is the way to differentiate them, right? One more important thing, whenever urine microscopy says I am seeing dysmorphic RBCs, this is important. See, because hematuria can be due to your renal calculi, can be due to your bladder stones, can be due to UTI also, right? Many causes of hematuria is there. How do I say is glomerulonephritis? If I see dysmorphic RBCs, which means the bleeding is in the glomerulus or bleeding is in the kidney, which is an indirect evidence of glomerulonephritis or nephritic syndrome, right? Since hematuria can be there in many conditions, dysmorphic is abnormal morphology RBC, because let's say the bleeding is from glomerulus, have to go to PCT, loop of Henle, TCT, collecting duct, pelvis, your ureter, bladder, then come out. Say lots of space to travel. In that time, it get damaged. That's why we have dysmorphic RBCs. Very important clue to say, it's a nephritic syndrome. Fine. Just few important images. Before that, we have to go to the normal. If you know normal, very simple to understand abnormality, right? This is how normal. A normal capillary. This space, we call it a mesangium. The space between the glomerular capillary is mesangium, and this is your Bowman's. Fine. Now, compared to the image in left, tell me what is the change you are seeing in right. Anyone, whatever comes to your mind, what is the change you are seeing in right? Compared to the left, what is the change you are seeing in right? You see a very thick glomerular capillary loop, right? That's the classical finding. There's a classical basement membrane is being thick. If I see a very thick glomerular capillary, I don't see nodules here. If I have nodules, I'll show that also. It's diagnostic of two conditions. One, membranous glomerulopathy. Other one, Goodpasture syndrome. In both membranous glomerulopathy and Goodpasture syndrome, I'll have a thick basement membrane, right? KW nodule, I think I have, I don't have it. Yeah, see, this is KW nodule. Anumita, this is KW nodule. I have a nodule here, right? This is not a KW nodule. Here it's just a thickness. It's not nodular. You can still see the capillaries, right? If you see the capillaries, it's just thickened glomerular capillary. How do I differentiate a membranous glomerulopathy from Goodpasture? Clinical, enough. This is nephrotic. This is nephritic. Here the pathogenesis is, here I have antibodies against PLA2R, phospholipase A2 receptor. Here I have antibodies against collagen, right? Actually collagen type 4. Fine. Okay. So if I want immunofluorescence, here I'll have IgG deposit, but it will be granular IgG deposit. The only place in the entire glomerulonephritis where you have linear IgG deposit is this IgG, but it will be linear positive. Rest, every glomerulonephritis will be granular positive. It's linear. I want you to think of Goodpasture syndrome. Nephritic, Goodpasture, and both will have the same light microscopy, thick basement membrane, right? Next, if you have an image like this, can I say there's lots of cells inside the glomerulus in this image? Lots of cells. If you carefully look, these are actually neutrophils. Look at the one which I've circled. Looks like a bent nuclei, right? They are neutrophils. A neutrophil, right? A neutrophil, right? If you see lots of neutrophils inside capillaries, I think of a bacterial infection. What's the only bacterial infection comes to your mind? Perfect. I have PSGN or PIGN. How do I diagnose PSGN or PIGN? History is important, right? The history of URI, or I can have history of skin infection. Anything is fine. After that, there should be a lag time. Very, very important. At least 1 week should be there. 1 to 3 weeks of lag time. Then you have hematuria. Diagnostic of PSGN. I don't even want microscope. If they're asked, what do you see in the microscopy of PSGN? If they ask that, microscopy you see, I'll have more cells inside capillary. I'll name that, that's all. Endocapillary hypercellularity. It's just endocapillary hypercellularity, that's all. Right? What do you see in immunofluorescence? So I'll see both IgG and the most importantly is C3. C3 will be deposited granular in the IF, and electron microscopy is a classical finding of this. See, it will not be seen throughout. Suddenly there will be a deposit. We call it an subepithelial hump-like deposit. So subepithelial hump, again classical for PSG and PIGN, right? It looks like a hump. Suddenly, subepithelial there will be a hump-like deposit, classical. Treatment is simple, symptomatic, wait and watch, automatically come back. One more important thing, because C3 is being consumed here, what happens is serum levels of C3 will be reduced. That's also a classical clue for a PSGN or a PIGN, right? PIGN is post-infectious, PSGN is post-streptococcal. That's all. Fine? Done. Now look at this. If you compare this guy with the normal, see normal, I told you, that's how maximum mesangium can be. But look at this image. The mesangium is too much, na? That's mesangial expansion, right? So this is primarily for your Berger's disease. What's the other name for Berger? It's your IgA nephropathy. Classical history. Here also I can have URA, I can have UTI, I can have diarrhea, any mucosal involvement. But the most important thing is second day itself, you'll have hematuria. There'll be no lag time. That's one important difference between this and PSGN. No lag time, IgA nephropathy, lag time there, PSGN. That's all. Both can have same history. URA can be there, UTA can be there, right? What do I look in the microscopy? Like if we saw first, there'll be an expansion of mesangium. Mesangium will be expanded. And the most important thing is your immunofluorescence. The place is important. IgA is obviously important. There'll be an IgA deposit, nothing else, only IgA, and it will be in the mesangium. Even electron microscopy deposits will also be in the mesangium. Everything here goes to the mesangium, and the problem is in IgA, right? IgA deposit has to be an IgA nephropathy. Don't worry about the image. If I am giving this image, the question will say it's an IgA deposit because every image is green. No one can say it's Ig or IgM. So question says IgM, write IgA nephropathy, as simple as that, right? Last couple of them. It's a spotter. Can anyone tell me what this is? That's your crescent. Crescent, or we call it an RPGN, right? How do I pick up RPGN clinically? If there's a history, let's say creatinine is 2 milligram today, and it became creatinine of 9 milligram percentage in less than 24 hours. That's rapid. It should be maximum 1 or 2 days. The progress, if it's happening in 1 month, today creatinine 1, next month creatinine is like, or next week creatinine is like 5. It's not rapid. The progression is important. Rapid progression within 24 to 48 hours. If the progression is rapid, then I call it RPGN, rapidly progressive glomerulonephritis, right? The reason is simple. The pathogenesis starts with the electron microscopic finding, break in the basement membrane. Once a capillary breaks, glomerulus is gone. Glomerulus is nothing but capillary, right? It will not function. I have a deterioration. That's how it is, right? I have 3 types of RPGN. The types is based on your IF. Type 1 RPGN is linear IF, which is only Goodpasture syndrome. Okay. Type 2 RPGN is granular IF, which is rest everything of the glomerulonephritis. Type 3 is called as pauci-immune, no immunofluorescence or absent immunofluorescence, which is seen in vasculitis like vaginas, microscopic polyangiitis, right? It's not diagnostic of primary kidney disorder. It's a primary vessel problem, right? That's about RPGN. This is common in exam once. A rapid progression with an electron microscopic image, they ask the diagnosis. It's RPGN. This is important. It should be in this timeline, not in a week or in a month or a year. Within a day or 2, progresses, definitely RPGN, right? Last but not least is this guy. Sclerosed. Half of the glomerulus here is completely gone, right? FSGS. Focal segmental glomerulonephritis. Most common cause of nephrotic syndrome in adults. Microscopic finding of almost any CKD. Any CKD end point may allow fibrosis only. That's what FSGS stands for. It's an end stage. Based on the amount of fibrosis involved, automatically I'm going to replace the kidney at some point of time. It's not working. 80-90% glomeruli undergo fibrosis, dialysis, or a renal transplant. That's why, fine. That's about FSGS. Okay. Few more spotters in kidney. Can anyone tell me what this is? This is spotter. I'm sure you'll tell. Last slide. I'll give you definitely good enough time for you to go and have your lunch before Jesse sir can come and join. That's onion skinning, right? Onion skin lesion is classical for malignant hypertension. Okay. Malignant hypertension, onion skin is classical. Perfect. This is your hyaline arteriolosclerosis. Onion skin other name is hyperplastic arteriolosclerosis. This is hyaline arteriolosclerosis. This is seen in benign nephrosclerosis or benign hypertension. Fine. This hypoplastic. Okay, and this is the one which I already told, your KW nodule, a nodule lesion in the glomerulosclerosis, diagnostic of diabetic kidney disease. Fine. Okay. This might come because these spotters keep on coming without even a question, right? Just they'll ask you a spotter and what it is. Again, a spotter, ADPKD, autosomal dominant polycystic kidney disease, where you'll have cysts. The most important thing is on outer and cut surface. ARPKD on the other hand, see, if my age is given, it's easy to diagnose. If age is not given, here outer surface will be smooth. Only cut surface will have cyst. Okay, C bar S is the cut surface. Will have cyst, that's ARPKD. Obviously, age is the important clue here, right? One more associated finding which was kept on coming in an exam is it's associated with your berry aneurysm. Obviously, cyst throughout the body it's associated. Here also you'll have cyst in the liver, pancreas, everywhere. In brain you'll have berry aneurysm, and here one of the associated finding is hepatic fibrosis. ARPKD is little bit difficult in prognosis compared to the ADPKD. ADPKD presents at 40-50 years, decent. ARPKD might even kill the child. Fine. Okay, that's for your path revision, right? I had to kind of rush up the systemic pathology. I hope you will, if you have any doubts, do let us know. Not going to give any gyan. So I have 100% trust in you that you will do well. Only thing is, don't be tensed. You're prepared well. Anyone who's prepared well will do well. That's how the world works. If you're not prepared well, you won't do well. That's how the world works. Luck, your seniors might tell, but I always trust that luck favors the mighty. If you're good, luck will also follow. Go ahead. The only thing is, sleep early. Change your sleep pattern from today, so the next 1 week will be perfect. You sleep early, 9-10 maximum, right? Because you have a very long day in the FMG exams, 2 sessions. You'll be exhausted if you don't sleep well, right? Sleep well, you will do well. All the very best, guys. Take an half an hour break. 3:30 Jesse sir will start the class, and I hope you'll enjoy dermatology, and you'll have Jambul Kasar taking my biochemistry as well. Fine. Thank you, guys. Bye bye.
Good afternoon, everyone. I hope I'm audible and visible. Can you please confirm this in the chat box? Thank you so much. Voice is not. So voice is not clear. Can you please confirm that if my screen as well as my audio is all fine? Yeah, it's fine. Right. Thank you so much. So, okay, welcome to this FMG marathon today. And I'm Dr. Jazir, and I will be doing your dermatology sessions. I hope all of you had a nice time learning pathology. And now let's shift into the skin, right? Let's shift to the skin. Thank you so much for all the confirmation. And the idea here today is we'll be having around 2.5 hours of session in dermatology because I have almost 40 or 41 plus pages to cover. And whatever major images that I've added to the workbook today, that is all based on the previous year question pattern and all, so that we don't miss the most important topics that is necessary just before going for your exam, right? And let us think that it should be like a quick revision about whatever you have learned. And in between, if you have any doubts, please feel free to drop a message in the chat box and I'll be happy to respond to you. Okay, with your permission, so let me begin with this session. And what is the first image that you can see in the screen right now? You can see that there is something like this, which has a very typical shape like this. It is compared to something. And can any one of you answer in the chat box like what is this? Please remember that here the first image that I'm showing you in this workbook here is this is called as the Langerhans cells, isn't it? This is called as the Langerhans cells. So in the skin, these Langerhans cells, they are seen in the stratum spinosum. It is seen in the stratum spinosum. Excellent, Shamsu, Shekhar, Saf, all of you are answering it. So this is seen in the stratum spinosum. And this image that you see, the most important idea that you should have is when you do a normal microscopy, this Langerhans cell, it never appears like this. It appears something like your fingers. Like these are going to be dendritic cells on a normal microscopy. This appears to be a dendritic cells in a normal microscopy. Whereas when it comes to an electron microscopy, when it comes to electron microscopy, this image, it actually reflects the electron microscopic image of a Langerhans cell. Okay, please don't make a mistake. Normal microscopy finding of a Langerhans cell is dendritic cell, whereas electron microscopic image is this image. And as all of you have mentioned in the chat box correctly, this is called as the Birbeck granules. It is called as the Birbeck granules, or because of the shape, we also compare it as tennis racket cells, isn't it? We also compare it to a tennis racket. So that is the first point that we have discussed in today's session. And moving further, if you have noticed the previous year topics or the previous year questions, you can see that a lot of questions are coming from various investigations. Now let us see one of the investigation. Now what is the investigation that you're seeing in this image? Because it is written tinea capitis, green color, Pityriasis is versicolor, pale yellow to apple green. What is this investigation? Erythrasma, oral red color. So this is one question which was asked for the FMG exam, right? So any one of you can answer what is the name of the investigation here and why these colors are mentioned for respective diseases. Remember, this investigation is called as a Woods lamp. So in a Woods lamp examination, when you are going to turn on a Woods lamp over a diseased skin, some diseases may reflect some colors, and these colors will help us to reach a diagnosis. इसीलिए tinea capitis में you can see a green color if it is caused by microsporum. Pityriasis versicolor may also give you a green color or a yellow color. Erythrasma will show you a coral red fluorescence. So all these are the important table that you should remember in terms of a Woods lamp examination. Now let's see one more. Shagufta, Parul Patel, Vipul Saini, all of you, excellent. Okay, that is the right answer. It's a Wood Slam examination. Now, how about this investigation? यहाँ पे I have given you some names of diseases. जैसे dermatophytosis में fungal hyphae can be seen, candidiasis में pseudo hyphae can be seen, and pityriasis versicolor you can see a hyphae and spores, which is compared to banana and grapes, which is compared to spaghetti and meatballs appearance. अभी ये कौन सा investigation है जहाँ पे you can see all these findings, and again prefer if you make this session more interactive. If you answer whatever you can recollect, it is better that you answer to me in the chat box, right? So यहाँ पे what is this investigation? Anyone? Yeah, this is called as the potassium hydroxide test. So please remember that very good Shagufta. This is called as the KOH or skin scraping test, है ना? ये potassium hydroxide test is the investigation of choice whenever you are going to suspect what kind of a disease? Superficial fungal infections. Superficial fungal infections. So Vipul and Parul Patel was also answering it right. So यहाँ पे please keep one thing in your mind. If the question is going to make you feel that this is going to be a fungal infection, if it is a fungal infection, then always, be it a hair infection, be it nail infection or a skin infection, then you definitely need to mark it as potassium hydroxide test as a takeaway message. Clear? Now let us see one more test. Now what is this test? If you want, I can just zoom this image for you. In this test, what you can see is this patient has developed some vesicles just below the lips, है ना? So whenever you see these vesicles underneath the lips, there is an investigation that you can do. Or let us say this is the investigation done in vesiculobullous diseases. So in vesiculobullous disease, we can do this investigation where we are going to de-roof a vesicle or a bulla, and we will collect the contents of this vesicle into a glass slide. Now, what is the name of this test? This test is called as a Zank smear. This test is called as a Zank smear. Very good, Sagufta. So यहाँ पे ये जो Zank smear है, this can be done in any case where there is a vesicle or a bulla in the body, right? So if there is vesicle or bulla, there are two different findings. Now we'll talk about the findings and the image here. When you do a Zank smear, if it is going to be some infections, okay, if it is going to be some infections, we expect multinucleated giant cells. Multinucleated giant cells. So यहाँ पे which one is a multinucleated giant cell? This one. Okay, in infections like HSV or varicella or herpes zoster, we can expect a multinucleated giant cell. Now in the above image, you can see that the cells, they become almost rounded cells and there is a large nucleus inside. Now when you see something like this, that is seen in pemphigus group of diseases, which is also called as acantholytic cells. Now the takeaway message here is, if you do a test called Zank smear में there are two findings that you can expect. एक हो गया multinucleated giant cells if it is an infection. The second one would be acantholytic cells if it is a pemphigus group of diseases. Clear? So moving further, now what is this investigation that we are talking about? It's a very simple test. पता है ये टेस्ट में हम क्या कर रहे हैं? इस टेस्ट में we are just going to press the skin with a glass slide. Now simple test है, right? We take a glass slide, we are going to press it over the skin to see some difference. जैसे the first image में क्या दिख रहा है यहाँ पे? This kind of a color change that happens when you press over the skin. This one we call it as blanching. We call it as a blanching. Now what is the name of this test? This test is called as diascopy. It is called as diascopy. Okay? And this diascopy, in this diascopy, what you can see is, again, there are a lot of implications of doing a diascopy. Like if you want to differentiate between erythema and a purpura, ये image हो गया एक petechiae या फिर purpura, isn't it? So when it is erythema, the skin will blanch. Okay, that is the first point. When it is a petechiae or a purpura, जहाँ पे extravasation होता है of the blood, isn't it? There you will not find any blanching. In tuberculosis of the skin, जैसे lupus vulgaris, you can see apple jelly nodules. Sarcoidosis में you can see sago grain appearance. And in nevus depigmentosis, it will not blanch क्योंकि ये एक pigmentary disorder है. And nevus anemicus, this is a capillary defect. So if it is a capillary defect, then the lesion will blanch. So all these things, very good, Vipul. So all these things can be correlated with this test called as a diascopy. Now let us see another. Now this is another thing which was asked, especially in the last to last NEET PG exam. This question had come. Like you will be given an image like this, and you need to identify ki what is the skin line. When you see the skin line, are you able to say ki what is the skin line? In the skin, कौन से lines होते हैं? Yes, excellent. Excellent. This one is called as Blaschko lines. Okay, this is called as Blaschko lines. So in Blaschko lines, they are actually invisible cell development lines. But if you want to identify Blaschko lines, हम इसको identify कैसे करेंगे? Because when you are able to spot, one simple trick is, if you are able to spot this V-shaped pattern in the center, this could be a Blaschko line. It's a simple trick that which you can use to identify a Blaschko lines. Very good, Saf, Shaker, Gauri Saha, all of you are answering it right. And remember 3 diseases जहाँ पे we can see a Blaschko lines. That is hypomelanosis of ito, incontinentia pigmenti, and epidermal nevus. You can remember it as HIE. Okay, you can remember it as HIE. There is one more line which was a NEET PG PYQ. Okay, which was asked in a NEET PG exam. Now, इस line को मैं थोड़ा zoom करता हूँ. In this line, what do you find here? When you compare it with the Blaschko line, यहाँ पे कोई V pattern नहीं है, right? And most of these lines, they are arranged quite parallelly, isn't it? So they are arranged parallelly like this. When you see a parallel arrangement of these lines, this is called as Langer's lines. So this is called as a Langer's lines. Now Langer's lines, more than dermatology. Very good, Roja, Gauri Saha, all of you are answering it. ये जो Langer's line है ना, this is more important for a surgeon. क्योंकि whenever you are going to do an incision, you always want to give an incision which is parallel to the Langer's lines. Want to give an incision parallel to the Langer's line. So then what happens? There will be a better wound healing and less chances of scarring. So these are 2 very important lines that you can remember. Now talking about some of the hair disorders, you can expect an MCQ like this. Keep all of the following are scarring alopecia except, right? So first you should understand which are the examples of a scarring alopecia, which are the examples of a non-scarring alopecia. अभी इसमें scarring and non-scarring नहीं बता रहे, but remember non-cicatricial means this is non-scarring, whereas cicatricial means it is the scarring alopecia. So these are interchangeable words. दोनों का meaning is the same, right? Non-cicatricial alopecia or non-scarring alopecia. और यहाँ पे how do you remember it easily? You can remember it as ATA. Okay. So anything that starts with A or T is going to be non-scarring alopecia. जैसे androgenic alopecia, alopecia areata, trichotillomania, telogen effluvium, anagen effluvium. So please remember ATA for non-scarring alopecia. It is also called as non-cicatricial alopecia. Whereas scarring alopecia examples आपको याद रखना पड़ेगा, जैसे discoid lupus erythematosus, lichen planus. Lichen planus में scalp involvement जब होंगे, we call it as lichen planopilaris. Kerion is another fungal infection, pseudopelade of Brock, and folliculitis decalvans. All these are examples of cicatricial or a scarring alopecia. Now that we have started discussing about alopecia, can you correlate these three images and tell me one single diagnosis? क्योंकि ये तीनों images it's actually based on a single diagnosis. Anybody in the chat box? क्या हो सकता है? Because for me, what I can see in the first image is यहाँ पे ना एक patchy hair loss है, right? यहाँ पे I can see there is a patchy hair loss. And यहाँ पे also you can see there is another patchy hair loss. This is one. Second image for me, it looks like something like a microscopy. So when you do a microscopy of the hair, इसको बोलते हैं trichoscopy. So this is called as trichoscopy. So in this trichoscopy, what I can see is can you identify that यहाँ पे ना thickness ज़्यादा है, and then it becomes smaller like this. Now this is compared to something like this in reality. This is called as exclamation mark hair. It is called as a exclamation mark hair. और जो last image है यहाँ पे again I can see there is a patchy alopecia यहाँ पे, or there is another patchy alopecia in the second part, right? Now this is called as turning gray phenomenon. Why do I call turning gray? क्योंकि यहाँ पे the entire black hair in the patchy alopecia is lost and gray hair is retained. Still, the patient feels that there is a lot of graying of my hair. That is why we call it as a turning gray phenomenon. Now, till now, I did not tell you the diagnosis. Now, tell me patchy alopecia, exclamation mark hair, turning gray phenomenon. This exclamation mark hair is a PYQ. It's a PYQ. So, where do you find them? Yeah, I guess I already have the answers here. Excellent. A lot of you have answered. Vipul, Shamsu, Parul, Gauri Saha, Shekhar, Anirudh, Saf. Very good. So Vipin, so this one is called as alopecia areata. Please remember all these features that you can see in alopecia areata. Okay? So now let us see one of the nail findings here. So यहाँ पे ना the two types of nail findings are given. So what is this nail finding? In both the nail finding, you can see that there are some depression in the nails. So whenever there are depression in the nails, we call it as nail pitting. We call it as nail pitting. There are two types of nail pitting. One is regular and shallow. ये जो first image है ना, यहाँ पे you can see a very regular nail pitting. है ना, this is like very regular. So this regular nail pitting is one. Second one, यहाँ पे ये जो है, this is very irregular, isn't it? So the second one is irregular and deep kind of a nail pitting. Where do you find regular and irregular nail pitting is very important for your exam. Regular and shallow nail pitting. Very good. Vipin, Shekhar, excellent. So यहाँ पे Parul, Gauri Saha. Regular and shallow is seen in alopecia areata, and irregular and deep, this is seen in psoriasis. This is seen in psoriasis. Okay? So these are the basic differences when it comes to nail pitting. So now let's see more of the nail images. What do you see in the first image? मुझे क्या दिख रहा है ना इसमें? There is a gray color or a whitish line that is present over the nails. ऐसा. So once you find a white line over the nails, Is there any name for this kind of a nail finding? This nail finding? Yeah, यहाँ पे we call this one as leukonychia, or let us say, very good, this is called as Mies lines. Excellent. Roja is answering, Shamsu is answering. It's very good to see that you guys are able to recollect things, isn't it? Just few days for your exam and you are able to recollect these things is very good. Very, very reassuring. Now, when you find these Mies lines, it is usually associated with some poisoning. Concept poisoning, it can be associated with arsenic poisoning or thallium poisoning. Clear? Now let us see another image which is below. In the second image also you can see that the nails are turning white in color. And here all this region has turned white in color. But this is mostly because of a fungal overgrowth. So इसीलिए we call this one as a pseudo leukomycia. Pseudo leukomycia. पहले जो हमने अभी भी सीखा था ना ये Mies lines, this is an example of a true leukonychia. This is an example of a true leukonychia, and this one is called as a pseudo leukonychia. It is usually due to overgrowth of a fungus. It is usually due to the overgrowth of a fungus. Clear? Yes. Again, Shekhar, Gauri, all of you are answering it. Vipul, isn't it? So now let's see few more nail findings. Spot diagnosis हो जाएंगे. Now यहाँ पे what is the finding that you can see? For me, I can find that all these areas में there is a parallel white bands like this. So when you see multiple parallel white bands, this is called as Muir-Keys lines. ठीक है? And please remember, Muir-Keys lines is associated with chemotherapy or hypoalbuminemia. It is associated with chemotherapy or hypoalbuminemia. Lindsay nail, not yet. ठीक है? देखते हैं कि what is Lindsay nails. Let's see the next one. In the next one, what is the finding here? So if I just go logically, so whenever you see this image, you always try to describe the image. Okay? So in this image, I can see that this is the entire nail, right? Now, this much of the nail has turned white in color. This area has turned white in color. Can you see that? This area. Now, this is called 50% of the nails turning white. See this nail also, 50% of the proximal part of the nail has turned white. This is called half and half nails. So this half and half nails has one more name. It is called as Lindsay nails. And this is associated with chronic renal disease. जैसे renal failure हो सकता है, isn't it? Any chronic kidney disease can show half and half nails or Lindsay nails. Very good. Excellent. Now let us see the last one. So in this last one, can you identify कि यहाँ पे only 50% is there? नहीं. Entire nail has turned white in color, right? So this type of a nail is called as terry nails. So in terry nails, the most common association is with hepatic failure. So this is associated with hepatic failure. And now let's move further. Now what about this nail finding? यहाँ पे the thing is that I can find that there is a yellow discoloration over the lateral nail fold. This yellow discoloration over the lateral nail fold is called as paronychia. Paronychia. Painful हो सकता है ना? क्योंकि what is this yellowish discoloration? यहाँ पे जो yellow discoloration that you can see, it is going to be pus. So whenever there is pus, it is going to be painful. Abscess है ना? So we'll have to do the treatment of a paronychia should be incision and drainage, isn't it? And let us see the next one. In this next image, I'll just zoom it so that it is more clear for you. So in this image, the entire shape of the nails has changed. This can be compared to a spoon shaped nails. Now spoon shaped nails, this is another PYQ which was asked for your exam. Jैसे the same kind of an image was given for FMG exam, and the exam question was how will you treat this patient. अभी treatment के लिए पहले what is the name of this nail? It is called as कोइलोनाइकिया. And what is the association of कोइलोनाइकिया? This is associated with iron deficiency anemia. इसीलिए in that MCQ which was asked for your exam, the examiner asked you what is the treatment. One of the option was iron supplementation. Clear? Iron supplementation. Very good. Shekhar, Anirudh, who is answering. Now let us see one more image. I mean, in both the image, what is common for me is both are in the axilla. Both these images are showing that there is some lesion in the axilla. In the first image, you can see that there is some scarring and there is some connection in between the skin. So these kind of interconnecting bridges, when you see, that is seen in a disease called as hidradenitis suppurativa. Hidradenitis suppurativa. In the second image, what I can see is there are multiple papules right in the axilla. So when you find papules in the axilla, now your diagnosis is different. It is called as Fox Fordyce disease. It is called as Fox Fordyce disease. Now, what you have to think about is on the day of the exam, when you see an image in the axilla mein what can be the causative? Because yahan pe the reason is in the axilla, what is the type of sweat glands that you can see? You can see apocrine glands, isn't it? Apocrine sweat glands. So in the apocrine sweat glands, these are two diseases which is going to affect the apocrine sweat gland. एक हो गया interconnecting bridges which can be seen, that is in hidradenitis suppurativa. And whereas when you see papules in the axilla, then think about Fox Fordyce disease. When I say Fox Fordyce, then you will remember something else as well. Because that thing we call it as Fordyce spots. Okay, Fordyce spots. So this Fordyce spots, please remember that Fordyce spots can be seen in the lips or in the genitalia. But Fordyce spots is not a condition of apocrine sweat glands. It is due to ectopic sebaceous glands. I don't have an image today, but please remember, lip पे होते हैं, ठीक है? Yeah, Anirudh, all of you are answering. Excellent. I hope you are very able to correlate. I just said Fordyce यहाँ पे, reason is यहाँ पे भी Fordyce है, यहाँ पे भी Fordyce है. Fox Fordyce is a disease of apocrine sweat gland. Fordyce spots is a condition of ectopic sebaceous glands. Very good. Rocha, Vipul, all of you. Now see, we have 1, 2, 3, 4, 4 images here. So in all these 4 images, you know that the diagnosis is acne vulgaris. Now in acne vulgaris, I'll just zoom this. ये जो पहले ये जो दो images है ना, all both these things. Here you can see the color is black. Here you can see that the color is white. So these are either black heads or white heads. What is the name of this lesion? These lesions are called as comedones. And please remember, comedones is seen exclusively in acne vulgaris. अगर आपको कोई भी MCQ में, if there is this magic word जो लिखा है that the patient presented with comedonal, papular, pustular, nodulocystic lesions, in the entire thing, the moment you see this magic word comedones, always answer it as acne vulgaris. Clear? And second thing is, talking about the treatment of acne vulgaris, जो सबसे important है, the drug of choice for all types of acne except severe acne. जैसे ये हो गया severe acne, right? Except in severe acne, your answer should be topical retinoids. Okay, the answer should be topical retinoids. And in case of severe acne, that is the place where instead of applying a cream, we will give them tablets. So here this is called as isotretinoin. So topical retinoids can be used in all the other types, and in severe cases you will have to go for oral retinoids. Oral retinoids. Yeah, many of you are talking about doxy, clinda, isn't it? हाँ, ये सब यूज कर सकते हैं, doxycycline, clindamycin, minocycline. But when we talk about drug of choice is always retinoids. आपको बस इतना डिसाइड करना है कि टॉपिकल यूज करना है या फिर ओरल. प्लीज गो फॉर टॉपिकल इन ऑल द टाइप्स एक्सेप्ट सीवियर. सीवियर में क्या यूज करेंगे? सीवियर में वी गो फॉर ओरल रेटिनॉइड्स. ये frequently repeated question है. Okay, so this is one area where the concept should not be confusing. ठीक है. एंड ये जो ओरल रेटिनॉइड्स जैसे आइसोट्रेटिनोइन का बहुत साइड इफेक्ट्स भी होते हैं. व्हाट आर द साइड इफेक्ट्स? वन इज ड्राइनेस ऑफ द लिप्स. तो ड्राइनेस ऑफ द लिप्स वी आर नॉट वेरी कंसर्न्ड क्योंकि easily manageable है. You can apply some lip balms and all. But there is another side effect which is called as teratogenicity. Now this is very concerning because we never want a baby to be born with some, birth defects, right? So this teratogenicity period of isotretinoin is for 1 month. Please remember, 1 month. Other than that, there are many other side effects also. We can list a few like dyslipidemia. Patient का जो cholesterol profile है, it can all get disrupted. There can be depression in some of the cases, and some cases may also report night blindness as well. So all these things are different side effects of isotretinoin. Clear? So now let's see these two images. In these two images, we are going to discuss about something which is called as contact dermatitis. Okay, by the name itself, all of you know कि contact dermatitis क्या होता है? When there is a contact with any substance. If the patient is going to develop an eczematous rash at the site of contact, तो बोलते हैं contact dermatitis. There are two types of contact dermatitis. एक हो गया irritant contact dermatitis. Second one is allergic contact dermatitis. है ना? Remember one thing, irritant contact dermatitis, just इतना याद रखना कि detergents, क्योंकि this is the most common cause. So detergents या फिर dish wash और hand sanitizers जो भी use कर रहे हैं उनको, what is the kind of symptom that they will have after using detergent? The patient says, my skin has become very dry. After using hand sanitizer, skin becomes dry and itchy. This is called as irritant contact dermatitis. For this eczema, we also call it as a housewife's eczema. And for your exam purpose, I would say everything else is allergic contact dermatitis. You will not find this, but I'm just writing it like this for you to understand or easily correlate. सिर्फ इतना याद रखना, detergents, dishwash, sanitizers, ये all these three examples are irritant contact dermatitis. Everything else, for the exam they will give you a plant like Parthenium hysterophorus, that is also called as a congress weed. Nickel dermatitis, cement dermatitis, cosmetics dermatitis, footwear dermatitis, wristwatch dermatitis, bindi dermatitis, henna dermatitis, all these things are going to be allergic contact dermatitis. So please remember these two very important points. Now, what is this plant? So these are few examples right now. This is the plant which I told you just now, which is called as the congress weed. This is also called as Parthenium hysterophorus. So why do we learn about Parthenium hysterophorus in dermatology? because this also causes allergic contact dermatitis. In fact, this is the most common cause of allergic contact dermatitis. Okay? And if you get this image for your exam, what will be your diagnosis? Over the forehead, यहाँ पे एक eczematous rash can be seen. This is going to be Bindi dermatitis. And as I told you, Bindi dermatitis, ICD या ACD? Answer is this is also ACD. This is also ACD. Clear? Now let's see this one where a patient's trunk is being shown and there is some erythematous plaque lesion. Right? There are so many small erythematous plaque lesion in the trunk. Now, which is the type of psoriasis? This could be, so whenever you see this kind of an image, your answer should be acute guttate psoriasis. The answer should be acute guttate psoriasis. And because of multiple small erythematous plaques, we also call it as raindrop psoriasis. We also call it as raindrop psoriasis. Okay? And the second image, what you can see here is, you can see that there is a well demarcated erythematous plaque lesion here, right? Here the red color plaque can be seen here. But just above the red color plaque, you can see that there is a silvery white scaling as well. So this is a typical appearance of a psoriasis rash. Okay? It should look something like this. So with this type of an appearance, we call it as chronic plaque psoriasis. And in chronic plaque psoriasis, this one is the most common. इसलिए we call it as psoriasis vulgaris, where the patient will present to you with erythematous plaques with silvery white scaling, on extensor surfaces, because extensor surfaces are more common when it comes to psoriasis vulgaris. Okay. Very good. So all of you know how to identify a guttate psoriasis, and right now you're telling about chronic plaque psoriasis as well. Excellent. So now let us see two more types of psoriasis. In case the psoriasis lesion is only seen over the palms and soles like this, then we can call it as palmoplantar psoriasis. Whereas rarely, if you can find a psoriatic plaque like this over the flexural areas, जैसे axilla, isn't it, body folds में, in such cases we can call it as inverse psoriasis or flexural psoriasis. Inverse or flexural psoriasis. So why are you answering it as pitted? यहाँ पे कोई pitting नहीं है. I'll just zoom this image for you. You can see that there is a well demarcated erythematous plaque with some scaling. That is the inverse psoriasis or flexural psoriasis. अच्छा, pitted keratolysis बोल रहे थे आप. हाँ, यहाँ पे pitted keratolysis can be a differential diagnosis. I agree. Thank you. So after talking about the plaque type of psoriasis, there are some types of pustular psoriasis as well. So when it comes to pustular psoriasis, it can be either localized pustular psoriasis. I mean, when I say about localized, where is it localized to? It is localized to the palms and soles. It is localized to the palms and soles. Whereas there is one more thing where the pustules can be generalized throughout the trunk. This is called as generalized pustular psoriasis. This is called as generalized pustular psoriasis. In generalized pustular psoriasis has one more name. So please remember, it is also called as von Zombush reaction. It is also called as von Zombush reaction. So these are the two types of pustular psoriasis. See, both are pustular psoriasis. Localized भी हो सकता है, generalized भी हो सकता है, right? Now, in psoriasis, there is one typical scenario where more than 90% of the body surface area, it turns red in color. Along with that, there would be massive scaling as well. So if you get such a clinical scenario for your exam, what is this? Psoriasis patient was having some plaque lesions with silvery white scaling. Abhi 90% of the body has turned red in color and there is massive scaling. This is called as psoriatic erythroderma. So this is called as psoriatic erythroderma. Okay? It's considered to be a dermatological emergency. Because all of you know that we don't have too many emergency in dermatology. This is one of the dermatological emergency which is called as psoriatic erythroderma. Talking about the nail changes. So when you talk about nail changes in psoriasis, I'll give you a trick or a mnemonic to remember the nail changes in psoriasis. Remember it as POISON. What is it? Poison, right? POISON. Where P stands for nail pitting. P stands for nail pitting. OI is this image. Okay, this image is OI. It is oil drop sign. This image was asked for your exam. This is another PYQ. Whereas S stands for subungual hyperkeratosis. Subungual hyperkeratosis. O, it stands for, O is this one. This stands for onycholysis. When the nail gets separated from the nail bed, it's called as onycholysis. And N stands for nail plate dystrophy. N stands for nail plate dystrophy. So all these are the nail findings that you can see in psoriasis. Okay? In psoriasis, there is one very important clinical sign. Just imagine that I'm taking a glass slide. I'm going to scrape over the psoriatic plaque. जैसे यहाँ पे अगर psoriatic plaque is there, I'm going to scrape it. So once you scrape it, what happens? You can see that there are multiple pinpointed bleeding spots that can be seen. What is that called? No, pterygium is seen in Lichen planus. Okay, Shekhar. We will talk about Lichen planus in some time. I'll show you the image as well. So this test is called as Auspitz test or Auspitz sign. Let us say Auspitz sign, which shows pinpointed bleeding spots on scraping the lesion. Pinpointed bleeding spots on scraping the lesion. Now, Shamsuzzaman was talking about the Grattage test. Let us write down about Grattage test as well, because as I remember, Grattage test was also one of the PYQs, isn't it? In dermatology. What is the meaning of a Grattage test? Saying अगर यहाँ पे एक psoriatic plaque lesion है and you're going to take a glass slide, if you're going to scrape over the lesion, the scaling becomes more visible. इसको बोलते हैं accentuation. Accentuation of scales on scraping the lesions. This is called as grattage test. This is called as grattage test. Clear? Okay. Any idea what is this phenomenon? You can see that it looks like somebody has scratched over the skin. After scratching, the patient developed two linear erythematous plaque lesion in the trunk. Now, this is called as Koebner or isomorphic phenomenon. What is the meaning of a Koebner or a isomorphic phenomenon? This means that new lesions appear at the site of trauma. At the site of trauma. And please remember for your exam, there are three diseases where you can see Koebner phenomenon. You can remember it as LVP. So what is L? L stands for Lichen planus, V for vitiligo, and P for psoriasis. And P for psoriasis. Okay? Yes, all of you are answering it. Isomorphic and Koebner. Very good. So now let's talk something about pityriasis rosea. See, in pityriasis rosea, what happens is patient may come to you with multiple erythematous plaques. But in this image, can you see that this is the largest lesion? You know? And this largest lesion has a name. What is the name? This is called as mother patch or herald patch. After that, what happens? The entire lesions which will develop after the mother patch are going to be smaller lesions. And there is a peculiar pattern for this lesion, which is called as Christmas tree pattern as well. It is called as a Christmas tree pattern. So if any question is coming like a patient developed multiple erythematous plaques in the body, out of which the first lesion is the largest lesion, followed by smaller eruptions in a Christmas tree pattern. That is going to be pityriasis rosea. That is going to be pityriasis rosea. In the next image, you can see that this is wrist area, which means you can see that the lesions are in the flexures and the color is not red. You know, this does not look like red. The color is purple colored or a violaceous lesion. So whenever you see a purple or violaceous plaque lesion, then always think about this diagnosis, that is lichen planus. And always think about this diagnosis, that is lichen planus. कहीं पे भी अगर mention है purple colored plaque lesions, purple colored itchy plaque lesions, violaceous lesions, 90% of the instances the answer should be lichen planus. अभी lichen planus में जो scaling होता है वो psoriasis जैसे नहीं है, right? क्योंकि psoriasis में क्या होगा, entire lesion will be covered with silvery white scaling. But यहाँ पे you can see that there is some white lacy reticulate pattern. ये जो white lacy reticulate pattern है, we call it as Wickham's stripe. We call it as Wickham's stripe. Okay, that is how you can identify the lesions in lichen planus. In lichen planus, sometimes what happens is there can be a oral lichen planus. This oral lichen planus will also present to you with this white lacy reticulate pattern like this. Patient का primary complaint ये होगा कि there is some burning sensation in the oral mucosa. But this is a very important finding for you, very probable question as well. Reason is, this is a pre-malignant lesion. So what can it be pre-malignant to? क्या ये प्रोग्रेस हो सकता है टू मैलिग्नेंट मेलानोमा या स्क्वामस सेल कार्सिनोमा या बेसल सेल कार्सिनोमा? This may progress to squamous cell carcinoma. Okay, please remember squamous cell carcinoma. In lichen planus we have already discussed कि lichen planus में hair findings हो सकता है. यहाँ पे जो patchy alopecia है, this is going to be a scarring alopecia. So in our list of the table जहाँ पे हमने डिस्कस किया था स्कारिंग या सिकैट्रिशियल एलोपेशिया, उसमें लाइकेन प्लानस भी है, isn't it? So yes, yeah. So whoever is answering, excellent, very good. All of you are answering that. Vicam striae, all of you remember. Squamous cell carcinoma, all of you remember, isn't it? Excellent. And earlier somebody was asking कि pterygium कहाँ पे होता है, isn't it? This is the pterygium that you can see. So this is pterygium where there is a wing shaped extension of the nails, and this pterygium is also seen in lichen planus. It is also seen in lichen planus, and lichen planus mein there are a lot of other nail findings also, like nail thinning is the most common nail change in lichen planus. Okay, nail thinning is the most common nail change in lichen planus. So now let's talk about another condition which is called as urticaria. So what happens in urticaria is patient will always complain of a certain lesion. And what is the name of the lesion? This lesion is called as wheals, okay, or hives. So these wheals or hives have also been asked. Usually what happens, imagine that a patient has taken seafood, or he had a change of environment, or he consumed some fruit juices. After consuming all these things, the patient may develop an allergic reaction. And this allergic reaction, if there is some edematous lesion in the skin, these are called as wheals or hives. It is going to be extremely itchy. So what was asked for your exam is, what is the primary management of urticaria? So please remember that in urticaria, the drug of choice is antihistamines. तो इस टॉपिक को लेके एक इंटीग्रेटेड क्वेश्चन आया था, जहाँ पे द क्वेश्चन वाज लाइक देयर इज अ स्टूडेंट who developed urticarial wheals in the body, and since she is having exams in 1 week time, which is the preferred drug that you will give? क्योंकि antihistamines आपको याद है कि there are first generation antihistamines, second generation antihistamines. What will you prefer? You always prefer to give a second generation antihistamine in terms of a student, right? Because of the side effect of sedation. Sedation won't be there in a second generation antihistamine. That is the kind of question which was asked. Now see, this is another very important part. Now in this part, what you can see is there are some phenomenon. Just imagine that I'm taking my pen, the sharp object, and using the sharp object, I'm going to scrape over the lesion, isn't it? So once I am going to stroke over the skin, that area will develop a urticarial wheal. Just say if I'm writing your name in the skin, your name will develop as an urticaria. This one we call it as white. Sorry. So this one is not white. So this is called as red dermographism. And this red dermographism is seen in chronic urticaria. There is another type of finding where you can see that once you are going to stroke over the skin, that part of the skin may turn white in color, mostly because of a vasoconstriction. So this is called as white dermographism. And where do you find this white dermographism? This white dermographism can be seen in atopic dermatitis. It can be seen in atopic dermatitis. And the last one is called as black dermographism. It's not very common. This black dermographism can be seen in nickel dermatitis. It can be seen in nickel dermatitis. So all these things are called as dermographism. All these are called as dermographism. So now let's see this image. Now this is a very important sign. Last NEET PG exam या फिर INI-CT exam में this sign came as a match of following. Okay, so this is going to be another PYQ. So here what is happening is once you stroke over the skin, that area is going to have a flare reaction, right? So this is called as Darrier sign. So Darrier sign is seen in cutaneous mastocytosis, जहाँ पे mast cell का degeneration होता है. So in Darrier sign, this one is seen in cutaneous mastocytosis, also known as urticaria pigmentosa. It is also called as urticaria pigmentosa. And the last image, can anybody tell me what is the spot diagnosis? इसका spot diagnosis क्या हो सकता है? So let's say that a child suddenly develops a swelling over the lips. Yes, this is called as angioedema. See, in angioedema, remember that in children, angioedema is mostly due to some infection. Whereas in adults, angioedema can be because of some drugs. The moment I say drugs, which drug should come to your mind, which is the cause, which is causing angioedema? Yeah, this should be ACE inhibitors. ACE inhibitors can cause angioedema. So Anirudh, Saf, Gauri Saha, all of you are answering it right. That is going to be the spot diagnosis here. So in dermatology, you know that there are different types of erythema that you can find in the skin, right? So let us quickly recap what are the types of erythema that we know. When you see the first image here, this image, what would be your spot diagnosis? Because I can see that there is something in the center and there is a rim of erythema. There is something in the center, rim of erythema, center, rim of erythema. Any idea what comes to your mind? This looks like a target lesion or a bullseye lesion or an iris lesion. But the point that we are discussing right now is an erythema, right? So this is a very good Saf. This is called as erythema multiforme. So this is called as erythema multiforme. That is the first type of erythema. The second one, again, it looks again like a target. Because in the center, यहाँ पे एक erythematous rash is there. And then there is a large erythematous rim as well. But yet this lesion जो है, it is bit more bigger in size than a small erythema multiforme. Now, what is your answer? What is this kind of an erythema called? This erythema, please remember, it is called as erythema chronicum migrans. Okay, it's important. Erythema chronicum migrans. Where do you see erythema chronicum migrans? You can see them in Lyme's disease. Because of Borrelia burgdorferi. So this is called as erythema chronicum migrans. Erythema marginatum is mentioned in the chat box. Erythema marginatum nahi hai. Erythema marginatum may be this next one. Okay, which is a transient kind of an erythema. This transient kind of erythema is called as erythema marginatum. Where do you find erythema marginatum. You can also call it as erythema marginatum rheumaticum. So if I say rheumaticum, you'll be able to answer. You know? Yes, Gauri. So this is called as this seen in rheumatic heart disease. This seen in rheumatic heart disease. The next one is another image. Here you can see that there is some beautiful pattern that can be seen in the trunk of the patient, right? It looks like a cross section of a wooden plank. So बोलते हैं erythema gyratum repens. So this erythema gyratum repens, even though I called it as a beautiful pattern, it is not going to be a good news. It's a bad news. क्योंकि this is a marker of malignancy. Okay, it is a marker of malignancy. Which malignancy? It can be breast cancer or lung cancer. Breast cancer or lung cancer. And the last one, imagine that this is a child who had the child with complaints of fever and a red face. Child with fever, red face. Yeah, but what should be the diagnosis? Because if you want, I can give you the name of this, the erythema. The erythema is called erythema infectiosum. Erythema infectiosum. But can you tell me the name of the disease? This is seen in fifth disease. This is seen in fifth disease because this appearance is called as slapped cheek appearance. Isn't it? Parvovirus infection. That is a slapped cheek appearance called as fifth disease. Okay, fifth disease. So yes, I can see that Anirudh, Gauri, Saf, all of you are answering it as the right one. Good, step by step as well. Okay. So now moving forward, now let's see this one. So here you can see that both sides of the forearm is shown, and I can see that there is a well demarcated depigmented patches. So when you see this kind of an image, what should be your spot diagnosis? Your spot diagnosis should be vitiligo, which is an example of a autoimmune disease, isn't it? It's an example of a autoimmune disease. Now in this vitiligo, in one of the FMG exam, you got a depigmented rash, that is white color, over one side of the neck. If I just zoom this image for you, you can see that in this image, it is not the neck, only in one side of the forehead, you can see this vitiligo kind of a lesion. So this type of vitiligo is called as segmental vitiligo. So this segmental vitiligo is going to be along a dermatomal distribution. So this is going to be along a dermatomal distribution. Okay? So let's see another image. This is another PYQ, isn't it? We have PYQs in almost every page. That is how the questions really come. So then one question they may ask you vitiligo. The next exam they may ask you something like this. यहाँ पे I don't see a hypo, I see a hyperpigmentation. That too brown in color, and this is a hyperpigmented patch lesion. Any spot diagnosis? गौरी साहब विटिलिगो का बहुत टाइप्स होते हैं. Acrofacial is also one more type, but I have limited my discussion to whatever was asked in the previous years. So that is why we have discussed about segmental vitiligo. So Parul, Patel, Shekhar, Pratap, all of you are answering it as melasma. Roja also. So I would also agree with you. This is called as melasma. And melasma usually happens because of two reasons. Either because of a sun damage or because of hormonal reasons. isn't it? Like a patient can be on oral contraceptive pills, or the patient may be having some endocrine diseases, or if the patient is pregnant. यहाँ पे जो pregnancy and melasma, we call it as cloasma, isn't it? It is compared to the mask of pregnancy. It is compared to the mask of pregnancy, right? And the treatment of melasma also, you can just remember, it is called as hydroquinone. So this is going to be the drug of choice. Hydroquinone is a drug of choice in the management of melasma. Now see the next image. In the next image that you can see here, it is not melasma, because all these lesions, they are small lesions, not a big patch lesion like what you have seen in melasma. So all these are brown color, hyperpigmented macules. So in this case, your diagnosis should be freckles. And what is the only reason why you diagnose it as freckles? Because these are brown macules which can be seen, not brown patches, not brown patches. So in the last year we got this question, right? So what is this? Here you can see there is a black color hyperpigmentation over the skin as well as the oral mucosa. This is called as lentigenes. So in the last FMG exam, the question was a patient who is having a hyperpigmentation over the lips. What is the most common association? So this is due to hyperpigmentation of the lips. We call it as lentigenes, and this is associated with Peutz-Jeghers syndrome. It is associated with Peutz-Jeghers syndrome. Isn't it? It's an autosomal dominant disease. Jahan pe the patient will have some hematomatous polyps in the intestine. Isn't it? Hematomatous polyps in the intestine. Excellent. Tusha, Saf, Gauri, all of you are answering it. Excellent. Shaker also. And now, after talking about these kind of lesions in the face, how about these lesions? Can we quickly label it and move? If you see this brown color in the trunk, that is called as cafe o lie macules, right? So there are two types. एक हो सकता है with regular border, and the second one is this one where there is a irregular border. There is cafe o lie macules with a regular border or with a irregular border. The regular border one can be seen in neurofibromatosis, whereas irregular border, it can be seen in McCune Albright syndrome. It can be seen in McCune Albright syndrome. Clear? Now see, the entire color has changed. We were talking about brown color till now. The color has now changed into blue color. So whenever there is a bluish discoloration, we call it as ceruloderma. There are three types of ceruloderma. This one is a spot diagnosis. Small babies, blue color over the buttocks, lower back, thighs and all. What is this called? This is called as Mongolian spots. This is called as Mongolian spots. Whereas these two things are together. Okay, this one and this one, they both are together. If there is a blue discoloration over the face, and in some patients, if there is a scleral involvement, this is called as nevus of Ota. It is called as nevus of Ota. Whereas in the third one, you can see that there is a baby, there is a blue color discoloration over the shoulder area. This is called as nevus of Ito. It is called as nevus of Ito. So Ota and Ito on the day of the exam, please don't get confused. ऐसे याद रख सकते हैं कि when there is eye involvement ऐसा, so Ota, this is going to be nevus of Ota and shoulder is nevus of Ito. Clear? So very good. Shaker, step by step, Gauri, and Saf, and all of you are able to answer. See, please remember that both these cases, यहाँ पे the treatment should be ND yak laser, whereas Mongolian spots are self-limiting. So Mongolian spot does not require a treatment, whereas nevus of Ota and nevus of Ito, these may require a treatment, and that is with ND yak laser. So now let's see some of the vesicular bullous diseases. So in the vesicular bullous diseases, the first one we talk about is pemphigus vulgaris. So pemphigus vulgaris, for your exam, the most important thing is to identify the clinical feature. The clinical feature of pemphigus vulgaris is it always begins in oral mucosa, okay, which is followed by flaccid bulla over the trunk. So these kind of patients, they will start with oral mucosal erosions, which is followed by flaccid bulla over the trunk. So this is oral mucosa followed by a flaccid bulla. Answer is always going to be pemphigus vulgaris. In pemphigus vulgaris, so this is the oral mucosal erosion. So there are multiple other findings in pemphigus vulgaris. So let us see the histopathological finding. The histopathological finding here is row of tombstone appearance. यहाँ पे row of tombstone appearance होगा. That is because of the separation of the basal keratinocytes. Okay. Along with that, when you do an investigation which is called as direct immunofluorescence, direct immunofluorescence will show a pattern something like this. It looks like a fishnet, isn't it? So you can see a fishnet pattern or a chicken wire pattern. In the epidermis. Like a fishnet or a chicken wire pattern can be seen in the epidermis. Clear? And along with this pemphigus vulgaris, we can also learn one more thing, where if you just try to give a tangential pressure like this, the skin will peel off. This is called as Nikolsky sign. So what do you mean by a Nikolsky sign? Skin peels off on tangential pressure. Here you can try to remember some of the examples of a Nikolsky sign. Okay, the examples are pemphigus vulgaris is one, what we have discussed just now. Along with pemphigus vulgaris, pemphigus foliaceus is another example, and staphylococcal scalded skin syndrome is another example of a positive Nikolsky sign. Okay. Now coming to pemphigus foliaceus, abhi pemphigus vulgaris and pemphigus foliaceus, what is the basic difference? The basic difference lies in this one, the oral mucosal involvement, because pemphigus vulgaris always begins in the oral mucosa, whereas pemphigus foliaceus, here the patient will complain of flaccid bulla over the skin. And I will write this point in red. No oral mucosal involvement. Okay, so if you're getting any question on from vesicular bullous diseases, just try to look out for oral mucosa. अगर oral mucosa involved है along with a flaccid bulla, answer is pemphigus vulgaris. अगर oral mucosa involved नहीं है and there is a flaccid bulla, pemphigus foliaceus. And DIF here is the same. DIF is the same क्योंकि यहाँ पे भी we can see a fish net or a chicken wire pattern, fishnet or a chicken wire pattern can be seen, right? And when it comes to bullous pemphigoid, what is the difference? Bullous pemphigoid में क्या होगा? Every MCQ of bullous pemphigoid will tell you not a flaccid bulla. Instead, the patient will have a tense bulla. So if any question says tense bulla, start thinking about a bullous pemphigoid. And usually this is seen in elderly patients also. It is usually seen in elderly patients. Now, when you see the DIF, you cannot see the same pattern, है like what we have seen in pemphigus vulgaris and pemphigus foliaceus. यहाँ पे, what is the type of pattern that you can see? The kind of pattern that you can see here. See, it's something like this, isn't it? You can see a linear fluorescence in the basement membrane zone or dermoepidermal junction. You can see a linear fluorescence in the basement membrane zone or dermoepidermal junction. That is how you can differentiate between a pemphigus vulgaris, foliaceus, and a bullous pemphigoid. Clear? So now let's see skin malignancy. This is also a repeat question for your exam, isn't it? So when you get a image of a basal cell carcinoma, just see this, the spot diagnosis. If you can see a rolled up border, in the center you can see some red color, that can be a telangiectasia in the center. So whenever you see a rolled up border with central telangiectasia, that is a presentation of basal cell carcinoma, where the most common site is going to be the face. The most common site is going to be the face. Now in this thing, what you should remember is, in the case of basal cell carcinoma, in last exam, there was a confusion whether the lesion that was given on the day of the exam was basal cell carcinoma or a squamous cell carcinoma. And in the question itself, they had mentioned the histopathological examination findings. If the histopathological finding is peripheral palisading of the basal cells, then the answer is going to be basal cell carcinoma. Because here I can just make a note. If it is squamous cell carcinoma, we may better see keratin pearls, but not a peripheral palisading, pattern. Okay. So before we go further, you can see that Dr. Ibnu Farouk has asked, what are the desmogleins that is involved in pemphigus vulgaris and pemphigus foliaceus? So for your information, I'll just note it down somewhere here itself. Pemphigus vulgaris में it is desmoglein 3 that is involved initially, followed by desmoglein 1. Kyunki when there is desmoglein 3 involvement, there is a oral mucosal involvement. When there is desmoglein 1 involvement, there is a skin involvement. Okay, that is one. And in pemphigus foliaceus, here there is only skin, right? Only skin involvement is there. If there is only skin involvement, there is a desmoglein 1 defect. There is no desmoglein 3 defect. Okay? And in bullous pemphigoid, since the bulla is very deep, यहाँ पे we will not get anything that like a desmoglein. Here the defect is bullous pemphigoid antigen 2 more than bullous pemphigoid antigen 1. BPAG2 more than BPAG1. Clear? So let's go further. Another thing that you should remember is, if you get a question from malignant melanoma, here how do you suspect a malignant melanoma? When there's a patient who complains of a new mole, okay, and whenever there is a new mole, you always have to evaluate it. And how do we evaluate it? You have to evaluate it with a algorithm which is called as ABCDE. where A stands for asymmetry, B for border irregularity, C for color variation, D for diameter more than 6 mm, and E means it is going to be evolving, like evolving in color, evolving in shape, evolving in size, isn't it? It's an evolving lesion. So when all these things are seen, that is how we can diagnose a malignant melanoma. Okay, anything atypical like in this image, here's the typical malignant melanoma. Because here it is light in color, here it is dark in color, right? So if any of these features are there, then you suspect about a malignant melanoma. So what about this next image? So from the next image, what is your primary diagnosis? I can just zoom this image for you. So in this image, what has happened is the patient is presenting to you with a hyperpigmentation like this. So ये जो hyperpigmentation है, so in this hyperpigmentation over the axilla, hyperpigmentation over the axilla, and this axillary hyperpigmentation, if you are going to use a Woods lamp examination, this is the finding that you can see, and this finding is coral red fluorescence. So when you see coral red fluorescence, what is the final diagnosis? The diagnosis here should be erythrasma. Okay, the diagnosis here is going to be erythrasma. Very good, Roshni. It is going to be erythrasma. In erythrasma, please remember it is due to a Corynebacterium infection. It is due to a Corynebacterial infection. Again, few more very common type of bacterial infections. I think we should be able to label it as a spot diagnosis and move ahead. It's the first image where you can see there are a group of pustules. So whenever there is a group of pustules, the diagnosis should be folliculitis. Okay? And in fact, I will mark the third image first, because when there is a pus forming infection of a single hair follicle, this one we call it as a furuncle. This one we call it as a furuncle. So in furuncle, what happens? There is only one hair follicle that is involved. Instead, if there is multiple hair follicles that is involved, something like this. So here, this one has another name. It is called as carbuncle. So multiple hair follicles are involved. That is called as carbuncle. So folliculitis, spot diagnosis will be multiple pustules together. Furuncle, the spot diagnosis will be a pus forming infection of a single hair follicle. When multiple hair follicles are involved, it's called as a carbuncle. Impetigo, I guess you must have done this in micro as well. There are two types of impetigo. Tell me, how are you going to diagnose these two types of impetigo? Because the first type we call it as impetigo contagiosum, isn't it? Impetigo contagiosum, you are going to diagnose based on the color of the crust. यहाँ पे color of the crust क्या होगा? It will be a golden yellow honey colored crust, isn't it? Whereas see the second thing here, this is called as bullous impetigo. एक हो गया non bullous, दूसरा है bullous. So in bullous impetigo, what you can see here is that there will be a varnish crust. So I'm writing this in brown color because it's going to be something brown in color. Easily we call it as a varnish crust. How about these two? See, these two conditions the common clinical scenario would be something like there is a patient who complains of fever plus chills plus inflamed skin. Okay, just imagine that the patient is coming to you, fever, chills, and an inflamed skin. Now, when you examine this inflamed skin, if it is over the face and if it has a well-defined borders, then the diagnosis would be erysipelas. Diagnosis would be erysipelas. Whereas if it is in the lower leg, like this image, and it has a ill-defined border, then this one is called as cellulitis. And this one is called as cellulitis. So please try to differentiate it accordingly. Mostly when you get an image in the face, it should be impetigo. But if the image is of the leg, lower leg, it should be cellulitis. It should be cellulitis. Now we can see two rounded lesions here. One is in the scalp, one is in the trunk. Now what is the basic difference? Whenever you're seeing a rounded, patchy alopecia lesion in the scalp, it can be due to tinea capitis. Isn't it? Tinea capitis. So in tinea capitis, it is definitely very important because it is going to be a fungal infection. But please remember that in cases of tinea capitis, our drug of choice is going to be griseofulvin, okay, more than terbinafine. Terbinafine can also be used, but griseofulvin will stay as the drug of choice. Will stay as the drug of choice. Whereas when you get an itchy lesion over the trunk, this is something that we usually call it as ringworm, you know, ringworm. But what is the medical terminology? We call it as tinea corporis. And all of you know very well, why do we call it as a tinea corporis? Because in the beginning of our discussion itself, I said, any fungal infection, your investigation of choice is going to be a KOH test. And so once you do a KOH, the KOH will turn out to be positive. You can see fungal filaments for fungal strands in under a microscope. So in tinea corporis, the drug of choice is going to be terbinafine. So please keep two things in mind. In every tinea, tinea cruris, tinea pedis, tinea manum, tinea fasciae, everywhere, please go for terbinafine as your answer. Whereas if it is tinea capitis, then your answer should be griseofulvin. Should be griseofulvin. Can we quickly label this image? What is this image? So in this image, you can see that the patient is having some lesion over the groin area. You know? So in groin area, it is called as tinea cruris. So tinea cruris is also called as the joke itch, or what is it called? Dobby itch. जोक एच और दोबी एच. यहाँ पे भी ट्रीटमेंट सेम टू सेम होगा. टर्बिनाफिन ही यूज कर सकते हैं because terbinafine is the overall drug of choice in all the types of tinea. In all the types of tinea. So this is another PYQ which was asked for your exam. What is important with this image is it is a condition which is called as tinea incognito. So in today's clinical scenario, it has a big significance because there is a widespread use of steroids, isn't it, these days, even without knowing the right diagnosis. So यहाँ पे just imagine that the patient had a tinea corporis and you applied steroid creams. Steroid cannot kill a fungus, isn't it? The end result is a tinea incognito. So tinea incognito means steroid modified tinea. In your exam, you got a question like a young doctor, probably someone who is not very experienced. That is why they mentioned a young doctor prescribed steroid creams for an itchy lesion, and there was no improvement after using this cream. What could be the diagnosis? So यहाँ पे this is steroid modified tinea. In these cases, what you're supposed to do is you should stop steroids. Steroids can definitely bring down inflammation, but never kill a fungus. So you have to start antifungals. You have to start on antifungals. So this is called as tinea incognito. The next is pityriasis versicolor. This pityriasis versicolor mein this image was asked for your exam, right? So what is this pityriasis versicolor? In the name itself, you can see versicolor. Versicolor means, that is why in this image you can see hyperpigmentation, and in this image you can see hypopigmentation. So this is some rare instances in dermatology where pityriasis versicolor is not rare. Okay, but it's very common. But these are rare instances where you can see either hyper or hypo. Hyper or hypopigmented lesions can be seen in this condition called pityriasis versicolor. What is asked for your exam was what is the typical KOH finding in pityriasis versicolor. Let's zoom this image. ये जो long strands दिख रहे हैं ना, these are the fungal hyphae, and these small balls that you can see here, so these balls, they are called as the fungal spores. So you can see both hyphae and spores. That is why in the beginning of our discussion in the table we mentioned banana and grapes appearance, spaghetti and meatball appearance, isn't it? So this is one condition which is caused by Malassezia globosa more than Malassezia furfur. It can be caused by Porphyria globosa, but globosa is more common in cases of pityriasis versicolor. So let's see what happens in some deep fungal infections. In the last ionized set exam, they asked you a question like, why would someone develop a deep fungal infection? Isn't it? So this deep fungal infection can be developed due to traumatic implantation of the fungus. Jैसे, that is why in most of the deep fungal infections, the clinical scenario will be a farmer, because farmer will be working barefoot, isn't it, in the fields. So they are more prone to injuries. Through the injury, there can be a fungal implantation, right? That is why traumatic implantation of the fungus can lead to deep fungal infection. The first disease is going to be a rose gardener's disease. So this rose gardener's disease has another name, which is also called as sporotrichosis. So if it is a sporotrichosis, then the clinical scenario can be, there would be a history of a rose thorn prick, isn't it? There can be a history of a rose thorn prick, after which the patient is developing these kind of nodular lesions. And how are these lesions arranged? They are arranged linearly because they run along a lymphatics. So when we discuss about sporotrichosis, what I feel is, what is more important is to discuss about the histopathological finding. The confirmatory diagnosis यहाँ पे does not happen with KOH, क्योंकि KOH is done in the skin, superficial होना चाहिए fungus, और यहाँ पे तो deep fungal infection है. So if it is a deep fungal infection, mostly the histopathological examination yields you better result. And here you can see asteroid bodies. Here you can find asteroid bodies, which is confirmatory for rose gardener's disease or sporotrichosis. Another deep fungal infection which we can discuss today is this one. It is called as chromoblastomycosis. So you can see that in this image, the patient has developed some large nodular exophytic lesions in the lower limb, isn't it? So here also what you're going to do is, You will not be able to make out a diagnosis just by seeing this image. Again, what do? एक excision biopsy करेंगे and we will be checking the histopathological finding. This histopathological finding can give you a result. क्योंकि this finding is very typical. It is called as copper penny bodies. So these copper penny bodies are seen in chromoblastomycosis, which is another deep fungal infection, isn't it? And you can treat it with some antifungal agents like itraconazole. So now let's see another one. So heading is given, it's a viral infection. ये जो viral infection in this image, I need not even tell you the question, क्योंकि it is a spot diagnosis. Can anybody tell me कि ये जो image है, इसका spot diagnosis क्या हो सकता है? So this one, if I just zoom this image for you, you can see there is a dome-shaped papule, and the center you can see that there is a central umbilication as well. So this central umbilication is going to give you the diagnosis. Saf says it is molluscum contagiosum. Agupta also says the same. Very good. So this is called as molluscum contagiosum. यहाँ पे you can see this dome-shaped papules with, I'll write central umbilication in red because that is a differentiating feature. Central umbilication can be seen. Once again, two more things which we cannot omit from this topic, because in the last FMG exam you got this another question. What is the histopathological examination finding of a molluscum contagiosum? So what is the histopathology finding? There is some inclusion bodies which can be seen, and these inclusion bodies are called as Anderson-Patterson bodies. So please remember, in molluscum contagiosum you can see Henderson-Patterson bodies. And there is one more very important phenomenon. It is called as pseudo-Koebner phenomenon can be seen. What do you mean by pseudo-Koebner? Because earlier we have discussed कि Koebner phenomenon can be seen in LVP, lichen planus, vitiligo, psoriasis. Whereas pseudo-Koebner means once you repeatedly touch on this lesion, one lesion will be followed by the other, followed by the other, followed by the other. This is because of auto-inoculation of the virus. This auto-inoculation of the virus, this is called as Koebner phenomenon. So pseudo-Koebner phenomenon. Okay. यहाँ पे what we can see is a pseudo-Koebner. Usually happens in viral infection. जैसे warts में भी हो सकता है, right? So the examples are molluscum contagiosum virus and viral warts. And viral warts as well. Another one, again repeatedly asked. I don't know how many times it was asked. It's always a repeated topic. And whenever you see these kind of rough exophytic growths in the genitalia, what is the name for this rough exophytic growths? Anyone? Rough exophytic growths in genitalia, ये हो सकता है genital warts, है ना? This genital warts, you will not see an option called genital warts in the MCQ. In MCQ, they always will mention it as condyloma. Very good, Roshni. Acuminata. It's called as condyloma acuminata. SAF is also answering. So in this condyloma acuminata, it is caused by human papilloma virus. If they ask you very specifically कि कौन सा subtype है, then the answer should be 6 and 11, which both are a low risk subtype. So both of them are a low risk subtype, condyloma acuminata. यहाँ पे सबसे important यही है कि about the treatment part, because इसमें specific treatment होते हैं for genital warts. It is with imiquimod or podophyllins. Because imiquimod and podophyllins, they are immunomodulators which can be used. But the problem with imiquimod and podophyllins is they both are teratogenic. अभी ये अगर ये दोनों teratogenic agents हैं, then imagine a clinical scenario जहाँ पे एक pregnant female is coming to you and this pregnant female is having genital warts. अब क्या करेंगे? Imiquimod और podophyllins use नहीं कर सकते, isn't it? So at that time, the treatment of genital warts in pregnancy, your answer should be different from imiquimod and podophyllins. So I got the answer right now. Roshni, Vipul, Saf, all of you have answered it very good. So this should be with cryotherapy. So here the answer should be cryotherapy. So don't make this mistake. So please remember cryotherapy in case of pregnancy. Now see these two images. Are you able to give me one single answer? Because what do you see? You can see a genital ulcer and you can see some black color background and something is moving in a peculiar order. So this is called as corkscrew motility in a dark field microscopy. So together, does it ring a bell? What is the diagnosis? Ulcer hai and dark field microscopy mein there is a corkscrew motility. Very good, step by step. I don't know your real name. So this should be primary syphilis. This should be primary syphilis, right? So in syphilis, remember this S. ये S, you can remember it as a silent disease, isn't it? Silent disease क्यों? क्योंकि यहाँ पे ulcer is painless and lymphadenopathy is also painless. Painless ulcer, painless lymphadenopathy, always consider syphilis in your diagnosis. Now let us see these two images. In these two images, we can see there is a genital ulcer here and there is a gram staining here. Something is arranged very nicely in order, right? So this one is called as the school of fish or the railroad track appearance. So if you find something like this, railroad track appearance, school of fish appearance in a gram staining, then what are you going to think about? You are going to think about a condition called as chancroid. This chancroid है ना, you should always learn chancroid with syphilis. क्योंकि syphilis में क्या होता है? Painless ulcer, painless lymphadenopathy. ये exact opposite है. यहाँ पे you can find a painful ulcer and a painful lymphadenopathy. And this lymphadenopathy is also having a peculiarity. This lymphadenopathy is also called as buboes. It is also called as a bubo. So remember, syphilis and chancroid, you should learn it together. Exactly opposite features, yeah, clinically. So how about this one? I would say this is the easiest image-based question when it comes to a genital ulcer. Kyunki, what is the color that you can see? The color I would describe it as beefy red in color. There is one more feature for this ulcer because this is an ulcer that can bleed to touch. So when you touch, it can even bleed. So it's a red color ulcer. कहाँ पे दिखेंगे? And you can see that in the tissue smear. You can see this is very typical, right? What is this? What does it resemble to? It has a closed safety pin appearance. So this closed safety pin appearance is called as Donovan bodies. Donovan bodies. अब easy हो गया ना? Because Donovan bodies. Now disease name is something that you can easily predict. Vipul, step by step, all of you are answering. It is called as Donovanosis. It is called as donovenosis. And as Vipin Sharma has very rightly pointed out, ये जो donovenosis है इसका पुराना नाम यही है कि granuloma inguinale. It's not a new name, it's an old name, but we can't believe or trust on our examiners, right? They can pull up this old name into one of the options. Remember, granuloma inguinale is an old name for donovenosis. And in donovenosis, just one point before we move further, ये जो no है ना, this no actually stands for no lymphadenopathy. Please remember this additional point as well. No venosus, no lymphadenopathy. So these are key things which can help you to segregate and reach out the right diagnosis. Clear? Moving further, herpes genitalis. ये जो herpes genitalis है, this is the most common genital ulcer disease. Since it is herpes, we know that it can be due to HSV, herpes simplex virus. Since it is below the waist, it is caused by HSV2 in most of the instances. Every herpes infection, you get vesicles. फिर क्या होगा? Vesicles rupture होंगे. Rupture होने के बाद there will be some erosions, है ना? Once the erosions is also not treated, it can lead to ulcers. And what is the peculiarity of the ulcer? Here this is very aggressive, just like our chancroid. There is going to be again painful ulcer and painful lymphadenopathy. Painful ulcer hoga, painful lymphadenopathy hoga. That is how you can find herpes genital. Clear? See this one. Something else has come now. Earlier, when we learned about where is it? Yeah. Now see this image. यहाँ पे ना male and female genitalia है, and you can see some rough surfaced exophytic lesions in this image, right? Now after you see this image, then you just see this image. यहाँ पे अभी क्या हो रहा है? It's a flat topped lesion, right? When you see these kind of flat topped lesion, in the genitalia, remember these are very infectious lesions, and the name of this lesion is condyloma lata. See, we have discussed about two condyloma now. पहले जो था genital warts वो हो गया condyloma acuminata, ये हो गया condyloma lata. So what happens in condyloma lata? In condyloma lata, this is seen in secondary syphilis. Okay, secondary syphilis. The reason why this image is given is many times condyloma acuminata was asked, but the image and in the option both were there. Option A condyloma acuminata, option B condyloma lata. So remember this is going to be condyloma lata that is seen in secondary syphilis. So just a few sentences about discharge diseases also. So there can be instances where a patient may complain of discharge, right? So whenever there is a discharge, there are only two possibilities. Either it should be a gonococcal discharge or it should be a non-gonococcal discharge. So when I say gonococcal, then we know that I'm talking about Neisseria gonorrhoeae. Whereas non-gonococcal, it can be mostly due to chlamydia. Can be mostly due to chlamydia. Now even the symptoms are going to be different here. What is going to be more aggressive? जहाँ पे the patient will complain of painful, I mean dysuria itself is going to be painful, right? Painful micturition. So यहाँ पे one of the complaint is going to be dysuria. Okay. There is a pain while micturating or while passing the urine. Along with that, there would be a purulent discharge. So if the clinical scenario that is given for your exam is painful micturition with a purulent discharge, then think about gonococcal urethritis. Whereas if it is going to be chlamydial urethritis, यहाँ पे symptoms will be kind of not tolerable for the patient. So there would be a variable dysuria here. There will be a variable dysuria. Sometimes severe pain is there, sometimes not that much painful. So variable dysuria along with a clear or a mucus discharge. That is how you can easily differentiate between a gonococcal and a non-gonococcal urethritis. Okay. Annotated PDF will be shared to you. Will be shared to the FMG Sankalp Telegram channel. Okay, of PW Medet. Take care, people. So now let's see another one, which is called as scabies. Scabies. What do you think is going to be the common complaint of a patient who is having scabies? Definitely itching hoga, right? Severe itching. So if the MCQ says patient presented with severe itching, that too with a very important point, that is nocturnal exacerbation, because the itching becomes very severe during the night time. That is called as nocturnal exacerbation. Then think about scabies. In scabies, when you examine in between the finger webs and all, you can see a typical lesion in scabies. So what is the name of this typical feature that you can see, or the skin lesion that you can see in scabies? जैसे मैंने बोला था कोमिडोन्स एक्नी वल्गारिस में ही दिखते हैं, है ना? Similarly, in scabies, you can see there are burrows. So if there is a mention of burrows, confidently tick scabies. Okay, there is no other disease where burrows can be seen. In some case, जैसे अभी step by step is saying, this is called as nodular scabies. I completely agree with you. This is called as nodular scabies when there is some nodules in the scrotum, right? And scabies का जो treatment है, it was asked recently in one of the exams. So in the treatment part, please remember, scabies should be managed with 5% permethrin. And remember, this 5% permethrin, this is safe in any age group, especially more than 2 months of age. It is very unlikely na, कि a patient can get scabies in 1 month or less than 2 months of age immediately after birth. इसलिए in most of the age groups, be it adolescent, be it puberty, be it adulthood, elderly, सब लोग में permethrin would be the single best choice. But in some severe cases जहाँ पे resistance हो सकता है या फिर very severe scabies and all, you can go for some oral agents as well. If they ask you the oral agent, your answer should be ivermectin. Oral agent should be ivermectin. Another very important topic for your exam can be from the nutritional dermatosis. Maybe you may learn about this in pediatrics, in biochemistry, isn't it? So no matter from which subject you may learn, it's very important to get this thing right on the day of the exam. Now, what is this? When you find a toad-like skin. Toad is a little frog. Like most of the times what happens, you get multiple papules around the elbow. So this is called as rhinoderma. It has been asked so many times, isn't it? Rhinoderma. So there is a child who comes with rhinoderma or a toad-like skin. यहाँ पे it is associated with vitamin A deficiency, which is the most common association. Isn't it? It is the most common association. इसीलिए some of the MCQs can be like Bitot spot and rhinoderma. Where do you see? Bitot spot, rhinoderma is equal to vitamin A deficiency. But this vitamin A deficiency is not the only place where you can see this rhinoderma. Rhinoderma can be seen in vitamin B deficiency, C deficiency, even free fatty acid deficiency. But there can be one exception, and that exception also you can note down, except vitamin D deficiency. It is not associated with vitamin D deficiency. Clear? So now let's see another one. ये हो गया एक time to time repeated question, hundreds of times, right? Every question you see, every year you see, or every 6 months this question is asked. What is this? you can see that there is a photosensitive rash around the neck region. What is the name of this rash? This is called as Casel's necklace. Second one, when you find a shiny rash over the dorsum of the hands or over the forearms, this is called as gauntlet sign. So when I say gauntlet sign and Casel's necklace, I think by this time you should be able to answer कि क्या deficiency है, isn't it? So both these things can happen in niacin deficiency, and this niacin deficiency is called as pellagra. And just to make sure that you have your concepts right, which is this niacin? Is it vitamin B1, B2, B3, B6, B12? Because we have different forms of vitamin B, right? Yeah, Vipin has already answered it. It is vitamin B3 deficiency. Is the B3 deficient. Clear? How about this one? ये भी एक image spotter हो सकता है. This is also another PYQ, isn't it? There is a child who complains to you with DAD, dad. Now, dad is a complaint. What is this dad? Where D stands for diarrhea, A stands for alopecia, and D for dermatitis. So this is a typical feature of this disease. Yeah, swingy mood, Sejal, Chinmayi, Thakur. So all of you are answering it. So this can be seen in zinc deficiency. But we'll just say about zinc deficiency may not be correct, because zinc deficiency, this condition has a name. You know what is the name? It is called as acrodermatitis enteropathica. It is called as acrodermatitis enteropathica. You can see that these rashes, they are seen as periorificial dermatitis, right? ये जो dermatitis है ना, this dermatitis, here the most important is periorificial dermatitis. So I'll just zoom this image. See, around the nasal orifice, around the oral orifice, around the anal orifice. So when you see this kind of a rash, then the answer should be zinc deficiency, acrodermatitis enteropathica. Clear? Yes. And now let us see some of the drug reactions. Just imagine what happens in this condition called as a fixed drug eruption. These are the examples of a fixed drug eruption, where there is a drug intake, and then after drug intake, the patient develops a hyperpigmented rash anywhere. But the most common sites would be the lips or the genitalia. They are the most common sites. It can happen anywhere, but lips and genitalia में थोड़ा और भी common है, right? And then this rash does not fade. It can fade with residual hyperpigmentation. So once a lesion will develop because of a fixed drug eruption, that lesion will always be there. थोड़ा fade हो जाएंगे, but it will not disappear completely. It is called a fixed drug eruption. Now, why do we call it as a fixed drug eruption? The reason is, once there is a retake of the drug, the lesions will reappear at the same site. So what is same here, or what is fixed here? Drug be fixed है, site be fixed है, isn't it? Same drug, same site. Multiple times. You take it multiple times, the same lesion will reappear, more hyperpigmented. This is called as fixed drug eruption. Okay. The next one is Stevens-Johnson syndrome and toxic epidermal necrolysis. In fact, one of the most severe type of a drug eruption. You know? तो यहाँ पे again you will have a history of a drug intake. After a history of a drug intake, the patient will develop massive peeling of the skin. There will be massive peeling of the skin. It is not only peeling of the skin, जैसे burns patient जैसे दिखता है, right? Along with that, there will be involvement of at least two mucosa. Involvement of at least two mucosa, जैसे oral mucosa का involvement हो गया. The patient is not able to drink or eat anything. The involvement of the mucosa in the eyes, the patient is not able to see properly. Genital mucosa, the patient is not able to pass urine or feces properly. That is going to be the presentation. Now, why do we learn Steven Johnson and toxic epidermal necrolysis together? The reason is based on the body surface area. Like imagine 10% body surface area is involved. Then we call it as Steven Johnson syndrome. More than 30% of body surface area is involved, we call it as toxic epidermal necrolysis. That is the basic difference. Second thing, but we learn them together. Reason is most of the times you may get patients in this category between 10 to 30%. So that we can call it as Steven Johnson toxic epidermal necrolysis overlap. So this one we can call it as a overlap. That is about Steven Johnson syndrome. Now in the Steven Johnson syndrome also, don't you think that if I apply a tangential pressure, the skin may peel off? Now remember what is the name of the sign? यहाँ पे don't make a mistake. The clinical sign is the same. You are using your fingers, you're going to give a tangential pressure, the skin will get peeled off. But instead of telling about Nikolsky, we call it a pseudo-Nikolsky sign. Is seen in Steven Johnson syndrome or toxic epidermal necrolysis. Clear? And why pseudo-Nikolsky? Because everything is the same, right? The clinical sign is the same. But since the etiology is different. Now, what is this different in etiology? Which means there is a difference in from acantholysis. Because when we learned about Nikolsky sign, examples tha pemphigus vulgaris, pemphigus foliaceus, staphylococcal scalded skin syndrome. In all these things, there is an acantholysis that happens. But in this patient, if you do a histopathology, you can see necrotic keratinocytes, but not acantholysis. Iसीलिए we call it as a pseudo-Nikolsky sign. Clear? The next image is something very common. And what is it? This image is where a patient is having a velvety kind of a hyperpigmentation in the neck region. So this velvety kind of a hyperpigmentation over the neck region, this is called as acanthosis nigricans, right? So this acanthosis nigricans, it usually happens because of multiple reasons. But the most common association here is due to obesity. There are many other reasons as well. The other reasons can be like metabolic syndrome, isn't it? And PCOD, even rarely malignancy as well. So all these things can be various causes for acanthosis nigricans. Okay. So I guess that is it for the dermatology part. I hope things are pretty much you are able to refresh it, isn't it? Yeah, diabetes can also cause. Very true. So I would agree that diabetes mellitus can also cause acanthosis nigricans. So please, I will be sharing this annotated PDF in the Telegram group as well. And just a few more days left for the exam. And in some time, we have one more session coming up for the day. I wish you all the very best. Okay, please Try to stay calm over these last few days. Try to revise everything in a very quick fashion and do rock the exam and do keep us posted with your results. Okay? Yes, we'll share you the PDF. Thank you so much. Wishing all of you the very best.
Hi everyone, please check my voice. Hi Said. Okay, please check my voice. Okay. Hello everyone. Today we will discuss the important points related with FMGE examination. We'll discuss the vitamins, we'll discuss the minerals, we'll discuss the inborn errors of metabolism, we'll discuss the trending topics जैसे कि we'll discuss the vacuotenors means different color coding system for vacuotenors. We'll discuss the trending topics in the FMG examination. Also some topics from the INICT and NEET PG में से भी थोड़ा सा टॉपिक लेंगे जो कि FMG के लिए पूछा जा सकता है, जो इम्पोर्टेंट है वो. ठीक है. So this topic is purely based on the PYTs means previous year topics and previous year questions. तो questions तो मैंने यहाँ पे नहीं लिए, लेकिन previous year topics से related हम यहाँ पे discussion करने वाले. Will focus on the important part, important questions, important highlighter point, the top rated MCQs for the FMG examination. So stay tuned for near about 3 hours regarding the discussion of important topics for the FMG examination. So let's begin. The first and important one is the vacuotenor. This is trending topic. Internship में मतलब ये जनरली हम ये ट्यूब लेके घूमते हैं. So see, for the vacuotenor to remember and the order of draw is important. Order of draw मतलब after the collection of blood sample you have to put in this sequence. First is the blood culture bottle. For this mnemonic is there. The mnemonic is bunny rabbit get pregnant food. This is mnemonic to remember the order of draw. Order of draw means in this sequence you have to add the blood to the tubes. First is the blood culture bottle. Obviously, no, there should not be contamination in the blood culture bottle. So first is the blood culture bottle. So remember, B for blood culture, B for blue. It is a blue top vacuotenor container. It is a citrate tube which is mainly used for the coagulation profile. So remember these words: coagulation profile, blue tube. It is used for the matlab for the coagulation profile. We take the sample in the citrate tube which is having the blue top. So blue top citrate tube coagulation profile for the coagulation profile. This red and yellow combine. So red and also yellow. This is sometimes it is with clot activator, without clot activator. This is with clot activator. Advanced version है red का ही. Generally government setup में red use होता है और private setup में yellow use होता है. Because of the cost, this is with the separating gel is also there in the yellow tube. So the primary focus or primary purpose is same for the red and the yellow vacuotenor. Red is mainly used in the biochemistry. This is mainly for the serum biochemistry parameters. Serum biochemistry means routine tests biochemistry. For example, KFT, urea creatinine, LFT, that is total protein, albumin, cholesterol, SGOT, SGPT, जितने भी routine parameter है, all these routine parameters done when we collect the blood in the plain vacuotenor without any anticoagulant. Okay, red or yellow tube, serum biochemistry पैरामीटर्स एनालिसिस रूटीन पैरामीटर एलएफटी केएफटी एंजाइम ऐसे इसके लिए ये प्लेन ट्यूब यूज करते हैं. नेक्स्ट वन इज द सी बनी रैबिट. ब्लू मीन्स ब्लड कल्चर फॉलोड बाय द ब्लू टॉप दैट इज साइट्रेट ट्यूब. रेड इज द प्लेन ट्यूब, रेड और येलो. नाउ इट इज येलो, रेड और येलो. एंड जी इज फॉर द ग्रीन ट्यूब. It is a heparinized tube or heparin tube, this which is mainly used for the ABG analysis, arterial blood gas analysis. Heparin tube, it is used for ABG analysis or immediate biochemistry parameter. For example, see, serum electrolyte also done in the plain tube. Serum electrolyte, it can be also done serum electrolyte also can be done along with the ABG in the heparinized tube. So immediate biochemistry parameter, and mainly for the ABG analysis, heparin tube means heparin tube or the green top tube is used. This is the purple top EDTA tube. It is EDTA tube. It is mainly used for the CBC. And remember, this is biochemistry parameter HbA1c. HbA1c, that is glycated hemoglobin. Glycated hemoglobin, which tells about the average blood glucose level for preceding 8 to 12 weeks. Remember, preceding 8 to 12 weeks. This is important MCQ. Purple top EDTA tube, CBC, complete blood count, and the HbA1c estimation. And this is a gray tube. So F for fluoride, it is a fluoride bulb. Fluoride bulb, gray cap is there, gray cap. It is for the glucose estimation. It is for the glucose estimation, whether it is CSF glucose or blood glucose. The sample is collected in the fluoride bulb, which contains sodium fluoride, potassium oxalate. So it is sodium fluoride, potassium oxalate in the ratio of 1:3. Here fluoride ion inhibit the enzyme enolase by the non-competitive inhibition, and this is anticoagulant. This is anticoagulant. Okay, so these are the tubes, and this is order of drop. Bunny rabbit get pregnant food. Blood culture bottles, followed by the blue top citrate tube for the coagulation study. Then red or yellow for the, it is a plain tube without any anticoagulant. So it is general for the routine biochemistry analysis. Red or yellow tube is used. Also for the electrolyte, red or yellow cap tube is used. Green, it is heparinized bulb. It is used for the ABG analysis. P for purple, it is for the CBC or HbA1c estimation, and F for fluoride bulb, gray cap tube, it is for the glucose estimation. So it is it contains sodium fluoride, potassium oxalate in the ratio of 1:3. Fluoride ion inhibit the enolase enzyme of the glycolysis by the non-competitive irreversible inhibition, maintain the glucose level in the collected sample. So this is, guys, this is a trending topic for the FMG, NEET PG, also INI-CT examination. Very important. Last 2-3 exam में there is question on the serum electrolyte estimation, there is question on the HbA1c estimation. Also repeatedly the question were on the fluoride bulb and the mechanism of the fluoride in inhibition of the enolase. So this is very important and trending topic for the any entrance examination. So note this is very important topic. Vacuum tenors, different color coding system, and this is the order of drop. First is the blood culture. First is the blood culture tube or blood culture bottle, followed by the citrate tube, coagulation analysis. So this is order of draw. Remember this. This is very important. Now coming to the various amino acid and their derivatives, this is simple question, but recollection or the collection of all data at one time, it is very important. Miss the glycine, how many products given by the glycine, or the what are the different products given by the tyrosine, phenylalanine, tryptophan. तो ये थोड़ा सा याद करना मुश्किल है. So we'll go one by one. See, tyrosine, all of you know that phenylalanine and tyrosine metabolism considered together, because phenylalanine is ultimately converted into tyrosine. For this conversion, the enzyme required is phenylalanine hydroxylase. So these are the products given by the tyrosine. In the skin, hair and eyes, tyrosine will give you melanin. In the thyroid gland, there is synthesis of T3 and T4 from the tyrosine. Norepinephrine, epinephrine in the adrenal medulla, and the dopamine in the central nervous system. These are the products given by the tyrosine. Apart from these, tyrosine is both glucogenic and ketogenic amino acid. Both glucogenic and ketogenic amino acid includes aromatic, all three, matlab phenylalanine, tyrosine, tryptophan and isoleucine. These are the both glucogenic and ketogenic amino acid. In their metabolism, this phenylalanine and tyrosine will give you both glucose and fat. That's why they are known as both glucogenic and ketogenic amino acid. Now remember here, the ketogenic amino acid, exclusively ketogenic amino acid. So ketogenic amino acid, that includes leucine mainly, leucine followed by lysine, leucine and lysine, these are the ketogenic amino acid. Both glucogenic and ketogenic includes aromatic amino acid, means phenylalanine, tyrosine, tryptophan and isoleucine. और बचे वाले सारे अमाइनो एसिड्स जो है दे आर ग्लूकोजेनिक अमाइनो एसिड. सो रिमेंबर दिस, कीटोजेनिक अमाइनो एसिड ल्यूसिन, लाइसिन, बोथ ग्लूकोजेनिक एंड कीटोजेनिक अमाइनो एसिड, ऑल aromatic, phenylalanine, tyrosine, tryptophan and isoleucine. These are the both glucogenic and ketogenic, means in their metabolism they will give you glucose, they will give you fat. Okay, so these are the products given by the tyrosine, these are the products given by the tryptophan in the kynurenine anthranilate pathway will give you alanine. And also there is generation of the acetoacetate in the tryptophan metabolism, so it is both glucogenic and ketogenic amino acid. Apart from this, the specialized product given by the tryptophan that includes the NAD, NADP, serotonin, melatonin, and it is excreted in urine as hydroxyindole acetic acid. Now see, this is in the kynurenine anthranilate pathway, while this is in the serotonin pathway. So serotonin and melatonin. Now, hydroxyindole acetic acid excreted in the urine in patient with the carcinoid syndrome, or also known as urgent taphinema, in which more than 60% of tryptophan is converted into serotonin. So remember, the tryptophan will give you NAD, means this is a niacin. The NAD and NADP, these are the coenzyme form of the niacin. 60 milligram of tryptophan will give you 1 milligram of niacin. 1 milligram of niacin. Okay, so in the some disorders where tryptophan metabolism is affected, for example, heart nerves disease, in the heart nerves disease, which is a defective absorption of tryptophan from the intestine, also from the renal tubules, because of the defective metabolism or absorption of tryptophan, there is pellagra like rash in the heart nerves disease. So remember, these are the products given by the tryptophan: NAD, NADP, serotonin, melatonin, and it is excreted in urine as hydroxyindole acetic acid. You may get a question, which of the following or all of the following are the derivatives of this amino acid except this type of question can be there on the amino acid and their derivative. Then cysteine is important. It is important for generation of the coenzyme A, taurine. Then it is the pyruvate, glutathione and glucose. Cysteine is glucogenic amino acid, will give you glucose also. So glucose, pyruvate, glutathione, taurine and coenzyme A. Apart from these three, one more important amino acid is there, that is glycine. So this is very, very important, and the product given by the glycine. So remember, these are the products given by the glycine. First is the heme. The glycine and succinyl coenzyme A combined to form the delta amino levulinic acid in the heme synthesis, first step of the heme synthesis reaction. So glycine will give you heme. Then it is creatine phosphate and creatinine. These are the products of this glycine, arginine and methionine. Arginine and methionine, these three amino acid, GAM, glycine, arginine and methionine will give you creatine phosphate and creatinine. Then glycine will give you the C4, C5 and N7 of the purine ring. C4, C5 and N7 of the purine ring. Glycine is important in the conjugation, or it is important in the excretion of the benzoic acid as hippuric acid. It is excreted in the urine as hippuric acid. It is important in the conjugation reaction. It is important for the conjugation or the synthesis of the bile salt, that is conjugation of bile salt, glycocolate, glycosinodeoxycolate. So conjugation reaction, it is important, means bile salt synthesis, it is important. Then glycine is important for the collagen synthesis. It is the most common amino acid in the collagen. 30% of the glycine is there. 30% is glycine in the collagen structure. It is glycine XY repeat in the collagen structure, in the collagen triple helix. So it is heme synthesis, creatine phosphate, creatinine, C4, C5, N7 of the purine ring, hippuric acid. It is benzoic acid or benzoyl coenzyme A conjugation and excretion as hippuric acid. Conjugation of the bile salt, that is glycocolate, glycosinodeoxycolate, collagen synthesis, glycine is important, and also glutathione. Glutathione is a tripeptide. It is a atypical peptide which is having the glutamate, cysteine, and glycine. This is a tripeptide, a typical peptide having the 3 amino acid, that is gamma glutamyl cysteanyl glycine. So glutamate, cysteine, and the glycine. These are the compounds given by the glycine. So amino acid, their derivatives, amino acid classification. Amino acid classification is important. In the amino acid classification, the essential amino acids, they are important. Essential amino acid, that includes the mnemonic. Essential amino acids, that includes the mnemonic, that is MAT will fly. MATT, MAT, VIL, PHLY, MAT will fly. These are the 10 essential amino acid. इसमें से 2 सेमी essential है. एक arginine, remember this A is for the arginine, and H, this is histidine. These are the semi essential amino acid. Apart from this, the thing to remember here is there is no tyrosine. This is for the threonine, and this is for the tryptophan. And there is no alanine. Remember, there is no alanine here in the essential amino acid. There is arginine in the essential amino acid, and there is no tyrosine, as phenylalanine give you tyrosine. So remember, there is no tyrosine, there is no alanine. Remember these 2 T, threonine and tryptophan. So these are the 10 essential amino acids: methionine, arginine, threonine, tryptophan, valine, isoleucine, leucine, phenylalanine, histidine, lysine. These are the 10 essential amino acid. इसमें से 2 सिर्फ during the period of growth या pregnancy लगते हैं, that is arginine and histidine. That's why they are known as semi essential amino acids. Semi essential amino acids. So amino acid classification is important. Polar, non-polar is also important. Remember polar and non-polar also. Here remember polar and non-polar also. So non-polar you can remember like this: non-polar amino acids. Non-polar amino acids. The key to remember the non-polar amino acid is the all 3 aromatic amino acid. Aromatic amino acid कौन से है? Aromatic amino acid phenylalanine, tyrosine, and tryptophan. These are non-polar amino acid. Then the branched amino acid, that is valine, isoleucine, leucine. These are the non-polar amino acid. Then in the simple one, alanine is non-polar. Simple one, alanine is non-polar, and in the sulfur containing methionine is non-polar. Methionine is non-polar. Methionine. Then the amino acid proline. Proline is non-polar. So these are the non-polar amino acid: phenylalanine, tyrosine, tryptophan, valine, isoleucine, leucine. Simple में alanine, sulfur containing methionine, and the amino acid proline. These are the non-polar amino acid. बाकी बचे वाले सब means the basic amino acid, histidine, arginine, lysine, the acidic amino acid, aspartic acid, glutamic acid, and their corresponding amides. The OH group containing, that is serine and threonine. The simple one, glycine. These are the polar amino acids. So amino acid classification is very, very important. Though it is simple, but practice it. It needs practice क्योंकि volatile subject है biochemistry, भूल जाता है अगर revise नहीं किए तो. So remember the polar, non-polar, ketogenic, glucogenic and ketogenic, and glucogenic amino acids. Then the derivatives which are given by the amino acid, these are important, particularly tyrosine, tryptophan, glycine, and the cysteine. These are the important amino acid and their derivatives. Now coming to the most important part, that is vitamins. क्योंकि ये vitamins, these are connected with the pediatric, these are connected with the PSM, RDA, recommended daily allowances, sources. It is connected with the community medicine. It is connected with the pediatric deficiency manifestation, toxicity effects. These are connected. So it is integrated topic. The clinical case, you can get a clinical case or any type of question on the vitamin from any subject. So this is very, very important. That's why repeatedly many questions are there on the vitamin topic. So this is match the pair actually. Match the pair. So we'll solve match the pair C, and then we'll discuss one by one these vitamins. So here is the vitamins, and this is the deficiency manifestation. So vitamin A deficiency, Vitamin A deficiency, what is a clinical feature? All of you know that vitamin A deficiency, आप तब तक सॉल्व करो तब तक मैं एक्सप्लेन करते जाता, मैं यहाँ से एक्सप्लेन करता हूँ नीचे से. सी कोबालामिन, विटामिन B12, कोबालामिन मीन्स विटामिन B12, सेंट्रल कोबाल्ट इज देयर. नाउ कोबालामिन, विटामिन B12, दिस इज इंपॉर्टेंट फॉर टू बायोकेमिकल रिएक्शन. कौन से दो बायोकेमिकल रिएक्शंस के लिए लगता है? वन इज methionine synthase, in which homocysteine is converted into methionine in the metabolism of sulfur containing amino acid. And second one is the methylmalonyl coenzyme mutase, which is the important reaction for the gluconeogenesis, in which methylmalonyl coenzyme A is converted into succinyl coenzyme A. For these two reaction, cobalamin is required. Cobalamin deficiency, vitamin B12 deficiency, also the folate and vitamin B12 deficiency, both deficiency causes megaloblastic anemia. In folate deficiency, on histidine load test, there is excretion of figlu in the urine, while B12 deficiency, there is excretion of methylmalonic acid in the urine. दोनों में मेगालोब्लास्टिक एनीमिया होता है. मेगालोब्लास्टिक एनीमिया मीन्स लार्ज ओवल आरबीसीज एंड हाइपर सेगमेंटेड न्यूट्रोफिल्स. लार्ज ओवल आरबीसीज एंड हाइपर सेगमेंटेड न्यूट्रोफिल. बट cobalamin deficiency is directly, it is not directly connected with the megaloblastic anemia, it is connected with folic acid, and folic acid deficiency causes the megaloblastic anemia. That reaction is known as folate trap, that is methionine synthase reaction, जहाँ पे दोनों मतलब B12 को B12 is required for the conversion of methyl tetrahydrofolate into folic acid. If the B12 deficiency is there, the conversion of methyl tetrahydrofolate into folate is blocked, and that's why दोनों के फीचर में, दोनों के deficiency में megaloblastic anemia is there. How to differentiate between the megaloblastic anemia due to folic acid deficiency and cobalamin deficiency? In cobalamin deficiency, there is excretion of methylmalonic acid in the urine, and there is increased methylmalonic acid in the blood. So methylmalonic acidemia and methylmalonic aciduria is there in the cobalamin deficiency. Also, along with this, in cobalamin deficiency, there is features of subacute combined degeneration of spinal cord, that is loss of vibration sense and all. So Romberg sign is positive and loss of vibration sense is there in the B12 deficiency. So subacute combined degeneration of spinal cord is there because of elevated level of methylmalonic acid, which decreases the myelin synthesis or causes the defective myelin and fatty acid synthesis. That's why there is subacute combined degeneration of spinal cord in the cobalamin deficiency, and there is increased methylmalonic acid in cobalamin deficiency, B12 deficiency. Folic acid deficiency, as such, it is not important for the neurological manifestation when there is deficiency, but when it is deficient in the pregnancy, it causes neural tube defect, that is spina bifida and anencephaly. Okay, pyridoxine, it is vitamin B6. The active form is pyridoxal phosphate. It is required for many biochemical reaction, mainly the transamination, transsulfuration, and it is required for the decarboxylation reaction and synthesis of neurotransmitter. Neurotransmitter के synthesis में pyridoxine न्यूरोट्रांसमीटर के सिंथेसिस में पायरिडोक्सल फॉस्फेट का रोल है. सिंथेसिस ऑफ न्यूरोट्रांसमीटर, फॉर ग्लूटामेट इज कन्वर्टेड इनटू गाबा, histidine is converted into histamine, like this. The neurotransmitter tyrosine is converted into tyramine. The dopa decarboxylase dopa is converted into norepinephrine. So this reaction requires the pyridoxine. So pyridoxine deficiency causes neurological features and sideroblastic anemia. So anemia is there as it is required for the first step of the heme synthesis reaction, and the neurological features are there in the pyridoxine deficiency, specifically on the INH therapy, isoniazid treatment. Isoniazid forms the complex with the pyridoxal phosphate, so there is deficiency of pyridoxal phosphate in the INH therapy, which is given for the tuberculosis treatment. Pantothenic acid, it is vitamin B5. The active form is the coenzyme form is the coenzyme A. Pantothenic acid, it is related with the burning feet syndrome. Also B12 deficiency also causes the burning feet syndrome. But this B5 pantothenic acid deficiency, it is discovered by the Indian scientist Gopalan. Pantothenic acid deficiency causes the burning feet syndrome. Niacin deficiency, niacin is vitamin B3. The active form or the coenzyme form is NADP. This is the coenzyme form. The deficiency of niacin causes the Castle's necklace dermatitis, typical classical 3Ds, diarrhea, dementia, and dermatitis. Niacin deficiency, classical 3Ds, classical 3Ds, diarrhea, dementia, and dermatitis. यहाँ पे होगा भी, see. It is pellagra. Niacin deficiency causes the pellagra. Pellagra means it is diarrhea. See, niacin deficiency causes the pellagra. Pellagra classical 3Ds are there: diarrhea, dementia, and dermatitis. Remember this niacin, it is repeatedly asked. Integrated question can be asked on the niacin because diarrhea, dementia, dermatitis. This is a pediatric question. There is dementia, so it belongs to psychiatry. There is the Castle's necklace dermatitis. It belongs to skin also. So ये बहुत important question हो जाता है. Niacin also, thiamine is very very important topic for the FMG examination. So niacin active form is NAD, NADP, vitamin B3, niacin. इस टाइप के मैनिफेस्टेशन और कहाँ पे होते हैं तो वो देखते हैं. सी, niacin deficiency causes pellagra. It causes pellagra. Classical 3Ds, that is diarrhea, dementia, dermatitis. So it is Castle's necklace dermatitis, erythematous demarcated lesion on sun exposed part of the body. Photosensitive dermatitis is there in the pellagra, niacin deficiency. Second is the zinc deficiency, maybe dermatitis होता है, that is known as acrodermatitis, or mainly it involves the periorificial region. Periorificial region it is involved, that is around the mouth, around the anal area. So there is dermatitis in the zinc deficiency. Also biotin deficiency also causes mild rash, mild dermatitis or mild rash. It is accompanied by the alopecia. It is accompanied by the alopecia and some hemolysis is there, hemolysis of the RBCs. So anemia is there. So anemia is there, mild anemia, alopecia and rash is there in the biotin deficiency. Lekin biotin deficiency is not common feature because biotin is available in food and it is required in very low amount. Now see, biotin deficiency के लिए raw consumption की history होना. The avidin is there which combines with the biotin. So raw एक consumption की जब तक history नहीं रहेंगी आप biotin के साथ जा नहीं सकते because biotin deficiency is very rare. It causes mild rash, alopecia, hemolysis. Zinc deficiency, it is connected with the disorder, autosomal recessive disorder that is known as acrodermatitis enteropathica. Acrodermatitis enteropathica. See, enteropathica. Enteropathica मतलब decrease absorption of zinc from the intestine. Decrease absorption of zinc from the intestine. So there is zinc deficiency that causes the involvement of acral part of the body. मतलब distal part of the body. So finger, toes, mouth, nose, these areas, anus, these areas are involved, and there is dermatitis in the zinc deficiency. Along with this, there is diarrhea. There is dermatitis, there is delayed wound healing in the zinc deficiency. Then there is impaired spermatogenesis. Spermatogenesis is impaired. Spermatogenesis, it is impaired. Then alopecia is there in the zinc deficiency. Alopecia. Loss of taste is there. Loss of taste sensation is there. So zinc is important antioxidant mineral. So deficiency causes lot of manifestation. But remember, diarrhea. There is diarrhea in the zinc deficiency. There is dermatitis. There is delayed wound healing. So DAD. Generally, you can remember it as a diarrhea, alopecia, dermatitis, delayed wound healing in the zinc deficiency. Impaired spermatogenesis. Also vitamin. It affects the vitamin A level, and there can be a night blindness in the zinc deficiency also because it is required for the transport or circulating the vitamin A level in the serum. So zinc deficiency also causes the night blindness. So remember, these are the manifestations of the zinc deficiency. So you have to differentiate between these three. Pellagra, classical 3Ds, diarrhea, dementia, dermatitis. The dermatitis here is the photosensitive. This is photosensitive dermatitis. Typically, Castle's necklace, ये हमेशा इमेज बेस्ड क्वेश्चन आता है. Castle's necklace dermatitis or glow and stalking appearance of the hand and feet. Also one disorder that confused with the pellagra. Pellagra like symptoms are there. That disease is known as the Hartnupp's disease. Hartnupp's disease में भी rash होती है. Hartnupp's disease, it is mad symptoms, that is mental retardation, ataxia, and the dermatitis is there, that is pellagra like dermatitis is there in heart nerves disease, because in heart nerves disease it is because of defective absorption of tryptophan, means neutral amino acid tryptophan from the intestine and from the renal tubule. Because of that it is a SIM port which is affected, the sodium dependent SIM port, so sodium dependent transport of amino acid, that is tryptophan, is affected and other neutral amino acid is affected, and because of this there is decreased niacin synthesis, so it causes the dermatitis. Other symptoms are mental retardation, ataxia and dermatitis. Now remember, heart nerve disease, mad symptom, that is mental retardation, ataxia and dermatitis, that is pellagra like dermatitis in the heart nerve disease. It is because of defective absorption and reabsorption of the tryptophan from the intestine and renal tubule. Pellagra, it is niacin deficiency, classical 3Ds, diarrhea, dementia, dermatitis. Typically, when the person is on the maize as a staple diet or jawar as a staple diet. In maize, it is niacin is present in the bound form, so not available for the absorption, and in jawar, it is the high leucine content which inhibit the QPRtase enzyme. QPRtase enzyme. So leucine, high leucine content of the jawar inhibit the enzyme QPRtase. So maize and jawar eating population, there is chances of getting pellagra like symptom. Just wait. Hi everyone. Okay. So many, so how many diseases here? How many diseases we discussed here? One is heart nerve disease, mad symptoms, mental retardation, ataxia, and pellagra like dermatitis. Dermatitis is there. Classical 3Ds in the pellagra, that is diarrhea, dementia, dermatitis. Dermatitis is photosensitive. DAD symptoms in the zinc, that is diarrhea, alopecia, dermatitis. Here the dermatitis involves the periorificial region. Biotin deficiency causes the mild rash, alopecia and mild hemolysis. It is very rare when the person consume raw egg, because of the avidin which combines with the biotin. So biotin deficiency can be there, but biotin is widely distributed. Deficiency manifestations are very rare. Now see here, vitamin A deficiency. So vitamin A deficiency causes the night blindness. So vitamin A deficiency causes vision impairment. Vision impairment, there is WHO grading of the vision impairment, which includes the XN, that is night blindness, then X1A, that is conjunctival xerosis, X1B, that is Bitot spot, triangular foamy white opaque spot on the conjunctiva, that is known as the Bitot spot because of increased keratin deposits on the conjunctiva. So X2, that is conjunctival xerosis. Then X3A, corneal ulceration less than 1/3 of the cornea. X3B, that is corneal ulcer involving the more than 1/3 of the cornea. This is WHO grading of vision impairment for the vitamin A deficiency. Also vitamin A deficiency along with the vision impairment, it causes the phrinoderma, toad-like skin, phrinoderma. Phrinoderma, it is a toad-like skin. It is a multi-nutrient deficient condition. Toad skin appearance is there because of acanthosis and hyperkeratosis. Thickening of the skin occur in the vitamin A deficiency. Also the essential fatty acid deficiency. Vitamin A and essential fatty acid deficiency causes the phrinoderma. So vitamin A deficiency causes vision impairment and the phrinoderma. The night blindness is the earliest manifestation. उसको बोलते हैं increase in the dark adaptation time. जैसे कि आप सिनेमा थिएटर में जब एंट्री करते हो, you can observe that delayed dark adaptation type in the vitamin A deficiency. Vitamin A, it is stored in the ito cells of the liver. It is stored in the ito cells of the liver, that is known as hepatic stellate cells. There are three forms of the vitamin A or vitamins of the vitamin A. Retinol means aldehyde, retinol and retinoic acid. Apart from this, beta carotene is a provitamin form. Vitamin A also causes the toxicity. It is a teratogenic vitamin. It causes the lysosomal damage. It causes hepatotoxicity, and acute dose of vitamin A causes the increased intracranial tension, that is known as pseudotumor cerebri. That is known as pseudotumor cerebri. So vitamin A is very, very important. Then vitamin niacin, the B3 is important. Thiamine is very, very important. So vitamin A deficiency causes vision impairment. Now the second, vitamin C deficiency causes scurvy. Vitamin C deficiency causes scurvy. So scurvy, there is petechiae, there is ecchymosis, there is purpura, there is hemorrhagic spots on the skin because of the fragile blood vessels, because of defective collagen synthesis. The vitamin C is required for the hydroxylation of proline and lysine and synthesis of hydroxyproline and hydroxylysine. So vitamin C deficiency causes scurvy. Vitamin D deficiency causes rickets in the children, osteomalacia in the adult. So rickets, remember, all of you know the symptoms: craniotibes, that is the ping pong ball like skull, then the widening of the wrist, bowing of the legs, the prominent costochondral junction, that is known as rachitic rosary, Harrison sulcus, that is transverse groove along the insertion of the diaphragm. These are the features of the rickets. Along with this, there is low calcium level, low to normal calcium level, low phosphorus level, increase in the parathyroid hormone, increase in the alkaline phosphatase activity. You should able to distinguish between the different types of ricket. For example, see here. So nutritional ricket first, then vitamin D dependent ricket type 1, vitamin D dependent ricket type 2, then chronic renal failure, also there is vitamin D deficiency, then hypophosphatemic rickets. These are the different types of ricket. You should able to differentiate between these three, means this 4 to 5 types of the ricket. Remember, the alkaline phosphatase level increases in all types of ricket. Calcium level, it is low to normal in the nutritional ricket. Also in this first, second and third, there is decrease in the calcium level, but in the hypophosphatemic ricket there is only phosphate which is decreases, calcium level remains normal. And parathyroid hormone, it is also normal in the hypophosphatemic ricket. Parathyroid hormone, it is also normal. In the nutritional ricket, 25 hydroxy cholecalciferol means 25 hydroxy vitamin D3, it is decreased in the nutritional ricket. With vitamin D dependent ricket type 1, it is due to 1 alpha hydroxylase defect, and vitamin D dependent ricket type 2, it is due to receptor defect, vitamin D receptor defect. Okay, so you should able to differentiate between the different types of rickets in the vitamin D deficiency. Then thiamine, it is vitamin B1. Thiamine deficiency causes dry beriberi, wet beriberi, infantile beriberi, and Wernicke-Korsakoff psychosis in the chronic alcoholic. If the deficiency is for the chronic period of time, it can cause the Wernicke-Korsakoff syndrome. So thiamine deficiency, it causes here, see, beriberi. Thiamine deficiency causes beriberi. So there are various types of beriberi: dry beriberi, wet beriberi. So there is neuropathy in the dry beriberi, but in wet beriberi there is cardiac involvement. There is accumulation of fluids in the pericardial and pleural spaces. There is edema. There is high output cardiac failure in the wet beriberi. And the Wernicke-Korsakoff syndrome, it is a combination of Wernicke's encephalopathy and Korsakoff psychosis, which includes number of features. For example, the global confusion, ophthalmoplegia, ataxia, memory loss, and psychosis. These are the features of Wernicke-Korsakoff syndrome. It is due to chronic thiamine deficiency. So thiamine, it is principally when we consume the polished rice as a staple diet, it causes the thiamine deficiency. So this is very, very important, thiamine and niacin. For checking the thiamine status of the body, you can measure the RBC transketolase activity. Pantothenic acid is vitamin B5. Pantothenic acid deficiency causes the burning fit syndrome. Pyridoxine deficiency causes the anemia and neurological problems. folic acid deficiency and the cobalamin deficiency causes the megaloblastic anemia. Folic acid deficiency causes megaloblastic anemia. Cobalamin deficiency causes the subacute combined degeneration of spinal cord. तो ये सभी जो भी जितने भी विटामिन है सारे के सारे इंपॉर्टेंट है, क्योंकि ये कम्युनिटी मेडिसिन में आते हैं, यही पेडियाट्रिक में भी क्लिनिकल केस करके आते हैं. तो ये this becomes the integrated topic and important topic for the FMG examination. Now just wait. Some RDA, remember some RDA. Try to remember some RDA. These are important, very, very important. Vitamin A. Vitamin A, the source for the vitamin A is cod liver oil, the halibut liver oil, polar liver beer. These are the important sources: cod liver oil, shark liver oil, halibut liver oil, and the matlab fish liver oil and the polar bear liver. These are the richest or rich sources of vitamin A. Apart from this, the beta carotene is there in the yellow orange colored fruits. For example, yellow orange vegetable and fruits. For example, carrots, papaya, mango. These contain beta carotene, that is provitamin form. So RD of vitamin A for the men, for women, pregnancy and lactation, it is 1000 microgram. 1000 microgram, it is 840 microgram, it is 900, and it is 950 microgram. This is according to the NIN guideline updated in December 2024 in collaboration with ICMR and MOHFW. This is the source for this RDA. Okay. National Institute of Nutrition in collaboration with ICMR and MOHFW in December 2024 published short summary of RDA. In that, these are the RDAs mentioned. Okay, vitamin A. Then vitamin A ke baad vitamin D. It is vitamin D. It is 600 international unit for adult. Vitamin D. Okay. Then the important one is folic acid and vitamin B12. Folic acid requirement is for men it is 300 microgram. For women it is 220 to 30 microgram for women. In pregnancy it is 570. This is very, very important. And in lactation it is 330 microgram. So this is folic acid requirement. Remember, this is in the pregnancy 570 microgram of the folic acid is needed. Then vitamin B12, the requirement is 2. Men, women, pregnancy, lactation, it is 2.2 microgram. It is 2.2 microgram. It is 2.7 and 3.2 microgram. Pregnancy and lactation vitamin B12 requirement. Okay, 2.2, 2.2, 2.7, 3.2 microgram. These are the requirement of these vitamins. So important vitamins to remember, they are RDA, important recommended daily allowances of these vitamins. Now coming to the minerals, this is all the important points related with the vitamins discussion. There is too much to talk on the vitamins. The important points, I will revise some important point. Listen carefully regarding the vitamins. The important MCQ points. Vitamin A, 3 vitamins are there: retinol, retinoic acid, and retinol. Retinol is a aldehyde form. So in rhodopsin there is 11-cis retinol NaL, retinol aldehyde form, which is required for the vision. If vitamin A deficiency is there, it causes night blindness. Also it causes the skin manifestation that is known as toad skin. Vitamin A is stored in the ito cells of the liver, that is also known as hepatic stellate cell, as retinal ester. The bitot spot, this can be image type question: triangular white foamy opaque spot on the conjunctiva, bitot spot, because increased keratin deposits on the conjunctiva. It is due to vitamin A deficiency. Then vitamin A toxicity is also there. Acute toxicity of vitamin A causes the pseudotumor cerebri, that is raised intracranial tension. Vitamin A toxicity damages the lysosome. It is hepatotoxic vitamin. It causes the skeletal problem causes the multiple means frequent fractures. Also vitamin A is teratogenic vitamin and hepatotoxicity. ये तो हमने already discuss किया. So this is all about the vitamin A. Now vitamin D. Vitamin D, it is the precursor is 7-dehydrocholesterol. It is synthesized in stratum corneum layer of epidermis, also in the kidney and liver and kidney. These are involved in the activation of vitamin D into calcitriol, into a calcitriol. So on exposure to the sunlight, in the stratum corneum layer of epidermis, 7-dehydrocholesterol, it is converted into cholecalciferol, which is converted into which is hydroxylated in the liver by the 25 hydroxylase and hydroxylated in the kidney by 1 alpha hydroxylase into the active form, that is 125 dihydroxy cholecalciferol. It is regulated, means vitamin D, it is important for regulation of calcium along with the parathyroid hormone and the calcitonin. Vitamin D deficiency causes rickets in children and osteomalacia in the adult. Vitamin E, the antioxidant role of vitamin E is because of alpha tocopherol. Vitamin E is present in vegetable oils. Deficiency of vitamin E causes axonal degeneration of large myelinated neurons, and vitamin E deficiency can cause the areflexia, neuropathy, myopathy, retinopathy. Vitamin E deficiency, the all functions of vitamin E, it is because of antioxidant function of vitamin E, that is alpha tocopherol. Vitamin K is required for the clotting, coagulation. It is required for the gamma carboxylation of clotting factor 2, 7, 9, 10. Gamma carboxylation of clotting factor 2, 7, 9, 10. Vitamin K, clotting factor 2, 7, 9, 10. Thiamine deficiency causes beriberi. Riboflavin deficiency causes ariboflavinosis, in which there is involvement of the circumoral region and the circumcorneal region. So there is glossitis, cheilosis, angular stomatitis like feature in the B2 deficiency, riboflavin deficiency. B3 deficiency we already discussed, causes the pellagra. B5 deficiency causes the burning feet syndrome. Pyridoxine deficiency causes neurological feature. The biotin deficiency causes mild hemolysis, rash and alopecia. Then the B9 deficiency and B12 deficiency causes the megaloblastic anemia. How to differentiate between the B9 and B12? Folic acid deficiency, neurological features are not there. Only if there is deficiency in the pregnancy, it causes neural tube defect, that is spina bifida and anencephaly. Vitamin B12 deficiency, there is increased methylmalonic acid in blood and urine. Okay, so this is the differentiating feature. Homocysteine दोनों में elevate होता है. Megaloblastic anemia is there in deficiency of folic acid and B12 both. Now coming to the minerals topic. Minerals. So minerals, they are divided into major elements and minor elements. Minor elements, they are also known as trace element. Major and minor elements. So major element, when the RDA of the mineral is more than 100 milligram per day, it is known as major element. This is known as major element if it is more than 100 milligram per day, not deciliter, per day, it is known as major element. And if requirement is less than 100 milligram per day, it is known as the trace elements or the minor element, trace elements. And if requirement is less than 1 milligram per day, it is known as ultra trace element, ultra trace. इसमें भी आते हैं actually selenium, iodine, molybdenum, ये सब ultra trace element में आते हैं. But this group ultra trace element is also included in the trace element group. So we'll discuss some important features about this minerals. So see, calcium, phosphorus, magnesium, sulfur. See, calcium, phosphorus, magnesium, sulfur, sodium, potassium, chloride. These are the major elements. These are the major elements. Calcium, phosphorus, magnesium, sulfur, sodium, potassium, chloride. Now the remaining one, so important one is the iron, copper, zinc, selenium, then selenium, iodine, molybdenum, then selenium, iodine, molybdenum, chromium. These are the fluoride. These are the trace elements. These are the trace element of this selenium, iodine, and the molybdenum, and the mineral which is having the requirement less than 1 milligram per day is also known as ultra trace elements. Okay, so see, the calcium deficiency, calcium requirement is 1000 milligram. 1000 milligram. Calcium deficiency causes the tetany. Tetany is a medical emergency. There is carpopedal spasm. There is carpopedal spasm in tetany when serum calcium level goes below 6 milligram per deciliter. This is medical emergency. Calcium deficiency causes CATS. 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 Remember, convulsion. CATS. Convulsion, arrhythmias, tetany or tremor, stridor and spasm. CATS. That CATS of hypocalcemia बोलते इसको. The CATS of hypocalcemia. Hypocalcemia. Convulsion, arrhythmia, tetany, tremor, stridor, spasm. These are the features of hypocalcemia. Calcium is regulated in our body with the help of vitamin D, parathyroid hormone, and calcitonin. Vitamin D and parathyroid hormone increases the calcium level, while the calcitonin decreases the calcium level. Iron, the important mineral iron, it is very, very important, and iron deficiency anemia is quite common in our community. Iron deficiency causes microcytic hypochromic anemia. Microcytic hypochromic anemia. The iron is absorbed through the intestine via the divalent metal ion transporter. Once it is in the intestinal cell, it comes out of the intestinal cell via the ferroportin. Transferrin is a transport form of the iron, while ferritin is a storage form of the iron, and hepcidin is a peptide which regulate the iron level. Iron deficiency causes microcytic hypochromic anemia. Zinc deficiency we already discussed. Zinc deficiency causes the DAD symptom, DAD, diarrhea, alopecia, dermatitis, delayed wound healing, then loss of taste sensation, impaired spermatogenesis, decreases the vitamin A level in the serum. And zinc is related with number of the enzyme, particularly carbonic anhydrase, superoxide dismutase, various dehydrogenase, and also important in the synthesis of various proteins. It is very, very important mineral, zinc. Zinc deficiency is related with the acrodermatitis enteropathica. This is a autosomal recessive disorder in which the enteropathica, intestinal absorption of zinc, is affected. That's why it affects the acral parts of the body, mainly distal part of the body, finger, nose, toes, mouth. These are the areas involved. It causes periorifacial dermatitis. Remember, around the mouth, around the anus, there is dermatitis in the zinc deficiency. Copper is the important mineral. It is connected with Menkes disease and Wilson's disease. So copper deficiency is there in the Menkes disease. Copper excess is there in the Wilson's disease. We'll discuss the Menkes and Wilson also. Then selenium. Selenium is the antioxidant mineral. Antioxidant mineral में क्या आता है? Selenium आता है, copper आता है, zinc आता है, और manganese आता है. Manganese and zinc, copper, these are the minerals connected with the superoxide dismutase activity, while selenium is connected with the glutathione peroxidase activity. That's why they are known as the antioxidant minerals. Okay, selenium. So deficiency of selenium, it causes Cation disease. There is cardiomyopathy, which is quite common in certain parts of the China. Selenium deficiency causes the Cation disease. There is cardiomyopathy in the Cation disease. Iodine deficiency causes the goiter. Iodine deficiency for the chronic period of time during the pregnancy and in the early childhood causes the cretinism. So iodine deficiency causes the goiter. Iodine deficiency causes the cretinism. Fluoride deficiency of fluoride. When it is less than 0.5 ppm, it causes the when in the drinking water the level is less than 0.5 ppm for chronic period of time, it causes dental caries. But when it is excess, it causes fluorosis. First initially it is a dental fluorosis. Then when it is more than 4 ppm, it causes the skeletal fluorosis. When it is more than 10 ppm, it causes crippling disease. Entire village is affected because the water is having the high fluoride level in the fluorosis. Deficiency causes the dental caries. Okay, so these are the important minerals and deficiency manifestations associated with this mineral. Remember the major elements, the minor elements, and the ultra trace element. Remember the selenium function. Selenium, it is very, very important. It is there in the glutathione peroxidase, deiodinase, and thioredoxin reductase. Apart from this, chromium is also important. Chromium increases the sensitivity of chromium. It increases the, or it potentiates the action of insulin. इंसुलिन की एक्शन बढ़ाता है, इंसुलिन एक्शन potentiates the action of insulin. So it enhances the tyrosine kinase activity of the insulin receptors. It increases the or enhances the tyrosine kinase activity of the insulin receptors. So it potentiates the action of insulin. Chromium, it is very, very important. It is also known as, it is a part of glucose tolerance factor. Which is composed of chromium plus niacin plus 3 amino acid, glycine, glutamate and cysteine. These are the part of glucose tolerance factor which potentiates the action of insulin. You may get confusing question on the selenium, not selenium, zinc and chromium. Now see, zinc, it is required for storage and release of insulin from the pancreas. It is required for storage and release of insulin from the pancreas. So it is for the storage and release of insulin from the pancreas. And chromium, it enhances or it potentiates the action of insulin. Chromium. So now coming to the new topic, that is the ABC transporters. So this is overlapping topic with many metabolism. For example, see ABCA1, it is important for the cholesterol transport. Then ABCC2, it is for the bilirubin metabolism. It is important. That's why this is very, very important question, because the diseases are related with this topic. See, ABCA1, actually these are the types of the primary transporters, primary active transporters. Primary active transporter is of 4 types. One is factor type, one is phosphorylated type, one is vacuolar type, and the fourth one is the ABC transporter, ATP binding cassette transporters. So see, these are the transporters. These are required for transport of some compounds. Now see, ABCA1, ATP binding cassette transporter A1, it is required for transport of the cholesterol. It is required for the transport of cholesterol. This is a cholesterol from the peripheral tissues. This is peripheral tissues to the HDL. It is transport of cholesterol from peripheral tissue to the HDL. This is very, very important. This is ABCA1. This is a transporter. ABCA1, ABCG1 and scavenger receptor B1. These are required for transport of cholesterol from peripheral tissues to the HDL. Transport of cholesterol from peripheral tissues to the HDL. ABCA1. ABCC2 or MRP2 or the MOAT, that is multispecific organic anion transporter. This is very, very important. So this is required for transport of bilirubin. Means this is required for active secretion of bilirubin into bile canaliculi. This is required for active secretion of bilirubin into bile canaliculi, and this is the rate limiting step in the bilirubin metabolism. This step is the rate limiting step in the bilirubin metabolism. This is very, very important. Rate limiting step in the bilirubin metabolism. Okay, so defect, we'll discuss the defect later, but first we'll discuss the function. Then ATP7A, ATP7B. ATP7A, it is required for absorption of copper from the intestine, and ATP7B, it is required for incorporation of copper into ceruloplasmin, and excretion of copper into a bile, ATP7B is required. CFTR, cystic fibrosis transmembrane regulatory protein, this is required for the transport of the chloride ions. And MDR1, this is to pump out the chemotherapeutic agent out of the cancer cell, and this is responsible for resistance to the treatment of the cancer. Okay, now the diseases related with this, see, if there is mutation in ABCA1 transporter, it causes Tangiers disease. It causes Tangiers disease. Tangiers disease. We'll discuss this Tangiers disease. This is alpha lipoprotein deficiency in which there is zero to low HDL level. Zero to low HDL level in this disease. HDL disease. Actually, this cholesterol makes the HDL particle spherical. Otherwise, it is nascent, चपका हुआ HDL रहता है. It becomes spherical after getting the cholesterol and esterified cholesterol. So transport of cholesterol from peripheral tissue to the HDL. If there is defect in the ABCA1, it causes the Tangiers disease. This is alpha lipoprotein deficiency in which zero to low HDL level is there. Apart from this, there is hepatosplenomegaly, and one classical feature, that is orange color, yellow-orange tonsil. Yellow-orange tonsil is there. So yellow-orange tonsil, hepatosplenomegaly, and the neuropathy. These are the features, and zero to low HDL levels are there in the Tangiers disease. Orange color tonsil is pathognomic or the classical for the this Tangiers disease. ABCC2 or MRP2 or the multispecific organic anion transporter, when there is defect in this transporter, it causes the Dubin-Johnson syndrome. Dubin-Johnson syndrome, also known as black liver jaundice because of accumulation of epinephrine metabolite. So Dubin-Johnson syndrome. There is raised direct bilirubin level in the Dubin-Johnson syndrome. Then ATP7A mutation, remember A is first, so that's why Menkes disease, and B is second, that's why it is Wilson disease. M first, followed by the W. So Menkes disease, Wilson's disease, AB. So A mutation in the ABCA, it causes the Menkes disease. This is neurodegenerative disorder in which there is mental retardation, hypopigmented patches, and kinky hair. That is also known as Menkes kinky hair syndrome because of affected lysyl oxidase, which is copper dependent enzyme which is required for the collagen cross linking. So Menkes disease, ATP7A mutation, the copper deficiency. ATP7B mutation, it causes Wilson's disease. Wilson's disease, that is known as hepatolenticular degeneration. There is accumulation of copper in the liver and lenticular nucleus of the brain, characterized by KF ring around the cornea, in the descending membrane of the cornea, KF ring, that is known as Kager-Fleischer ring. The confirmatory diagnosis is by liver biopsy and quantification of copper in the liver per gram of the liver tissue. It is more than 250 microgram per gram of the liver tissue, which is confirmatory test or gold standard test for the diagnosis of the Wilson's disease. So ATP7B mutation causes the Wilson's disease. Chloride transporter defect, this mutation causes the cystic fibrosis. Cystic fibrosis. There is one movie, the Hollywood movie, the 5 feet apart. Also one movie is there, South Indian movie, Hi Papa. The Hindi conversion is there, Hi Papa. There is one term that is the cystic fibrosis related term, that is cystic fibrosis. So it is this is obstructive lung disease, and there is thick mucus secretion. Because of the thick mucus secretion, the obstruction to the airway occurs, and there is frequent chances of the getting infection. So this is cystic fibrosis. Chloride channels, chloride transporters are affected in the cystic fibrosis. Then MDR1 mutation causes the cancer, matlab resistance to the cancer treatment. So these are the some transporter proteins and the diseases related with this protein. ABCA1 mutation, Tangiers disease. ABCC2 or MRP2, Dubin-Johnson syndrome. ATP7A, Menkes disease. ATP7B, Wilson's disease. CFTR, that is cystic fibrosis. MDR1, the resistance to the cancer treatment. Now coming to the enzymatic markers for the different subcellular organelles. Just wait. enzymatic marker of different membrane. So for the subcellular fractionation, means we centrifuge the subcellular these organelles in the sucrose density gradient, and after separation in the ultracentrifuge in the sucrose density gradient, the different layers, they are tested for the different markers to confirm the subcellular organelles. So these are the markers for the subcellular organelles. Recently this topic is gaining the importance. This is a chart from the Harper's Illustrated Biochemistry. Okay, so for the plasma membrane, the markers includes the it is adenylyl cyclase, 5' nucleotidase, and sodium potassium ATPase. So 5' nucleotidase, adenylyl cyclase, and sodium potassium ATPase, these are the markers for the plasma membrane. ER, endoplasmic reticulum, it is glucose 6 phosphatase. Inner mitochondrial membrane, it is ATP synthase. Golgi apparatus, it is galactosyl transferase for the Golgi apparatus. For the cytoplasm, it is LDH, that is lactate dehydrogenase. For the lysosome, it is cathepsin or acid phosphatase, and peroxisome, it is catalase. These are the markers for the subcellular organelles. Now remember, ER, it is glucose 6 phosphatase. Remember galactosyl transferase for the Golgi apparatus, and remember the lysosomal markers, that is cathepsin and acid phosphatase. These are important markers for the subcellular organelles, for the conformation of subcellular organelles. Now coming to the core biochemistry topic, the metabolism, the pathway, the regulation related with the pathway. Now remember this is the these are the pathways and these are the rate limiting enzyme. So one by one we'll go. Fatty acid synthesis, it is ACC, that is acetyl coenzyme carboxylase, regulated by CID, citrate, insulin, and dephosphorylated state of the enzyme. Acetyl coenzyme carboxylase is the rate limiting enzyme of fatty acid synthesis of palmitic acid, stearic acid. It is the starting molecule is acetyl coenzyme A, and the rate limiting enzyme is acetyl coenzyme carboxylase. The activity is promoted by the citrate. Citrate activates the acetyl coenzyme carboxylase, insulin, citrate, insulin, and dephosphorylated state of the enzyme. Acetyl coenzyme carboxylase. Okay, it is active in the dephosphorylated state. Glycolysis, it is phosphofructokinase, which is a rate limiting or bottleneck in the glycolysis. Phosphofructokinase 1, it is inhibited by citrate. It is activated by this phosphofructokinase. It is activated by the adenosine monophosphate. It is activated by the fructose 2,6 bisphosphate molecule. Remember this is very important. The regulator, these regulators are very important. Remember, fatty acid synthesis, it is activated by the citrate, but citrate inhibit the phosphofructokinase, the rate limiting enzyme of the glycolysis. Phosphofructokinase, it is activated by AMP and fructose 2,6 bisphosphate, it is inhibited by the citrate level. Beta oxidation of fatty acid or palmitic acid or stearic acid, it is carnitine acyl transferase 1, which is the rate limiting enzyme. It is inhibited by malonyl coenzyme A, which is synthesized in the fatty acid synthesis under the influence of insulin. So insulin will indirectly inhibit this carnitine acyl transferase 1. Gluconeogenesis, rate limiting enzyme is fructose 1,6 bisphosphatase. Ketone body synthesis, it is HMG coenzyme synthase. Ketone body synthesis, it is HMG coenzyme synthase. Cholesterol synthesis, it is HMG coenzyme reductase, hydroxymethyl glutaryl coenzyme reductase. This is the rate limiting enzyme. So statins group of drugs act on HMG coenzyme reductase. This is active in the dephosphorylated state. Dephosphorylated state may remember 5 enzymes, they are active in the dephosphorylated state. 5 important one to remember which are active in the dephosphorylated state. One is acetyl coenzyme carboxylase. Acetyl coenzyme carboxylase. This is important. Second one is pyruvate dehydrogenase complex. Third one is HMG coenzyme reductase. This is active in the dephosphorylated state. Then fourth one is the glycogen synthase, glycogen synthase. This dephosphorylated state, it is favored by the insulin. So remember this, insulin favor the dephosphorylated state of the enzyme, and in dephosphorylated state, this is also a table from the Harper, which is very important. There is mention phosphorylated and dephosphorylated state, active and inactive enzyme. So insulin favors the dephosphorylated state. It activates acetyl coenzyme carboxylase, pyruvate dehydrogenase complex, HMG coenzyme reductase, glycogen synthase, and enzymes of glycolysis. These are active in the dephosphorylated state. Okay, glycogen synthesis, the important enzyme is glycogen synthase, which is active in the dephosphorylated state. Then glycogen degradation, it is glycogen phosphorylase. Remember, two very important top rated, highly rated MCQ for the glycogen phosphorylase. This is the activated by allosteric activator. Two important allosteric activator. One is AMP in the muscle. AMP in the muscle activate the AMP in muscle directly activate the glycogen phosphorylase, while the calcium is the indirect activator. Calcium activates the phosphorylase kinase, and phosphorylase kinase activates the glycogen phosphorylase. So these are the two. Last 2 year there were MCQ on this glycogen phosphorylase activation regarding AMP and calcium. दोनों पे आके गया है. So glycogen phosphorylase is activated by AMP directly and it is activated by calcium indirectly. So these are the activator, allosteric activator of glycogen phosphorylase. Then TAG, मतलब triacyl glycerol degradation, that is lipolysis. It is promoted by the hormone sensitive lipase in response to glucagon, in response to fasting condition. In response to fasting and glucagon, this hormone sensitive lipase causes the degradation of triacyl glycerol. Heme synthesis, important enzyme is ALA synthase. Urea cycle, it is CPS1, that is carbamyl phosphate synthetase 1. Purine nucleotide synthesis, it is glutamyl amidotransferase. PRPP, glutamyl amidotransferase for the purine nucleotide synthesis. So these are the rate limiting enzymes of some pathways. Okay, so this is important to remember. This is a core biochemistry. The pathway, the regulatory enzymes, and how it is regulated. Remember specifically the citrate. Remember this molecule fructose 2,6-bisphosphate, which activates the phosphofructokinase. Remember this activators of glycogen phosphorylase, that is AMP and calcium. Remember hormone sensitive lipase, it is active in fasting state when there is release of glucagon, which causes the TG hydrolysis. Okay, now the energetics, some important energetics. Remember the Rappaport-Lubering cycle, RL cycle, and the HMP shunt. The net ATP production is zero ATP production in the RL cycle and HMP shunt. Remember this, there is production of NADPH in the HMP shunt. So NADPH it is important for the oxidant role. It is not antioxidant role. It is not for the ATP production. So anaerobic glycolysis, 2 ATPs are produced when there is conversion into lactate, specifically in the RBCs it is important, and the rapidly exercising muscle it is important. Anaerobic glycolysis 2. Okay, that lactate is diverted, or this is lactate is carried to the liver for the gluconeogenesis, that is known as the lactate cycle or Cori cycle. That is known as Cori cycle. So anaerobic glycolysis 2 ATPs are produced. Aerobic glycolysis 7 ATPs are produced. Complete oxidation of one glucose molecule, 32 ATPs are produced. How 32 ATPs are produced? By the complete oxidation of glucose molecule. See, aerobic glycolysis 7, PDH complex 2.5 plus 2.5, that is 5 ATPs. Per turn of TCA cycle 10 plus 10. 2 molecules of pyruvate they are generated. 2 molecules of acetyl coenzyme generated in the glycolysis 2 pyruvate and PDH complex 2 acetyl coenzyme A. So that will give you 7 plus 5 plus 10 plus 10, total 32 ATPs for oxidation of glucose molecule. One glucose molecule will give you 32 ATPs. Oxidation of palmitic acid having the 16 carbon, 106 ATPs. And oxidation of stearic acid will give you 120 ATPs. Rappaport-Lubering cycle 0 ATPs, and the glycolysis in RBCs, cancer cell means anaerobic glycolysis, that is 2 ATPs. Anaerobic glycolysis 2 ATPs. So this is important energetics. Remember this, RL cycle and the HMP shunt will give you 0 ATP. Now some inborn errors and the related deficient enzyme. This is will tell you in the diagrammatic way. See, The important inborn errors from the protein metabolism, that is the phenylalanine tyrosine metabolism. If there is block in the conversion of phenylalanine to tyrosine, this is phenylalanine hydroxylase that causes phenylketonuria. So this is PKU, phenylketonuria, that is phenylalanine hydroxylase defect. Phenylalanine hydroxylase defect, that is the deficiency causes the phenylketonuria, and the variant is there in which biopterin is deficient that causes the other types of phenylketonuria. Okay, then tyrosine to parahydroxy phenylpyruvate. This is tyrosine transaminase. So deficiency of tyrosine transaminase causes tyrosinemia type 2. This is tyrosinemia type 2. Okay, this parahydroxy phenylpyruvate, it is by the dioxygenase, it is converted into homogentic acid, gentisate. This is parahydroxy phenylpyruvate hydroxylase or dioxygenase. So this is parahydroxy phenylpyruvate dioxygenase या hydroxylase deficiency. This causes neonatal tyrosinemia. This is neonatal tyrosinemia or also known as tyrosinemia type 3. Homogentisate is converted into 4-mallyl acetoacetate. This is required homogentisate oxidase, and deficiency causes homogentisate oxidase. Deficiency causes the alkaptonuria. This is alkaptonuria. Staining alkaptonuria. This is staining of the urine turn dark on standing, the staining of the cartilage, nose cartilage, ear cartilage staining occur. There is tendency to develop arthritis in the latter ages after the age of 30. 4-mallyl acetoacetate is converted into 4-fumaryl acetoacetate, and 4-fumaryl acetoacetate is hydrolyzed into fumarate, which will give you glucose, and acetoacetate. It is converted into acetoacetate. This is enzyme is fumaryl acetoacetate hydrolase. It is fumaryl acetoacetate hydrolase. Now see the enzymes and the diseases. This deficiency is phenylketonuria. This is tyrosinemia type 2, that is TT, tyrosine transaminase. 2 T's are there. So deficiency causes tyrosinemia type 2. Parahydroxy phenylpyruvate dioxygenase or hydroxylase causes neonatal tyrosinemia or tyrosinemia type 3, also known as tyrosinemia type 3. Homogentisate oxidase defect causes alkaptonuria, and fumaryl acetoacetate hydrolase defect causes tyrosinemia type 1. Type 1, there is cabbage like order in the tyrosinemia type 1. Now see these disorders. Phenylketonuria, there is phenylalanine hydroxylase defect. Alkaptonuria, homogentisate oxidase defect, also known as homogentisate dioxygenase. Albinism, there is defective tyrosinase defect in the that is melanin synthesis. Homocysteinuria, that is cystathionine beta synthase defect, which is pyridoxal phosphate dependent, and you should able to differentiate between homocysteinuria and the Marfan syndrome. We'll take this later. Homocysteinuria and Marfan syndrome, specifically on the basis of the subluxation of lens. In the homocysteinuria, it is inferonasal or inferomedial subluxation of lens. There is downward subluxation of lens in the homocysteinuria, while Marfan syndrome, there is upward and the outward direction subluxation of lens occur. Maple syrup urine disease, this is branchine ketoacid dehydrogenase defect. There is intellectual disability in the maple syrup urine disease, and smell of urine, maple syrup, burnt sugar, smell of burnt sugar is there in the maple syrup urine disease. Primary hyperoxaluria, it is a protein targeting defect in the enzyme involved in the glyoxylate to glycine conversion, that is known as the transferase, also known as alanine glyoxylate aminotransferase. Galactosemia, galactose 1-phosphate uridyl transferase defect. Hereditary fructose intolerance typically manifests in the weaning period when during the adult food introduction to the child, we give the fruit pulp or the sucrose rich fruit in which fructose is there, and when we give the fructose rich diet, when when the child is deficient with the aldolase B enzyme, it will manifest as hereditary fructose intolerance can manifest as hypoglycemia, jaundice, or there may be excretion of fructose in the urine, which is detected by the Sullivanov and rapid furfural test. Then essential pentosuria, there is excretion of L-xylulose in the urine. The deficient enzyme is xylitol dehydrogenase. Essential pentosuria, xylitol dehydrogenase, uronic acid pathway defect. Drug-induced hemolytic anemia, it is related with the HMP shunt, hexose monophosphate shunt. When the affected HMP shunt, there is decreased NADPH production, and when person is exposed to the primaquine or any oxidant drug or sulfur drug or acetanilide or dapsone, or the favabin consumption or the severe infection can trigger this glucose 6-phosphate dehydrogenase deficiency, which causes the drug-induced hemolytic anemia because of the HMP shunt, affected HMP shunt. This is the X-linked recessive disorder in which the males are commonly affected, females are carrier, and there is hemolytic anemia when we give the primaquine or sulfur drug or favabin consumption or the severe infection. So it causes drug-induced hemolytic anemia. HMP shunt is affected. Lactose intolerance is the congenital lactase deficiency in which the intestinal brush border enzyme lactase is deficient, and if you stop the breast milk, the symptoms will disappear. So this is lactose intolerance. There is bloating, there is flatulence, there is abdominal distension and excessive cry in children after the breastfeed because of the lactose intolerance. So in such cases, avoid the lactose in the diet, give the commercial preparation, lactose free or galactose free commercial preparation. Leishman syndrome, it is related with the purine salvage pathway. Deficient enzyme is hypoxanthine guanine phosphoribosyl transferase. So there is mental retardation, there is self-mutilating activity like head banging or biting the finger and nails or lips. Lip biting is there, self-mutilation behavior, and increased uric acid is there in the Leishman syndrome. There is hyperuricemia in the Leishman syndrome, uric acid level increases. Leishman syndrome, it is because of the HGPRTase deficiency. This is purine salvage pathway. It is particularly important for nucleotide synthesis in brain and RBCs. Then orotic aciduria, there is excretion of orotic acid in the urine. Also there is megaloblastic anemia and the failure to thrive like features. It is because of UMP synthase defect, which is composed of two important enzymes, that is OMP decarboxylase and the OPRTase, orotodine phosphoribosyl transferase defect. So OMP decarboxylase or OPRTase defect, this together is known as UMP synthase. So these are the some important disorders and inborn errors and related enzyme deficiency. For this topic, go the system wise. If you go system wise, you can easily remember the metabolic disorders and the affected enzyme. Carbohydrate, go start with the do each and every clinical case from the biochemistry. These are the very, very important clinical cases, and these are connected with the pediatric, these are connected with the medicine. So these are very, very important clinical cases. For example, take carbohydrate metabolism. It is galactosemia, it is G6PD deficiency, it is hereditary fructose intolerance, it is lactase deficiency, it is sucrase deficiency. The important clinical case, for example, diabetic ketoacidosis, diabetes mellitus, and the glycogen storage disorder. These are the very, very important cases from the carbohydrate metabolism. Protein metabolism, phenylketonuria, alkaptonuria, tyrosinemia type 1, type 2, type 3, primary hyperoxaluria, which is related with the glycine metabolism, then homocystinuria, which is related with the methionine and cysteine metabolism. Then the maple syrup urine disease, which is connected with the branch chain amino acid metabolism. So these are the very, very important disorder. From the lipid metabolism, beta oxidation of fatty acid, alpha oxidation disorder, that is the Repsom's disease. Then hyperlipoproteinemias, the lysosomal storage disorder, Gaucher, Niemann-Pick. Yes, sub important is do these all important clinical cases. These are very, very important for the FMGE entrance examination. Okay. Now coming to this image based question, this is a solute concentration and this is absorption rate or the transport rate, percent maximal rate, that is transport rate, and this is a solute concentration. Now there may be question on the interpretation of red line or green line. Red line or green line. This is a graph from transport across the cell membrane. This is a graph from the Harper's illustrated biochemistry. Now see, you will see the direct relationship between the solute concentration and the transport rate. It is the straight line. It is a straight line in case of passive diffusion. This is a passive diffusion. This is passive diffusion because no transporter is involved here. No transporter. All of you know that it is down the gradient. It is the passive diffusion. It is down the gradient. No ATP is needed. No transporter is needed. Whenever there is need of the transporter, there is saturation kinetic. It follows the saturation kinetic. It is ability of that transporter. There is certain limit of that transport to transport certain ions or solute. So that's why it shows the enzyme like kinetic, that is known as saturable kinetic. So this green line, it shows the transport without involvement of the transport protein, that is the simple passive diffusion. This is a simple diffusion, passive diffusion, and this is a carrier mediated transport. For example, facilitated diffusion. This is a facilitated diffusion and active transport, either primary active and secondary active transport. So here for the facilitated diffusion, carrier is needed, carrier molecule is needed, transporter is needed, active transport, primary active transport or secondary active transport. Transport protein is needed. Whenever there is requirement of transport protein, it follows saturable kinetic. So this is carrier mediated diffusion, either facilitated diffusion or the active transport, whether primary or secondary active transport. This is no carrier is needed in the passive diffusion. Okay, so this is the image showing the kinetic of carrier mediated diffusion with passive diffusion. So this is passive diffusion, this is facilitated diffusion or the active transport. Now these are the different types of inhibition, and this type of graph is known as Line-Weaver-Burke double reciprocal plot. So this is Line-Weaver-Burke double reciprocal plot. When you see the X-shaped graph, it indicates competitive inhibition. It indicates competitive inhibition. So remember this, in competitive inhibition there is X-shaped graph. In competitive inhibition, Km increases and Vmax remain same. Vmax remains same. Remember, this type of inhibition, competitive inhibition, there is competition with the substrate to bind with the active site of an enzyme molecule. This type of inhibition can be overcome by increasing the substrate concentration. So in this type of inhibition, when you increases the substrate concentration, this type of inhibition can be overcome. Km is nothing but the substrate concentration to achieve half of the Vmax. Km is nothing but the substrate concentration to achieve the half of the Vmax. Increasing substrate concentration can overcome this type of inhibition. That's why Km increases, Vmax remains same in the competitive inhibition. Okay, this is the X-shaped graph. Then V-shaped graph, it is a non-competitive inhibition. This is a graph of non-competitive inhibition. This can be an image-based question. Non-competitive inhibition. Generally, the inhibitors of electron transport chain, these are the irreversible non-competitive inhibitors. Most of these are irreversible non-competitive inhibitors except the malonate. Malonate is a competitive inhibitor, okay, which inhibits succinate dehydrogenase. So V-shaped graph is there in the non-competitive inhibition. In non-competitive inhibition, the Km remains same and Vmax get lowered. And in the uncompetitive inhibition, you may get the parallel lines. Vmax and Km both decreases in the uncompetitive inhibition. Very rare type of inhibition, uncompetitive inhibition. High level of phenylalanine inhibit the placental alkaline phosphatase. Uncompetitive inhibition, parallel lines. So remember, X-shaped graph, it is a competitive inhibition. V-shaped graph, it is a non-competitive inhibition, and the parallel lines both decreases. It is a uncompetitive inhibition in the enzyme inhibition. So identify drug Z in the given image. This is acting on the vitamin K reductase, vitamin K epoxide reductase. This is Z. Here is the oral anticoagulant warfarin or dicumarol. Warfarin or dicumarol. Now see, this is vitamin K activity. Vitamin K, it is required for the post translational gamma carboxylation of clotting factor, gamma carboxylation of clotting factor 2, 7, 9 and 10. Remember this, post translational gamma carboxylation of clotting factor 2, 7 and 9 and 10. So what is the effect? See, NH CO, this is peptide, this is glutamate in the peptide, this is CH2, this is CH. So one carboxyl group is there in the glutamate. This is a glutamate structure, CH2COO, CH2COO. This is a glutamate structure. So this is alpha carbon, this is beta carbon, this is gamma carbon. So vitamin K causes the carboxylation of this gamma carbon. It added additional carboxyl group. Additional carboxyl group is added by the vitamin K activity, carboxylase activity, and this can form complex with the calcium. So for formation of complex with the calcium, this is very important step in the clotting process. So vitamin K, this topic, vitamin K, it is integrated topic with the genetic, that is post translational gamma carboxylation. That's why it is important topic. So vitamin K activates factor 2, factor 7, factor 9 and factor 10. You may get MCQ on this, or you may get MCQ on this. Post translational gamma carboxylation is a function of, remember this, see, for the carboxylation process, you need biotin, vitamin B7, that is biotin, vitamin B7 biotin. For example, acetyl coenzyme carboxylase, propionyl coenzyme carboxylase. So for carboxylation you need biotin. For gamma carboxylation of clotting factor, you requires vitamin K. Vitamin K is required, gamma carboxylation. For oxidative decarboxylation, what is required? For oxidative decarboxylation, what is required? Thymine pyrophosphate, vitamin B1. Thymine pyrophosphate is needed for oxidative decarboxylation. For example, pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, or branch-chain keto acid dehydrogenase complex. And for the decarboxylation only, decarboxylase activity, decarboxylation, pyridoxal phosphate is needed for the synthesis of neurotransmitter. Vitamin B6 pyridoxal phosphate is needed. Remember this. So this is carboxylation. See, mainly acetyl coenzyme carboxylase, propionyl coenzyme carboxylase. So acetyl coenzyme carboxylase, propionyl coenzyme carboxylase requires biotin, vitamin B7. Clotting factor 2, 7, 9, 10 activation requires vitamin K. The oxidative decarboxylation, that is the pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, branch chain keto acid dehydrogenase complex. This requires vitamin B1, thymine pyrophosphate, and decarboxylation for synthesis of neurotransmitter. For glutamate is converted into GABA, or the dopa is converted into norepinephrine. Dopa is converted into dopamine. For this requires the decarboxylation reaction, which requires the pyridoxal phosphate. So these are the important reactions to remember. So here, this is warfarin or dicumarol. These are oral anticoagulant which inhibit the enzyme vitamin K epoxide reductase. So they are oral anticoagulant drug, the competitive inhibitors of vitamin K epoxide reductase. Which drug is used in the treatment of gout as a drug of choice? So all of you know this answer. The allopurinol is a drug of choice. This is known as podagral gout. Involvement of first metatarsophalangeal joint. This is most commonly affected joint in the gout. So it is the drug of choice is allopurinol, which is a competitive inhibitor as well as the suicide inhibitor, competitive inhibitor as well as suicide inhibitor of enzyme xanthine oxidase. Competitive inhibitor, initially it is a competitive inhibitor. Once it attaches to the xanthine oxidase causes the conversion of allopurinol into alloxanthine, and alloxanthine is a more potent inhibitor of xanthine oxidase. So it is competitive and suicide inhibitor of the xanthine oxidase, decreases the synthesis of uric acid, so relieves the symptoms of gout. So gout, the drug of choice is allopurinol. The confirmatory test, the diagnosis confirmatory test is the monosodium urate crystal. Monosodium urate crystals. So this is microscopy, aspiration of synovial fluid, and microscopy in which you will see negatively birefringent urate crystals in the polarized microscopy. So monosodium urate crystal in the microscopy, this is aspiration, and microscopy is a gold standard test for the diagnosis of gout. The treatment of choice is allopurinol. Okay, so this is enzyme. It is xanthine oxidase, which is inhibited by the xanthine oxidase enzyme, which is inhibited by the allopurinol. So identify the enzyme X targeted by the allopurinol in the picture given below. So it act on the xanthine oxidase enzyme, decreases the synthesis of uric acid, decreases the symptoms of gout. Allopurinol. These are the some inhibitors, competitive inhibitors, and these are the examples. See the match the pair question है. So see dicumarol, अभी हमने देखा dicumarol is a it inhibits the vitamin K epoxide reductase. So dicumarol inhibit the vitamin K epoxide reductase. Statin, lovastatin, HMG coenzyme A reductase, inhibit the HMG coenzyme A reductase. This is a statin which decreases the cholesterol level. Allopurinol inhibit the xanthine oxidase. Just wait. Allopurinol inhibit the xanthine oxidase, and methotrexate inhibit the, क्या गलत हो गया, just wait. Dicumarol inhibit the vitamin K epoxide reductase. Lovastatin inhibit the HMG coenzyme A reductase. Allopurinol inhibit the xanthine oxidase, and methotrexate inhibit the dihydrofolate reductase. These are the competitive inhibitors. Dicumarol, oral anticoagulant, lovastatin to lower the cholesterol level in the patient with CAD or the atherosclerosis. Allopurinol in the treatment of the gout. Methotrexate, it is an anti-folate drug, folate antagonist. It is anti-cancer drug. Methotrexate. Yeah, we already discussed this. Red vacuum thinner. It is mainly for the, this is a plain bulb. This is without any anticoagulant. This is without any anticoagulant. This is known as plain bulb, which is used for the mainly serum parameters in the biochemistry. For example, LFT, liver function test, KFT, lipid profile, electrolytes. This is preferred tube for this investigation. This is EDTA tube. It is mainly for the CBC analysis, also for the HbA1c estimation. CBC analysis, HbA1c estimation, also for the interleukins. This EDTA bulb is used. This is a fluoride gray cap tube. This is a fluoride bulb. It is for the glucose. Estimation. Fluoride inhibit the enzyme enolase of glycolysis. We already discussed this table regarding the anticoagulant. Then important topic, that is glutes, glucose transporters. There are various glucose transporters. इसमें से the first 5 glucose transporters, their distribution is very, very important. Also, one important question is there from on the glutes, that is GLUT4. It is insulin sensitive glucose transporter. GLUT4, GLUT8 and GLUT12. These are the insulin sensitive glucose transporter. Just wait. Let me see. Is everything okay or not? Now see, glucose transporters, the first 5, these are very, very important glucose transporter. GLUT1, most widely distributed glucose transporter. It is present in, you can remember the mnemonic for this, the Kohli plays for RCB. So it is kidney, placenta, RBCs, brain, that is blood-brain barrier, brain, and the colon. Okay, kidney, placenta, RBC, brain, and colon. It is GLUT1, which is widely distributed. It is required for the basal glucose uptake. GLUT2, it is present on other side. GLUT2, it is present on other side. It is present on basolateral surface of the intestinal cell, also basolateral surface of the proximal convoluted tubule. It is present in the sinusoidal surface of the liver, also in the beta cells of the pancreas. It is required for the glucose regulation. It is important for the regulation of the glucose. Liver, pancreas, basolateral surface of intestine, and basolateral surface of proximal convoluted tubule. Once the glucose enters into the intestinal cell, this is lumen, this is intestinal cell, So once glucose enters into the cell via the sodium dependent symport via the SGLT1, this is SGLT1, sodium dependent glucose transporter 1. Once glucose enter into the cell, it exit out of the cell through GLUT2, GLUT2. It is the glucose transporter which is present on the basolateral surface, other surface of the intestinal cell, also proximal convoluted tubule. GLUT3, it is present mainly it is present in neuron and placenta. GLUT3. Neurons, it is GLUT3. Blood-brain barrier, it is GLUT1. Remember, blood-brain barrier GLUT1, GLUT3, it is present in the neuron. GLUT4, it is present in the skeletal muscle, heart, and adipose tissue. Skeletal muscle, heart, and adipose tissue. It is GLUT4. It is insulin dependent glucose transporter, also 8 and 12. GLUT4, 8 and 12, these are the insulin dependent glucose transporter, GLUT4. GLUT5, it is present in the small intestine, it is present in the testes. It is for the absorption of fructose. So it is GLUT5, which is important for the transport of the fructose, absorption of the fructose in the intestine. So small intestine, testes and sperm, there is GLUT5. GLUT7, it is present in endoplasmic reticulum. It is for the transport of glucose in the endoplasmic reticulum. This GLUT7 is required. First 5 glucose transporters, these are very, very important. Principally, the distribution of GLUT4 and GLUT1 is important. GLUT1 is distributed in kidney, placenta, RBC, brain, and colon. While GLUT4, it is skeletal muscle, adipose tissue, and heart. GLUT4 is insulin dependent glucose transporter. These are the bidirectional glucose transporters type of the facilitated diffusion. Okay. Now coming to the glycosaminoglycans, GAGs. Glycosaminoglycans are also known as heteropolysaccharides or mucopolysaccharide. Their distribution and the disorder related with the glycosaminoglycans. So there are 6 glycosaminoglycans important: hyaluronic acid, chondroitin sulfate, dermatan sulfate, heparin, heparan sulfate, and keratin sulfate. Okay, so for remembering the composition, just remember this mnemonic to remember the composition of this. See, this is hyaluronic acid, this is chondroitin sulfate, this is dermatan sulfate, this is heparin, This is heparan sulfate and this is keratan sulfate. So the composition wise keratan sulfate is completely different. So you cannot remember with the keratan sulfate with the help of mnemonic. So it is N-acetyl glucosamine, N-acetyl glucosamine plus galactose. N-acetyl glucosamine plus galactose, that is keratan sulfate. While these are, remember these like this. So those who starts with the H is having the N-acetyl glucosamine. So there is N-acetyl glucosamine. Remember, these are the repeating disaccharide unit composed of amino sugar plus uronic acid. So this will repeat amino sugar, uronic acid, amino sugar plus uronic acid. This will repeat in this heteropolysaccharide or mucopolysaccharide or glycosaminoglycan. So one amino sugar, one uronic acid. So this is the disaccharide, repeating disaccharide unit. Amino sugar, uronic acid. So amino sugar can be N-acetyl glucosamine or galactosamine. N-acetyl glucosamine or galactosamine, and the uronic acid is glucuronic acid or iduronic acid. Glucuronic acid or iduronic acid. So structure wise, those who starts with the H is having the N-acetyl glucosamine. So N-acetyl glucosamine, also the heparan sulfate N-acetyl glucosamine. Those who do not start with the H is having the N-acetyl galactosamine. N-acetyl galactosamine. So N-acetyl galactosamine for dermatan sulfate also. Now sir, uronic acid. So the keratan sulfate is not having the uronic acid. This is important MCQ. No uronic acid in the keratan sulfate structure. There is no uronic acid. All the glycosaminoglycan is having the D-glucuronic acid. D-glucuronic acid. All having D-glucuronic acid, except this dermatan sulfate, which is having the L-iduronic acid, which is a C5 epimer of glucuronic acid. L-iduronic acid. Okay. Rest of the glycosaminoglycan is having the D-glucuronic acid. So this is D-glucuronic acid. D-glucuronic acid. Heparin is having the D-glucuronic acid. Also the L-iduronic acid. Means either this or D-glucuronic or L-iduronic acid. And heparan sulfate is also having the D-glucuronic acid or L-iduronic acid in the disaccharide unit. Now remember, the heparin is with the more amount of this L-iduronic acid, and heparan sulfate is with more amount of D-glucuronic acid. So this is distribution. Those who start with the H is having the N-acetyl glucosamine. All the glycosaminoglycan is having the D-glucuronic acid in their structure, except dermatan sulfate, which is having the L-iduronic acid only. No D-glucuronic acid is here. Keratan sulfate, there is no uronic acid in the structure. This is important MCQ. It is N-acetyl glucosamine plus galactose. This is how to remember the composition of this glycosaminoglycan. So hyaluronic acid, it is present in the synovial fluid. It is present in the synovial fluid and vitreous humor of the eye. It acts as a lubricant, shock absorbent. It is required for the cell migration. And it is required for the wound repair. Cell migration, wound repair. Wound repair के लिए कोलेजन लगता है. wound repair के लिए जिंक लगता है. wound repair के लिए विटामिन सी लगता है. wound repair के लिए hyaluronic acid लगता है. Okay. Chondroitin sulfate, it is present in cartilage, bone, tendon. Chondroitin sulfate, it is important for compressibility of the cartilage in the wet bearing. Along with the hyaluronic acid, it is important for shape and structure of the cartilage, bone and tendon. So shape and structure of cartilage, bone and tendon. It is important for compressibility of cartilage in the wet bearing along with the hyaluronic acid. So it is important. Chondroitin sulfate is for the compressibility of the cartilage. Dermatan sulfate, it is N-acetyl galactosamine plus L-iduronic acid. L-iduronic acid. It is present in skin, walls and sclera, blood vessel. It is present. It is important for shape and structure of these tissues. Dermatan sulfate. Derma means skin. Heparin, it is anticoagulant. It is composed of N-acetyl glucosamine plus L-iduronic acid or D-glucuronic acid. Mostly it is L-iduronic acid, 90%. It is present in lung, mast cell, blood and skin. It is oral anticoagulant and it is also required for release of lipoprotein lipase from the capillary endothelium. Anticoagulant causes release of lipoprotein lipase from the capillary endothelium. Heparan sulfate, it is the N-acetyl glucosamine plus D-glucuronic acid or L-iduronic acid. It is present in the basement membrane. It is present in the capillary endothelium and it is present in the synaptic vesicles. So basement membrane, capillary endothelium and the synaptic vesicle. It is responsible for charge selectiveness of the glomerular basement membrane. It acts as a receptor on the surface of the cell surface. It acts as a cell surface receptor. Negative charge on the glomerular basement membrane. This is first function. Second, it is having the anchoring role to lipoprotein lipase to the capillary endothelium. It is present in the synaptic vesicle. It is important for cell adhesion and cell-cell interaction. So it participates in cell adhesion and cell-cell interaction. Attachment of lipoprotein lipase to the capillary endothelium and act as a receptor and participate in the cell adhesion and cell-cell interaction. तो हिपेरन सल्फेट के फंक्शन पे आपको MCQ आ सकता है. चार्ज सिलेक्टिवनेस ऑफ ग्लोमेरुलर बेसमेंट मेम्ब्रेन, anchoring role to lipoprotein lipase to the capillary endothelium, act as a cell surface receptor, important in cell adhesion and cell-cell interaction. Heparan sulfate. Keratin sulfate is N-acetyl glucosamine plus galactose, no uronic acid. This is important. There is no uronic acid, no uronic acid in the keratin sulfate structure. This is important MCQ. This is important for the transparency of the cornea. This is very, very important MCQ. Keratin sulfate is important for the transparency of the cornea. So these are the important glycosaminoglycan. It is very, very important for the FMG examination. Glycosaminoglycans, their role and the disorders related with the glycosaminoglycan. So remember, some disorders are there that they are known as mucopolysaccharidosis. There is multi-system involvement in the mucopolysaccharidosis. When there is defect in the enzyme that degrades this glycosaminoglycan, if there is defect in the enzymes which degrades the glycosaminoglycan, that causes the mucopolysaccharidosis. Generally, multi-system involvement is there. The classical features are mental retardation, hepatosplenomegaly, skeletal abnormality, short stature. These are the features in the mucopolysaccharidosis. Remember some mucopolysaccharidosis, for example, Hurler is the first. Hurler, the feminine name is there. So Hurler is the first. She is always first. So Hurler is the first. Hunter is the second. Remember, Hunter needs vision to kill. So Hunter is having the clear cornea. Hunter is having the clear cornea. Remember this. Remember the enzyme defect iduronate and iduronate sulfatase. Hurler and Hunter. So Hurler syndrome, the enzyme defect is iduronidase. There is accumulation of dermatan sulfate and heparan sulfate in the Hurler and Hunter. Also in the Sly syndrome, that is type 7. Type 1, type 2 and type 7, there is accumulation of dermatan sulfate and heparan sulfate. When there is accumulation of heparan sulfate, it causes mental retardation. When there is accumulation of dermatan sulfate, heparan sulfate, it causes mental retardation. So dermatan sulfate plus heparan sulfate is there in the type 1, type 2 and type 7. Hurler, Hunter and Sly disease. Hurler, Hunter and Sly disease. Whenever there is accumulation of heparan sulfate, it causes mental retardation. The deficient enzyme in Hurler is the iduronidase, while Hunter it is iduronate sulfatase. Iduronate sulfatase. So having the same manifestations, only the mental involvement in the Hunter is late. It is having the clear cornea, no corneal clouding is there in the Hunter syndrome. There is no corneal clouding in the Hunter syndrome. This is a X-linked disorder. X-linked disorder typically affect the males. Having the clear cornea and it is X-linked. The general features are same as that of the hurler. The mental involvement is less as compared to the hurler, and the late mental involvement is there in the Hunter syndrome. Okay, so see, this is difference between hurler and Hunter. So iduronidase deficiency in the hurler, iduronate sulfatase deficiency in the Hunter syndrome. See, remember, there is no corneal clouding in the Hunter syndrome. This is X-linked recessive disorder. Rest of the symptoms are same as that of the hurler syndrome. Okay, so there is no corneal clouding in the Hunter syndrome, and it is a X-linked recessive disorder. These are the other: Sanfilippo ABCD, Marquio A, Marquio B, Morotilami, and the Sly syndrome. Morotilami and the Sly syndrome, Sly disease. Now remember the enzyme defect. Hurler, it is iduronidase. Hunter, it is iduronate sulfatase. The Sanfilippo ABCD, there is defect in the enzyme which degrades the heparan sulfate. So mental retardation is much more in the Sanfilippo ABCD. Then Marquio, जो M से चालू होते हैं, those who start with the M, there is no mental retardation because there is no accumulation of heparan sulfate. In the Morotilami and the Marquio, see Marquio A, B and Morotilami, the accumulated compounds are here is the keratin sulfate and chondroitin sulfate, here keratin sulfate, here dermatin sulfate. So there is no mental retardation in the Marquio and the Morotilami. In Marquio AB, it is galactosamine 6 sulfatase defect. Marquio B, it is beta galactosidase defect. So beta galactocerebrosidase defect in the Krabbe's disease. Remember, here it is beta galactosidase. In Krabbe's disease, it is beta galactocerebrosidase defect. Remember this. Marquio A, it is galactosamine 6 sulfatase. Marquio B, it is beta galactosidase defect. Morotilami, it is aryl sulfatase B. It is aryl sulfatase B, B defect. Okay, Morotilami. And the Sly disease, it is the beta glucuronidase. The type 9 Natovic syndrome. This is type 7. Type 9 is Natovic syndrome, in which the hyaluronidase is affected and the joints are involved in the Natovic syndrome type 9. Remember this. Natovic syndrome type 9, hyaluronidase is affected. So these are the some defect in the mucopolysaccharidosis. See, glycogen storage disorders, the important disorders in which glycogen accumulation in the liver or muscle occur. Type 0, it is glycogen synthase which is affected. Here there is hypoglycemia in between the meal. Life expectancy is very less. Early death occur. There is no hepatomegaly. There is hypoglycemia in between the meal and early death occur in the glycogen synthase defect. Type 1 glycogen storage disorder, that is, I will see, just wait. See, you can remember this like versatile player, Corey Anderson. Versatile player Corey Anderson made history. This is mnemonic to remember the glycogen storage disorder. This is von Gerk disease. This is Pompe's. This is Pompe's disease. This is Corey disease. This is Anderson disease. This is McArdle disease, and this is Her's disease. And next one is the Tharoi's disease. Okay, Tharoi's disease. It is type 7. Okay, now see, this is type 1, this is type 2, this is type 3, this is type 4, this is type 5, this is type 6, and Tharoi's disease, this is type 7 glycogen storage disorder. Versatile player Corey Anderson made history. These are the important glycogen storage disorder. Now the defective enzyme, see the defective enzyme. Von Gogh disease, it is glucose 6 phosphatase. Glucose 6 phosphatase. Remember, this enzyme is absent in the muscle, so no muscle involvement in the von Gogh disease. Pompe's disease, this is the lysosomal acid maltase or the lysosomal glucosidase. Lysosomal acid maltase defect. Acid maltase or lysosomal glucosidase defect. Early involvement is there. The neonate and infant, specifically the glycogen degradation occurs in the lysosome with the help of glucosidase enzyme. If there is block in the lysosomal acid maltase, it causes Pompe's disease. There is pump failure. Remember Pompe's, it is pump failure. Pump matlab cardiac failure is there, and cardiac enlargement, कार्डियोमायोपैथी की वजह से कार्डियक इन्वॉल्वमेंट की वजह से डेथ होती है. Pompe's disease, 18 month to 2 year is the life expectancy. A, B, C, D. A, B, Anderson. B, branching enzyme defect. Anderson disease, it is branching enzyme defect. Branching enzyme. So it is also known as amylopectinosis. The less branch glycogen accumulates. Less branched glycogen accumulates. So this involves the liver mainly, but muscles are slightly involved in the Anderson disease, but it is a progressive liver cirrhosis. Death occurred because of progressive, this is the word important here, progressive liver cirrhosis is there in the Anderson disease. Cirrhosis, progressive liver cirrhosis, and death below the 5 years of age. 5-year life expectancy is only 5-year. Anderson disease, amylopectinosis, Anderson disease. Now this is Cori disease. It is debranching enzyme defect. Debranching enzyme defect. This is also known as the limited dextrinosis or the Forbes disease. Limited dextrinosis or Forbes disease. Cori disease, there is debranching enzyme defect, and there is limit dextrin accumulation. There is dextrin accumulates. Remember this word dextrin. If the word dextrin is there, go with the Cori's disease. So Cori's disease, debranching enzyme defect. Anderson disease, branching enzyme defect. McArdle disease, it is McArdle disease. It is muscle glycogen phosphorylase. Muscle glycogen phosphorylase defect. The typical feature is exercise intolerance. Exercise intolerance, second wind phenomenon, and if the exercise continued, it causes the myoglobinuria. It causes myoglobinuria in the McArdle disease. So, and Hers disease, the liver glycogen phosphorylase is defective. Liver glycogen phosphorylase is defective. Mild hepatomegaly is there. Mild hepatomegaly is there. Liver enlargement is there. Liver hepatic glycogen accumulation is there. Then the Thyroid disease. In the Thyroid disease, there is the muscle and RBC. Muscle and RBCs phosphofructokinase 1. Phosphofructokinase defect. There is mild hemolysis and exercise intolerance. Hemolysis and exercise intolerance. These are the feature. Intolerance. So these are the glycogen storage disorder. Remember, glucose 6 phosphate defect, no muscle involvement, no muscle involvement, no spleen involvement, no spleen involvement. There is hepatorenomegaly. Reno matlab kidney. Hepatorenomegaly is there in the von Gogh's disease. There is lactic acidosis, increased lactic acid, increased uric acid is there. TG cholesterol level increases. And blood sugar level, hypoglycemia is there. These are the features of the von Gogh's disease. Typically starts at 4 to 6 months of the age. Hepatomegaly, distended abdomen because of hepatorenomegaly, distended abdomen, protuberant abdomen, thin extremities, doll-like faces because of deposition of fat in the cheeks. Then lactic acidosis, because of lactic acid competes with the uric acid for the excretion. So there is increased uric acid, also diversion of glucose 6 phosphate for the fat synthesis, and diversion of glucose 6-phosphate for the ribose and nucleotide synthesis and uric acid synthesis, that increases the uric acid level, also increases the TG and cholesterol level. So there is hyperlipidemia, hyperuricemia, lactic acidosis, and decreased blood sugar level in the von Gogh disease. This is hepatic glycogen storage disorder. Specifically, Pompe's muscle involvement is there in the Pompe's disease. There is hypotonia, there is floppy infant, the lysosomal acid maltase defect, there is pump failure, there is cardiomegaly, there is enlargement of the tongue in the Pompe's disease. Corey and Anderson disease, there is accumulation of limit dextrin in the Corey's disease. Anderson disease, there is progressive liver cirrhosis, branching enzyme defect. McArdle, exercise intolerance is a feature. Second wind phenomena matlab when you pause for some time you can resume your activity, and the myoglobin urea on prolonged exercise. Her disease, it is a liver glycogen phosphorylase defect and the phosphofructokinase in RBC and muscle that causes the Thyroid disease. These are the glycogen storage disorder. See, so this is type 0, glycogen synthase is affected, early death occur. Von Gogh disease type 1A है, type 1B there is neutropenia and the recurrent infection. There is glucose 6-phosphate transporter defect in the type 1B. Von Gogh's disease, it is glucose 6-phosphatase defect. There is hypoglycemia, hyperlipidemia, hyperuricemia, lactic acidosis, and hepatomegaly. Pompe's disease, it is lysosomal acid maltase या lysosomal glucosidase. There is glycogen accumulation in liver, specifically heart is there. Death at the early age occur due to the heart failure. There is hypotonia, decreased muscle tone in the Pompe's disease. Corey's disease, also known as limited dextrinosis or Forbes disease, debranching enzyme defect. Remember ABCD. Anderson branching enzyme, Corey debranching enzyme. In Corey's disease, there is dextrin accumulates. In Anderson disease, there is progressive cirrhosis of the liver. Less branch glycogen accumulates in the Anderson disease. McArdle disease, it is muscle glycogen phosphorylase defect. Muscle glycogen phosphorylase defect in the McArdle disease. Exercise intolerance, accumulation of glycogen in muscle. Normally it is less than 0.7% glycogen is there in the muscle or up to 0.7%. But in the muscle glycogen storage disorder, it is 2.5 to 4% or 4.5% glycogen accumulates in the muscle. Abnormal glycogen accumulates in the muscle. Hers disease, liver glycogen phosphorylase. There is hepatomegaly and fasting hypoglycemia. Whenever there is liver involvement, it causes fasting hypoglycemia because of affected glycogenolysis. So these are the glycogen storage disorders. Very, very important to remember for the entrance FMGE entrance examination. Now see, severe fasting hypoglycemia, lactic acidosis, hepatomegaly, and the uric acid hyperuricemia. It is von Gogh's disease type 1. If it is with the neutropenia and the recurrent infection, neutropenia with recurrent infection, it is type 1B glycogen storage disorder. Okay, then cardiomegaly, muscle hypotonia, and normal blood glucose, it is Pompe's disease. Mild hypoglycemia and the dextrin accumulates, the branch glycogen, short branch glycogen, that is dextrin accumulates, it is Corey's disease. Cirrhosis of liver, abnormal amylopectin like glycogen, or the the less branch glycogen accumulation, it is Anderson disease. Exercise intolerance and no rise in lactate, that is McArdle disease. Mild hepatic form of the GSD with normal lactate, it is Hers disease. And muscle cramps plus hemolysis, it is Thyroid disease. These are the glycogen storage disorders. Now coming to the PDH complex, the pyruvate dehydrogenase complex or the PDH complex, it is a combination of 3 enzymes and 5 coenzymes. 3 enzymes and 5 coenzymes. Remember pyruvate dehydrogenase complex और इसके 2 भाई है, the alpha ketoglutarate dehydrogenase complex and branch chain keto acid dehydrogenase complex. The E1 here is pyruvate dehydrogenase itself. E2 is dihydrolipoyl trans acetylase, and third one is dihydrolipoyl dehydrogenase. So pyruvate dehydrogenase, dihydrolipoyl transacylase or transacetylase, and dihydrolipoyl dehydrogenase. So E1, E2, E3. This is pyruvate dehydrogenase. This is dihydrolipoyl transacetylase, dihydrolipoyl dehydrogenase. And 5 coenzymes are required. That is thymine pyrophosphate B1, FAD B2, NAD that is B3, B5 that is coenzyme A, and the lipomide. So here thymine pyrophosphate, which is from the B1, lipomide. Third one is the coenzyme A, then FAD, flavin adenine dinucleotide, and NAD, nicotinamide adenine dinucleotide. So these are the coenzymes required. So TPP, lipomide, coenzyme A, FAD, NAD. So this is from the B3, this is from the B2, this is from the B5, this is from the B1, and this is lipomide. These are the coenzymes required. So 3 enzymes and 5 coenzymes are required for the PDH complex, also for the alpha ketoglutarate dehydrogenase complex, and also for branch chain alpha keto acid dehydrogenase complex, the link reaction. Name the mobile electron carriers in the electron transport chain. So it includes the 2 important mobile electron carrier. One is coenzyme Q, that is ubiquinone, which is lipid in nature. This is lipid in nature. And the cytochrome C, this is protein in nature. So this is soluble, water soluble. So if there is question on water soluble mobile electron carrier in the electron transport chain, answer is cytochrome C. If lipid in nature with isoprenoid unit, it is coenzyme Q or ubiquinone. There are 4 complexes in the electron transport chain: complex 1, 2, 3, 4, and 5th one is the ATP synthase. There are inhibitor, and you may get, there are in every year 1 or more question is there on the rotenone or the inhibitors of complex 4 of electron transport chain. So complex 1 inhibitor, it includes rotenone. This is an insecticide, also a fish poison, rotenone. Then pericidin and amital, that is the barbiturates or amital. These are the inhibitors of pericidin, gonithidine, rotenone, amital. These are the inhibitors of complex 1 of electron transport chain. Then malonate is a competitive inhibitor of succinate dehydrogenase. So malonate, the phenyl trifluoroacetone, TTFA, phenyl trifluoroacetone, and carboxyl. These are the inhibitors of complex 2 of electron transport chain. British anti-levisite, antimycin, also fenformin. These are the inhibitors of complex 3 of electron transport chain. Cyanide, hydrogen sulfide, carbon monoxide, and the azide. These are the gases. This inhibits the complex 4 of electron transport chain. The complex 4: cyanide, hydrogen sulfide, carbon monoxide, and azide. These gases inhibit the complex 4 of electron transport chain. These are the inhibitors of electron transport chain. Now some inhibitors, see some compounds which act as a inhibitors, or the important compounds. ATP, which inhibit the ATP ADP transporter. This is atractyloside transporter, ATP ADP transporter across the mitochondrial membrane. It is atractyloside. Then FO unit, this O represents oligomycin. FO unit, it is oligomycin and venturicidin. These are the 2 inhibitors of FO unit. Then orovatin inhibit the F1 unit. The chemical uncouplers. Uncouplers means delinks. It delinks the electron transport chain and oxidative phosphorylation. Only heat production occurs. So it is 2,4-dinitrophenol, dinitocresol, fluorochlorocarbonyl phenylhydrazine, aspirin in high doses. These are the chemical uncouplers. Uncouple the electron transport chain from the oxidative phosphorylation. There is only generation of heat occur, no ATP production occurs. So 2,4-dinitrophenol, dinitocresol, fluorochlorocarbonyl phenylhydrazine, aspirin in high doses. These are the chemical uncouplers. Then the thyroxine thyroxine, thermogenin, also known as uncoupling protein 1, thermogenin, which is present in brown adipose tissue, which is important in the newborn, also in the hibernating animals. This, for example, bear. So thermogenin, or also known as uncoupling protein 1, thyroxine, long chain free fatty acid, and unconjugated bilirubin. These are the, this is 1, this is 2nd, this is 3rd, and this is 4th. These are the physiological uncouplers. So this thermogenin, it is present in brown adipose tissue. It is particularly important in the neonate. It prevents the hypothermia in the neonate, thermogenin. Then ionophores, it causes the entry of the ions across the membrane, disrupt the proton gradient which is required for synthesis of ATP. That includes the valinomycin, gramicidin, nigrosin. These are the potassium ionophores. They also act as a uncouplers. So this is also important. This chart is from the Leninger biochemistry, from the biological oxidation topic. So this is also very, very important. Specifically, oligomycin inhibit the FO subunit, the chemical uncouplers which delinks the electron transport chain, and the oxidative phosphorylation. Physiological uncoupler, specifically thermogenin, is important. Okay. Then there are various types of porphyrias. Particularly remember the 3 types of the matlab 3 important porphyrias, that is acute intermittent porphyria, Porphyria cutanea tarda, and the congenital erythropoietic porphyria. Now see this. Remember this: U1, UD, U1, U3 and UD. Remember this: U1, U3 and UD. So see, this is uroporphyrinogen synthase. Also known as hydroxymethylbilane synthase, also known as porphobilinogen deaminase. एक ही इसके 3 नाम है: पार्फोबिलिनोजेन डीअमाइनेज, हाइड्रोक्सीमिथिलबिलेन सिंथेज और यूरोपोरफायरिनोजेन 1 सिंथेज. This is one first. Then uroporphyrinogen 3 co-synthase. This is second, co-synthase. And third one is the uroporphyrinogen decarboxylase. U1, U3, U3, UD. U1, U3, UD. Okay. 13D. U1, U3, UD. Uroporphyrinogen 1 synthase, uroporphyrinogen 3 co-synthase, and uroporphyrinogen decarboxylase. If deficiency occurs, the uroporphyrinogen 1 synthase deficiency causes acute intermittent porphyria. Uroporphyrinogen 3 co-synthase defect causes congenital erythropoietic porphyria, and defect in uroporphyrinogen decarboxylase causes that is Porphyria cutanea tarda. These are the 3 important porphyrias. Remember, if there is block before the synthesis of porphyrinogen or the porphyrin, before the synthesis of porphyrin, if the block is occur, it does not causes the photosensitivity. As in acute intermittent porphyria, there is accumulation of ALA, aminolevulinic acid. There is accumulation of aminolevulinic acid and parphobilinogen, aminolevulinic acid and parphobilinogen. Also there is decreased heme synthesis, decreased heme protein synthesis, and accumulation of this compound which causes neurotoxicity. Neurovisceral symptoms are there. There is abdominal pain and neuropsychiatric manifestations in the acute intermittent porphyria, but there is no photosensitivity in the acute intermittent porphyria. There is accumulation of ALA and PBG. So if there is accumulation of ALA and PBG, go with the acute intermittent porphyria. And this two, congenital erythropoietic porphyria and Porphyria cutanea tarda, the major symptom is photosensitivity. Also there in the Porphyria cutanea tarda, there is photosensitivity. So these are the 3 important disorders: acute intermittent porphyria, congenital erythropoietic porphyria, Porphyria cutanea tarda. This is autosomal recessive disorder. Rest of the disorders, these are the autosomal dominant. So acute intermittent porphyria, enzyme defect is uroporphyrinogen 1 synthase, also known as hydroxymethylbilin synthase or porphobilinogen deaminase. There is removal of ammonia, abdominal pain and neuropsychiatric manifestations. So there is block in the enzyme, which are the enzyme required for the heme synthesis pathway. If block is before the porphyrinogen synthesis, it does not causes the photosensitivity. But when the block is after the porphyrinogen synthesis, these porphyrinogens, they are converted into porphyrins by the UV light, by the light. On exposure to sunlight, they are converted into porphyrin. This porphyrin causes the generation of reactive oxygen species that causes the release of lysosomal enzymes, and that causes the cutaneous manifestation, that is skin lesion. Okay, Porphyria cutanea tarda, it is uroporphyrinogen decarboxylase defect, photosensitivity, this is the symptoms. Hereditary coproporphyria and variegate porphyria, it is a mix of symptoms, that is abdominal pain, photosensitivity and neuropsychiatric manifestation. Congenital erythropoietic porphyria, there is uroporphyrinogen 3 co-synthase defect. It is also known as Gunther's disease. There is photosensitivity and increased hemolysis in the congenital erythropoietic porphyria. Then protoporphyria, it is ferrochelatase or heme synthase defect. There is photosensitivity in the protoporphyria. So remember the three: acute intermittent porphyria, porphyria cutanea tarda, and congenital erythropoietic porphyria. These are the features to differentiate between hemolytic, hepatic and obstructive jaundice. Remember, in the hemolytic jaundice, these all parameters, these are the normal. These enzymes, they are normal. Enzymes, they are normal in the hemolytic jaundice. जैसे कि the galactosemia is there, the hereditary fructose intolerance is there, the sickle cell anemia, thalassemia. In this disorder, the liver enzymes, the SGOT, whenever there is hemolytic jaundice, the SGOT, SGPT, alkaline phosphatase, GGT and 5' nucleotidase, these levels are normal. These levels are normal in the hemolytic jaundice. The bilirubin, specifically, it is indirect bilirubin level increases. Urobilinogen, it is present in the hemolytic jaundice. Urobilinogen, it is present in the hemolytic jaundice, while the urine bilirubin, it is absent. Okay, so the bile salt, bile pigment, Fauchet and H sulfur test will be negative in the hemolytic jaundice. Hepatic jaundice, there is marked increase in the SGOT, SGPT level. In the thousands, SGOT, SGPT levels, they are in the 1000. There is slightly raised alkaline phosphatase level, slightly raised ALP level, that is 2 to 3 times of the normal. GGT, and this is slightly raised or normal level of GGT and 5' nucleotidase. दोनों टाइप के बिलिरुबिन बढ़े हुए रहते, डायरेक्ट एंड इनडायरेक्ट, दोनों बिलिरुबिन बढ़े हुए रहते in the hepatic jaundice. Whenever there is liver parenchymal cells, they are involved, hepatocytes, they are involved, there is increase in the both type of bilirubin, indirect and direct bilirubin. Okay, so bile salt and bile pigment test can be positive, can be negative in the hepatic jaundice. Obstructive jaundice, it is the slight increase in the SGOT, SGPT, but marked increase in the alkaline phosphatase, GGT and the 5' nucleotidase. There is marked increase. There is increase in the direct bilirubin as compared to the unconjugated bilirubin. And urinary urobilinogen absent in the obstructive jaundice. Bilirubin, मतलब bile salt, bile pigment की जो test है, that is the Fauchet test and the H sulfur test is positive in the obstructive jaundice. This is to differentiate between these three types of jaundice. So this is very small, don't know whether it is visible or not. So remember, we'll take this on this page. See, if there is indirect bilirubin, if there is increase in the indirect bilirubin, you can suspect these are the congenital jaundice, indirect bilirubin. Indirect bilirubin increase is because of, in the congenital jaundice, it is because of Crigler-Najjar syndrome. It is Crigler-Najjar syndrome. Najjar syndrome, type 1, type 2, type 1 and type 2, Crigler-Najjar syndrome, type 1, type 2, indirect bilirubin level increases. Also the Gilbert Gilbert syndrome. Gilbert syndrome, the indirect bilirubin level increases. Indirect bilirubin increases. So unconjugated hyperbilirubinemia is there in the Krigler-Nair type 1, type 2 and the Gilbert syndrome. Here there is complete absence. So complete absence of the absent UDP glucuronil transferase activity, completely absent, 0% is there in the type 1 more severe bilirubin level. The bilirubin level goes above, bilirubin level goes more than 25 milligram per deciliter. It can up to 40 milligram per deciliter. It causes kernicterus. That is crosses the blood-brain barrier as the bilirubin. All of you know that unconjugated bilirubin is uncoupler, so it is toxic. So kernicterus is there in Krigler-Nair type 1. Absent activity of UDP glucuronil transferase. Bilirubin, indirect bilirubin goes above 25 milligram per deciliter, can be up to 40 milligram per deciliter. It is severe. Here the 10% activity is retained. 10% activity is retained. Bilirubin can go up to 20 milligram per deciliter. Bilirubin can go. It is less severe as compared to the type 1 Krigler-Nair type 1. This is the partial activity. 10% activity is retained. This is the bilirubin uptake defect. Bilirubin go up to 4 milligram per deciliter. 4 milligram per deciliter. Here the 33% activity of UDP glucuronil transferase is retained. 33%. Bilirubin go up to 4 milligram per deciliter, and this is mild. Disease as compared to Krigler-Nair type 1 and type 2. So this is indirect bilirubin level increases. Direct bilirubin level increases. Direct bilirubin level increases in two disorders. Bilirubin level increases in two diseases. One is direct, DR. So it is Dubin-Johnson syndrome, and second one is the Rotor syndrome, Dubin-Johnson and Rotor syndrome. So Dubin-Johnson, it is ABCC2 or ABCC2 defect or MRP2 defect. Here in Dubin-Johnson syndrome, this is there is direct bilirubin level increases because the active secretion of bilirubin into bile canaliculi is affected because of the MRP2 mutation. This is also known as the black liver jaundice, Dubin-Johnson syndrome. Rotor syndrome, it is because of organic anion transporter 1B1 or 1B3 defect, which is required for uptake of conjugated bilirubin into the hepatocyte, which is required for uptake of conjugated bilirubin into the hepatocytes. This is organic anion transporter 1B1 and 1B3, Rotor syndrome. No black staining of the liver. Occur in the Rotor syndrome. So remember, indirect bilirubin increases in Krigler-Nair type 1, type 2 and Gilbert, and direct bilirubin increases in the Dubin-Johnson and Rotor syndrome. This is also known as unconjugated bilirubin. This is known as conjugated bilirubin. Now coming to the lipoproteins, the various properties of lipoproteins and the hyperlipoproteinemia and some hypolipoproteinemia. This is a trending topic nowadays. This is gaining importance because this is repeatedly question where there on the in the NEET PG INICT, also in the FMGE examination, also mainly based on the type 1 the question were based on type 1 hyperlipoproteinemia, also type 2A hyperlipoproteinemia. Now see, so the density wise, these are the types of the lipoprotein: chylomicron, VLDL, IDL, LDL and HDL. These are the various types of the lipoprotein. Density wise, the density, it is chylomicron is less dense, maximum in size, while the HDL, it is highly dense, as name indicate, high density lipoprotein. Highly dense, minimum in the size, smallest in the size. Protein content is 1%, 7 to 10%, 11%, 21%, 30 to 60%. Lipid content, it is mainly chylomicron, it contains the triacyl glycerol. VLDL contain also triacyl glycerol. IDL contain cholesterol, LDL contain cholesterol, and HDL also contain cholesterol and phospholipid. Remember, chylomicron VLDL carries triacyl glycerol. Chylomicron carry exogenous TG. This carries the dietary TG, जो हम डाइट में लेते हैं. द डाइटरी triacyl glycerol it is transported with the help of chylomicron, while the see these lipids they are absorbed into the intestine by forming the mixed micelle. They absorb through a intestine with the help of bile salt. They absorb into the intestinal cell. The resynthesis occur. They are incorporated into a chylomicron, and through bile they are absorbed. So this chylomicron is responsible for transport of the exogenous triacyl glycerol. So this is function, transport of exogenous TG from GIT to peripheral tissue, that is muscle and adipose tissue. VLDL is responsible for transport of endogenous, which is produced in the liver, which is produced inside the liver, that is transported with the help of VLDL. Transport of endogenous TG from liver to the peripheral tissue, this VLDL is important. So chylomicron and VLDL, they are responsible for the transport of TG. This is dietary TG or the exogenous TG. This is the endogenous TG or TG which is produced by the liver. Ideal, it is intermediate in VLDL and LDL synthesis. LDL carries the cholesterol from liver to the peripheral tissue. Hence, whenever there is more LDL level, it is responsible for atherosclerosis. That's why it is known as bad cholesterol. While HDL, it is responsible for transport of cholesterol from peripheral tissues to the liver, and metabolism of the cholesterol, it is important. That's why it is known as good cholesterol. It is responsible for reverse transport of cholesterol. HDL is important for reverse transport of cholesterol. The major apoprotein matlab the lipoprotein is composed of lipid. It is composed of lipid and protein. So protein part of lipoprotein is known as apoprotein. The major apoprotein in chylomicron is ApoB48. VLDL, IDL and LDL. ये VLDL से IDL बनता, IDL से LDL बनता. So it is B100 which is important in the VLDL, IDL and LDL. While HDL, ApoA1 is important. ApoA1 is important in the HDL core. Okay. So these are the functions of apoprotein. ApoB48 is there in the chylomicron. ApoB100 is there in the VLDL, IDL and LDL. This is produced by the liver. These are the examples of RNA editing from the same gene, from the same heterogeneous nuclear RNA. There is production of two different protein occur. In the intestine, only 48% of the protein is synthesized, that because of the premature introduction of the stop codon. Only 48% of the protein is synthesized, that is known as ApoB48, and in liver 100% protein is produced, that is known as ApoB100. So this is example of RNA editing. ApoB48 is there in the chylomicron, ApoB100 is there in the VLDL, IDL and LDL. Apo C1, C2 and C3. ApoA1, it is present in the HDL. ApoA1 activates lecithin cholesterol acyl transferase. ApoC2 activates lipoprotein lipase. ApoC2 activates lipoprotein lipase. And AC23, remember AC23 matlab ApoA2 and ApoC3 inhibit lipoprotein lipase. ApoA2 and ApoC3 inhibit lipoprotein lipase. ApoC2 activates lipoprotein lipase. ApoA1 activates lecithin cholesterol acyl transferase. Okay, so these are the important. ApoE is for the it act as a receptor for the uptake of the remnant. It acts as a ligand for LDL receptor for uptake of chylomicron remnant and VLDL remnant. ApoE. Okay, ApoE. If there is increased cholesterol level and tendon xanthoma, if there is xanthoma on the tendon, the foam lesion on the tendon, if involvement of tendon is there, it mainly occurs in the when there is increase in the cholesterol level. So cholesterol increase and tendon xanthoma, it is a type 2A familial hypercholesterolemia. If there is increase in the triglyceride, eruptive xanthoma, it can be in the type 1, type 4 and type 5. Type 1, type 4 and type 5 eruptive xanthomas. If there is increase in the chylomicron level and milky plasma or lipemic plasma appearance, it can be a it is mainly occurs in the type 1, that is familial hyperchylomicronemia. So these are the hyperlipoproteinemia important. So type 1 is important. Type 1 is lipoprotein lipase deficiency or ApoC2 defect. ApoC2 defect. In this, there is increase in the chylomicron level, there is increase in the triglyceride level, which is more than 1000. More than 1000. There is milky plasma. There is milky plasma. These are the features of type 1 hyperlipoproteinemia. That is type 1 hyperchylomicronemia. So there is increase in the chylomicron. Chylomicron carries triacylglycerol. TG increase more than 1000 milligram per deciliter. There is milky plasma. There is increased risk of pancreatitis. There is increased risk of pancreatitis. This is type 1 lipoprotein lipase deficiency or ApoC2 defect, that is known as familial chylomicronemia. Familial chylomicronemia. As there is increased TG level, there is increased risk of pancreatitis. These are the features of type 1 hyperlipoproteinemia. Fredrickson classification type 1, it is familial hyperchylomicronemia in which lipoprotein lipase is deficient or ApoC2 defect. There is elevated chylomicron level, the TG level more than 100, more than 1000. Milky plasma is there because chylomicron gives milky or lipemic plasma appearance. And as there is increase in the TG level, it increases the risk of pancreatitis in the type 1 familial chylomicronemia. Then type 2, see, this is familial chylomicronemia, that is type 1. This is LDL receptor defect. So sorry, this is lipoprotein lipase deficiency or ApoC2 defect, where chylomicron and VLDL level increases. TG is more than 1000 milligram per deciliter. There is eruptive xanthomas, there is risk of pancreatitis, and there is milky plasma appearance, milky serum or milky plasma appearance because of elevated chylomicron level. Type 2, it is type 2A, it is familial hypercholesterolemia. It is because of LDL receptor defect, LDL receptor defect or ApoB100 defect. There is accumulated LDL level and cholesterol level. There is risk of or the clinical feature is tendon xanthoma. Because of elevated cholesterol and LDL level, there is premature risk of atherosclerosis. So there is risk of atherosclerosis, coronary artery diseases, and tendon xanthoma in the type 2A, that is familial hypercholesterolemia. There is LDL level increases, there is increased level of cholesterol. Type 2B, that is combined dyslipidemia or familial combined dyslipidemia. There is familial combined dyslipidemia, there is LDL and VLDL. Both increases. This is ApoB defect, familial combined dyslipidemia, LDL and VLDL increases, there is risk of atherosclerosis. Type 3, this is dys-beta lipoproteinemia. Dys-beta lipoproteinemia, also known as broad beta disease. It is ApoE defect in the type 3. This is type 3 ApoE defect. Type 3. Here the remnant VLDL and remnant chylomicron accumulates. There is risk of the clinical feature is Palmer's xanthomas and the atherosclerosis. ये तो बाकी के कुछ याद नहीं रहते. Remember type 1 and type 2A. So type 1 is familial chylomicronemia, type 2A is familial hypercholesterolemia. There is milky plasma, there is increased triglyceride level, chylomicron level, there is risk of pancreatitis. Here there is increased LDL, increased cholesterol level, there is premature risk of atherosclerosis. The eruptive xanthomas, increased TG level is seen in type 1, type 4 and type 5. Type 1, type 4 and type 5. This type 4 and type 5, these are known as familial hypertriglyceridemia. Along with this familial triglyceridemia, the VLDL, there is increase also chylomicron level. So these are the mixed features. Type 4 is associated with alcoholism, diabetes, and one more condition is there. It is obesity, alcoholism, and diabetes mellitus. It is associated. That is type 4. Type 4. So remember, there are 5 classes of Fredrickson classification of hyperlipoproteinemia. First 2 are important. Chylomicronemia and hypercholesterolemia. Okay, first one is lipoprotein lipase defect or ApoC2 defect. Second one is the LDL receptor defect or ApoB100 defect. Then Tanger's disease, we already discussed the Tanger's disease. Just wait. This is a yellow-orange color tonsil. See, a patient presented with reduced level of high density lipoprotein, low to absent, matlab absent to low, 0 to low HDL level. There is mutation in ABCA1 transporter. On examination, tonsil appeared as shown in the image, that is yellow or orange tonsil. It is a case of Tanger's disease. Tanger's disease. Tanger's disease. There is mutation in ABC transporter A1, ABCA1, which is required for transport of cholesterol from peripheral tissues to the HDL. So here low or absent HDL. This is the classical feature, HDL. Then yellow orange color tonsil, yellow orange tonsils. There is hepatosplenomegaly and neuropathy. These are the features of Tanger's disease, alpha lipoprotein deficiency. Tanger's disease. This is an image based question. Tanger's disease. This is the most important, the frequently asked, top rated topic for any entrance examination. This is, see, the crumpled tissue paper, tissue paper or wrinkled paper macrophages are there. This is a microscopic feature of the Gaucher's disease. This is a microscopic feature of Gaucher's disease. Gaucher's disease, it is a lysosomal storage disorder. Gaucher's disease, due to defect in the enzyme glucocerebrosidase. Now see, see, a patient presented with refractory anemia. There is anemia, means pancytopenia is there. There is decrease in the RBC count. There is decrease in the WBC count. There is decrease in the platelet count. Thrombocytes. Platelet means thrombocytes. So anemia, the leukopenia is there, and the thrombocytopenia is there. Thrombocytes also decrease. So there is pancytopenia. Because of involvement of bone marrow. So bone marrow, liver and spleen, these are involved. So hepatosplenomegaly is there, and bone marrow involvement causes the decrease in the cell count. That is refractory anemia. Also, the decrease in the platelet thrombocytes causes the bleeding tendencies. So hemorrhagic tendencies are also there. So if you see the macrophages, you will see the intracytoplasmic inclusion body, that is known as Gaucher's cell. This is wrinkled paper or tissue paper macrophages. Gaucher's disease. One more finding, there is no cherry red spot on the macula in the Gaucher's disease, Krabbe's disease and Fabry's disease. No cherry red spot on the macula in the Gaucher, Krabbe's and Fabry's disease. Remember KGF. There is no cherry red spot on the macula. Cherry red spot is the feature where macula appears bright, the fovea appears bright because of lipid accumulation in the surrounding retinal area. No cherry red spot. KGF means Krabbe's, Gaucher and Fabry's disease. Okay, so there is pancytopenia, there is wrinkled tissue paper macrophages, there is Erlenmeyer flask deformity on the long bone. We'll see that. See, just following is the bone marrow biopsy picture from a child with hepatosplenomegaly and pancytopenia. The characteristic cell seen in this biopsy is diagnostic finding in which of the following diseases. So here answer is, this is a crumpled paper or the wrinkled paper macrophages, tissue paper macrophages. It is a feature of Gaucher's disease. Intracytoplasmic inclusion body, Gaucher's disease. This is the X-ray of lower limb, which will show the conical flask, the Erlenmeyer flask deformity of the long bone. So this is known as Erlenmeyer flask deformity. See, this is Erlenmeyer flask deformity because of involvement of the bone marrow and avascular necrosis of the bone, there is this deformity. This is known as Erlenmeyer-Flass deformity. It is a feature of Gaucher's disease. So Gaucher is the most important. Remember the features of the Gaucher's disease. So कौन से feature मैंने बताया? Pancytopenia, decreased WBC, RBC and the platelet count. So because of this, there is anemia, there is frequent infection, there is bleeding tendencies, there is hepatosplenomegaly, there is crumpled tissue paper macrophages, there is Erlenmeyer-Flass deformity in the X-ray of the long bone. These are the features of the Gaucher's disease, and no cherry red spot on the macula. This is a cherry red spot on the macula. See, the following fundoscopy depict a characteristic finding. This finding is present in all of the following diseases except मैंने अभी बोला आपको. So there is no cherry red spot in the KGF, Krabbe's, Gaucher and Fabry's disease. Now see, so this is Gaucher disease. Answer is Gaucher's disease. In Niemann-Pick disease, there is cherry red spot on the macula and the hepatosplenomegaly, sphingomyelinase defect. Tay-Sachs disease, there is no organ involvement. Tay-Sachs disease, it is because of hexosaminidase A defect. Sandoff disease, it is because of hexosaminidase A and B defect, and there is organ involvement, there is hepatomegaly, there is cardiac enlargement in the Sandoff disease. These are the GM2 gangliosidosis. This is because of the sphingomyelinase defect. Sphingomyelin accumulates. In these two disorder, GM2 gangliosides accumulates. Gaucher disease, it is glucose cerebroside accumulation because of glucose cerebrosidase defect. Okay. See, these are the enzyme defects. Gaucher's disease, it is the glucose cerebrosidase defect, accumulation of glucose cerebrosides occur. Niemann-Pick disease, sphingomyelinase defect, sphingomyelin accumulates. Krabbe's disease, it is beta galactocerebrosidase, actually galactocerebrosidase defect. Fabry's disease, it is alpha galactosidase defect. Tay-Sachs disease, hexosaminidase A. Sandoff disease, it is hexosaminidase A and B. Metachromatic leukodystrophy, it is aryl sulfatase defect. Farber's disease, it is ceramidase defect. Okay. See, these are the accumulated compounds. See, these are the features, important features for lysosomal storage disorder. Cherry red macula without hepatosplenomegaly, without organ involvement, it is Tay-Sachs disease, GM2 gangliosidosis. Cherry red macula with hepatosplenomegaly, it is the Niemann-Pick disease, sphingomyelinase defect, Niemann-Pick disease. Bone crisis, that is Erlenmeyer-Flass deformity, crumpled tissue paper macrophages, Gaucher cells, pancytopenia. This is the feature of Gaucher's disease. There is no cherry red spot. Angiokeratomas, ABC, angiokeratomas, the burning sensation in the hand and feet, corneal opacity. So angiokeratomas, burning sensation in the hand and feet, corneal opacity, early age involvement, vessel involvement is there, and the bathing tongue areas, angiokeratomas, particularly involving the angiokeratomas means telangiectatic skin lesion, particularly involving the below umbilicus and above the knee joint. So this is bathing trunk area is involved in the Fabry's disease. This is X-linked disorder, Fabry's disease, alpha galactosidase defect. Corneal clouding, coarse facial feature and developmental delay. Corneal clouding and the coarse facial feature and developmental delay. This is mucopolysaccharidosis type 1, that is Hurler disease. No corneal clouding, aggressive behavior, X-linked disorder. This is the Hunter syndrome. No cherry red spot on the macula, KGF, that is Krabbe's, Gaucher and Fabry's disease. These are the points to remember, the very, very important points to remember for the any entrance examination. See, this is from the nutrition topic. The SDA, specific dynamic action, SDA of the food, specific dynamic action of the food. So this is thermogenic action of the food or the specific dynamic action of the food. Some amount of energy is needed to process the food. So this should be taken in the account when we calculate the energy need of particular individual. When we calculate the energy need of particular individual, three things to be kept in the mind. First is the BMR, basal metabolic rate. Second is the SDA of the food, that is the specific dynamic action of the food. And third one is the physical activity. These three things should be kept in the mind while calculating the energy requirement of an individual. कौन सी तीन? So first is the BMR, second is the SDA, and third one is the physical activity. Now see SDA of the food, it is maximum for the protein, it is near about 30%, 30% for the protein, 30% for the protein. This SDA for the protein, it is required for digestion, absorption, transport and storage. In case of the protein, it is mainly utilized for the, mainly it is required for the transamination, deamination. It is required for the transamination, deamination, and it is required for the urea synthesis. Some amount of energy it is lost as urea. It is required for the protein synthesis, urea synthesis, protein synthesis. For these processes, this energy is needed. So it is maximum for the protein. So protein is not a good food for the fuel, for the energy purpose. It is mainly for the body building purpose. So this is protein, 30% SDA. So it is 5 to 10% for carbohydrate, 0 to 5% for lipid, near about 30% for protein, and mixed diet it is 10%. The caloric value means per gram of the carbohydrate you will get 4 calorie, per gram of the lipid 9 calorie, per gram of the protein 4 calorie. This is respiratory quotient, that is the CO2 produced to the O2 consume and CO2 produce ratio. This tells about the metabolic state of the individual. Metabolic food which is utilized, metabolic food for the fuel source, this indicates the metabolic state of the individual. It is the ratio of the CO2 produced to O2 utilized. It is maximum for the carbohydrate, that is it is maximum for the carbohydrate, that is 1. For lipid is 0.7, for protein is 0.8, and for mixed diet it is 0.85. So remember the respiratory quotient of particular foodstuff and the SDA of the particular foodstuff, particularly protein, and mixed diet it is 10%. This is the oxygen dissociation curve. You should remember the negative shift in the oxygen dissociation curve. So negative shift or right shift of the oxygen dissociation curve, this is a right shift of oxygen dissociation curve. It occurs whenever there is decrease in the pH, that is means increase in the H ion concentration, increase in the partial pressure of CO2, 2,3-bisphosphoglycerate, and increase in the temperature. These are the important compounds which causes the negative, these are the negative effector which shift the oxygen dissociation curve to the right, and it is responsible for unloading of oxygen to the tissues. So this is decrease in the pH, means increase in the H ion concentration, increase CO2, increase 2,3-bisphosphoglycerate, which is produced in the Rappaport lubricant shunt, and increase in the temperature. These are the negative shift. This causes the shift of the oxygen dissociation curve to the right shift of the oxygen dissociation curve, unloading of oxygen of O2 to tissues from hemoglobin. This is important. These are the particular odors of the urine in which the burnt sugar, it is important. It is maple syrup urine disease. The sweaty feet odor is there in isovaleric acidemia, leucine metabolism disorder. Mousy odor, musty odor is there in the phenylketonuria. The tomcat urine, this is multiple carboxylase deficiency. Swimming pool odor in the Hawkins urea. Rotten fish odor in the trimethyl aminuria, and the boiled cabbage-like odor in the tyrosinemia type 1. These are the different order of this. Remember this: burnt sugar, MSUD, sweaty feet, isovaleric acidemia, PKU, phenylketonuria, musty odor, mousy odor. These are the important. Also black urine, alkaptonuria. Black urine, it is alkaptonuria. Now coming to the DNA repair mechanism defect. So there are 4 important repair mechanisms: mismatch repair, base excision repair, न्यूक्लियोटाइड एक्सcision repair, and the double strand break repair. ये 4 mechanism है repair के लिए. See the double strand break repair, it is done with the help of 2 mechanisms. One is non-homologous end joining, and second one is the homologous recombination. This is the most common for the double strand break repair. Non-homologous end joining means ligation of 2 ends as it is. So there is more chances of mutation in the non-homologous end joining, but it is better than loss of the chromosome. So non-homologous end joining, if there is defect in the non-homologous end joining, it causes the severe combined immunodeficiency. Here the B cell and T cell both are defect, both reduce. There is decrease in the B cell and T cell and responsible for recurrent infection. SCID is also due to adenosine deaminase defect. So non-homologous end joining causes the SCID, severe combined immunodeficiency. Homologous recombination defect can be, if there is defect in the homologous recombination, it can cause the ataxia telangiectasia like disorders, Fanconi's anemia, or breast cancer susceptibility. So it is the homologous recombination, it is the ataxia telangiectasia, Bloom syndrome, Fanconi's anemia, breast cancer susceptibility. These are disorders related with the homologous recombination. Remember, non-homologous end joining defect causes the SCID. Homologous recombination defect causes the ataxia telangiectasia like disorder, Fanconi's anemia, Bloom syndrome, breast cancer susceptibility. Okay, homologous recombination defect. Okay, but important is here the if there is UV light induced thymine dimer production, and if it is not repaired with the help of nucleotide excision repair. So UV light causes the thymine dimer formation. There is cross-linking between the two adjacent thymine molecule. There is formation of cyclobutane ring in between the two thymine residue. There is formation of thymine dimer, and it is repaired by the nucleotide excision repair. If it is not repaired, by the nucleotide excision repair, it causes the xeroderma pigmentosum. This is very, very important. Xeroderma pigmentosum. There is risk of getting cancer. There is risk of getting 1000 times risk of getting cancer, mainly basal cell carcinoma, squamous cell carcinoma, and the melanoma. Basal cell carcinoma, squamous cell carcinoma, and melanoma. So it is UV light induced thymine dimer production repaired by the nucleotide excision repair. If it is not repaired, it causes the xeroderma pigmentosum. Second important is the if mismatch repair defect. If there is mismatch due to replication error, and if it is not repaired by the mismatch repair mechanism, it causes hereditary non-polyposis colon cancer, that is also known as Lynch syndrome. The family, the generations, they are affected. The family members are affected. The early age involvement is there. There is colon cancer, there is rectum cancer, there is endometrium, ovary. These are involved in the HNPCC. So this is hereditary non-polyposis colon cancer. It is because of the defect in the mismatch repair. Xeroderma pigmentosum, it is because of the defect in the nucleotide excision repair. These are the syndromes. These are due to defect in the homologous recombination. Severe combined immunodeficiency, where B cell and T cell both are defective. Here it is a defect of non-homologous end joining. These are the DNA repair mechanism and related defect. This is a chart from the Harper's Illustrated Biochemistry. This is Menkes and the Wilson's disease. Remember the important points related. Whenever this, remember 7A, A is first and the B is second. So M is first and W is after the M. So it is Wilson's disease. Wilson's disease. ATP7B mutation, it is Wilson's disease. 7A mutation, it is Menkes disease. Menkes disease, this is a neurodegenerative disorder. Characterized by mental retardation, hypopigmented patches all over the body, the kinky hair, the wiry hair. This is the characteristic of this Menkes disease. So this is the defective absorption of copper from the intestine. Decreased copper affect the lysyl oxidase and affect the collagen cross-linking. That's why these are the features in the Menkes disease. There is copper deficiency in the Menkes disease. Wilson's disease, it is hepatolenticular degeneration due to mutation in ATP7B, which is required for excretion of copper into a bile, also required for incorporation of copper into a ceruloplasmin. In both these diseases, ceruloplasmin level decreases. The Wilson disease, it is hepatolenticular degeneration. There is involvement of liver. There is involvement of lenticular nucleus of the brain. Lenticular degeneration. There is KF ring in the cornea, that is KF ring, Kesher-Fleischer ring around the cornea. It is in the decimate membrane of the cornea, KF ring. It is present in 99% cases with the neuropsychiatric manifestation. The diagnostic test for the Wilson disease is the liver biopsy and quantitative copper assay. quantitative copper assay per gram of the liver tissue. Per gram of the liver tissue, it is mainly more than 250 microgram per gram of the liver tissue in the Wilson's disease. This is a definitive diagnostic test for the Wilson's disease. Liver biopsy and quantification, measurement of copper in the liver tissue, more than 250 microgram per gram of the liver tissue. While urinary copper excretion and the serum ceruloplasmin, this can be used as a screening test for the Wilson's disease. So remember, hepatolenticular degeneration, KF ring, that is Kaiser-Fleischer ring. There is liver biopsy and quantification of the copper in the liver is the diagnostic test. The cataract is there because of the copper excess, that is known as the sunflower cataract in the Wilson's disease. The KF ring is there in the cornea, in the descending membrane of the cornea. Hepatolenticular degeneration, Wilson's disease. Wilson's disease. There is neuropsychiatric manifestation in the Wilson's disease. Ataxia is also there. Mental retardation, neurological symptoms, ataxia is there in the Wilson's disease. See, Marfan syndrome and homocystinuria. Last year, there was question on the Marfan syndrome. Which gene is affected in the Marfan syndrome? So it is fibrillin 1 gene which is mutated in the Marfan syndrome. There is long arm span. ऐसा बोलते कि Abraham Lincoln may had suffer from the Marfan syndrome. There is lens dislocation or subluxation of lens in the upward and outward direction. Superotemporal subluxation of lens. Marfan out. Marfan out. The lens is outward dislocated in the Marfan syndrome. There is involvement of the aorta. There is involvement of the vessels, means aorta is involved in the Marfan syndrome. The skeletal muscles, means bone is involved. Bone, aorta, means periosteum of the bone. Bone is involved, the aorta is involved, and one more tissue is involved. Just wait. Lens is involved. Lens, bone, means aorta, the periosteum and lens is involved in the Marfan syndrome. There is long arm span, the fibrillin 1 gene mutation, dislocation of lens in upward and outward direction. The most common root of cause is the aortic root dilation or dissection because of the aortic aneurysm is there. Intelligence is normal in the Marfan syndrome. It is autosomal dominant condition. Tall and long limbs, that is known as long arm span, that is Marfanite habitus. And there is normal homocysteine level in the Marfan syndrome. Fibrillin 1 gene mutation, and there is transforming growth factor beta. The transforming growth factor beta, which increases, which interferes with the fibrillin, so it affects the aorta, bone and lens. This is autosomal dominant condition. Homocystinuria, it is defect in the methionine and cysteine metabolism, in which homocysteine, see this homocysteine is not converted into methionine. This is a block. Methionine, this is a block. Homocysteine is not converted. This is not the block here. So in this metabolism, this is homocysteine methionine metabolism, in which homocysteine is not converted into the cystathionine and ultimately thionine and ultimately cysteine. Ultimately cysteine formation does not occur. So this is a block because of the cystathionine beta synthase enzyme, which is PLP dependent, pyridoxal phosphate. This enzyme is deficient, which is required pyridoxal phosphate dependent enzyme. This is blocked. Because of this, the homocysteine level increases, also methionine level increases. So there is increased methionine, increased homocysteine level, decreased cysteine level. So cysteine has to be given in the treatment. Avoid methionine and homocysteine level. So autosomal recessive condition, the dislocation of lens is downward and towards the nasal side. So medial and downward subluxation of lens occur. Because of homocysteine level, the increase in the 5 micromole of homocysteine level, it is corresponding with the 20 milligram of cholesterol. So there is risk of atherosclerosis. So there is thromboembolism or thrombus formation. There is intellectual disability, increased homocysteine and methionine level. Cyanide nitroprusside test is positive. This is a qualitative test for the detection of homocysteine in the urine. So cyanide nitroprusside test is positive, elevated homocysteine and methionine level. Similar symptoms, tall, long limbs, means skeletal changes are there, along with the osteoporosis is there. intellectual disability, thrombus formation, downward and inward subluxational planes. Remember, homocystinuria, homocysteine level elevated, there is downward and inward, must medial and downward subluxation of lens occur. Cystathionine beta synthase defect, autosomal recessive condition related with homocysteine methionine metabolism, elevated level of homocysteine and methionine, cysteine level decreases. This is homocystinuria. This is Marfan syndrome. Marfan syndrome is fibrillin 1 gene mutation. Okay. Telomere and telomerase. See, telomere and telomerase. Telomere, this is present. This is a nucleotide sequence. 6 nucleotide repeat is there. TTAGGG. 6 nucleotide repeat. That is TTAGGG repeat is there. Near about 15,000 base pairs are there, maintained by the enzyme telomerase, which is also known as telomere terminal transferase. This telomerase is complementary to the telomere repeat with reverse transcriptase activity. This activity is absent, telomerase activity is absent in the somatic cell. It is present in germ cell and stem cell. Increased activity is found in the cancer cell. Decreased activity is found with the aging. And it corrects this TTAGG repeat. It corrects the end replication problem. So telomere and telomerase. The end of the chromosome, there is the sequence, the 6 nucleotide repeat, TTAGGG. So there is end of the chromosome. This is the end of the chromosome. Suppose this is second. See. So end of the chromosome, there is repeat TTAGGG, which prevent the chromosome from the damage. So from the attack by the nucleases and prevent the chromosome from the damage. So that this sequence is known as telomere. It is maintained by the telomerase, which is known as telomere terminal transferase. This is arterial blood gas analysis. It is simple. Just wait. I will tell you the ABG analysis. See, 7.35 to 7.45 is the normal pH. It is normal pH. If pH decreases, it is known as acidosis. It is known as acidosis. If pH increases, it is known as alkalosis. This is clear, acidosis, alkalosis. So primary defect will be either acidosis or alkalosis, whatever it may be. If pH decreases, it is acidosis. If pH increases, it is alkalosis. Now bicarbonate, see HCO3. It is 22 to 28, or some book 26 is also mentioned. 22 to 28 millimole per liter. Millimole per liter. If base, this is base, alkali, bicarbonate. Bicarbonate, if decreases, it is acidosis, that is metabolic acidosis. Metabolic component, metabolic acidosis. At acidosis, if base increases, alkali increases, it is metabolic alkalosis. Metabolic alkalosis. It is metabolic alkalosis. And third important is the PCO2. PCO2. This is 35 to 45 mm of Hg. mmHg. If it is the carbonic acid, CO2 means carbonic acid. If carbonic acid increases, it is respiratory acidosis. Respiratory acidosis. If the acid decreases, carbonic acid decreases, it is respiratory alkalosis. It is respiratory alkalosis. See, alkalosis. Okay. So these are the three important parameters. First, see for the pH. If pH is decreased, it is acidosis. If pH is increased, it is alkalosis. So this will be a primary defect. Now remember this ROMS, respiratory opposite metabolic same. Remember this respiratory opposite metabolic same. Okay. So alkalosis, see PCO2, it is PCO2 decreases in alkalosis and the pH will increase. pH increase, PCO2 will decrease. Acidosis, see pH will decrease, the PCO2 will increase in the respiratory acidosis. So respiratory opposite. Now see the metabolic acidosis, the bicarbonate will decrease, means pH decrease, bicarbonate decrease, pH increase, bicarbonate increase, metabolic alkalosis, metabolic acidosis. Remember this, respiratory opposite, metabolic same. So this can be useful. This is useful for the diagnosis of the acid-base disorder. For the acid-base disorder, we collect the sample in the Hyperinase vacuotenor, that is green tube, ABG analysis in the green tube. These are the causes of high anion gap metabolic acidosis. This is a pneumonic mud piles. So methanol poisoning, uremia means the renal failure, diabetic ketoacidosis, propylene glycol poisoning, iron overdose or isoniazide or some inborn errors of metabolism, lactic acidosis, ethylene glycol poisoning and salicylate poisoning. These are the causes of the high anion gap metabolic acidosis. Also remember normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis, the causes includes mainly diarrhea. This is commonly asked question, diarrhea, renal tubular acidosis 1, 2 ka 4. 1, 2, renal tubular acidosis 1, 2 and 4, and the gastrointestinal fistula. These are the common causes. This is normal anion gap metabolic acidosis because of the increased chloride level. There is normal anion gap. So this is high anion gap metabolic acidosis causes. These are the normal anion gap metabolic acidosis causes. Acid-base disorders. So can you diagnose this? Interpret the lab report. So these are the 4 important lab scenario for the diagnosis. For the practice, see pH decrease. See PCO2, partial pressure of CO2, it is increase, and the bicarbonate level is normal. So pH decrease matlab acidosis, there is increase in the PCO2 means respiratory acidosis. This is respiratory acidosis. These are the simple cases, respiratory acidosis. So those who goes with the pH is the primary defect. Remember, those who goes with the pH is the primary defect. The another one is the compensation. Okay. Now see here, pH increases. The PCO2, partial pressure of CO2, it is normal, and the bicarbonate level, it is increase. So metabolic same. Respiratory opposite, metabolic same. Now see, bicarbonate is the metabolic component. So this is alkalosis. So it is metabolic alkalosis. Okay. Now see, pH decreases. PCO2 is normal, and bicarbonate level, it is decreased. So it is same direction. Now see, it is same direction. Going in the same direction means it is metabolic same. So it is metabolic acidosis. So this is 7.35, 7.45, pH increase, PCO2 decrease, HCO3 normal. So it is opposite direction, it is respiratory, pH increase, it is alkalosis. So in this way you can diagnose. Remember, the component who goes with the pH is the primary defect. Second one is the compensation. Those who goes with the pH is the primary defect. If pH decreases and bicarbonate decreases, it is metabolic acidosis. If pH decreases and the PCO2 increases, it is respiratory acidosis. These are the blotting techniques for identification of this compound. Southern blotting, so Edward Southern gives this technique. So southern blotting is for the DNA, northern blotting is for the RNA, and western blotting is for the protein. The eastern blotting is also there for the post-translational modification in the protein. So DNA, southern blotting, RNA, northern blotting, and western blotting is for the protein. These are the blotting techniques. So branch chain alpha ketoacid dehydrogenase complex, these are the E1, E2, E3 of the branch chain alpha ketoacid dehydrogenase complex. This enzyme is deficient in the maple syrup urine disease. These are the different tumor markers. For example, oncofetal antigen. Alpha fetoprotein level increases in hepatocellular carcinoma and germ cell tumor. Carcinoembryonic antigen, it is increases in the colorectal, breast and the lung cancer. Carbohydrate antigen, that is CA15-3, CA549, CA27-29, estrogen receptor, progesterone receptor, and human epidermal growth factor 2 new. HER2 new, it is increases. It is a marker for the breast carcinoma. CA19-9 for the pancreatic cancer. CA125 for the ovarian cancer. These are the tumor markers. ACTH for small cell carcinoma of the lung. Calcitonin, it is for the medullary carcinoma of thyroid gland. It is for medullary carcinoma of thyroid gland. Thyroid gland, calcitonin. Gastrin for gastrinoma, glucagon for glucagonoma, HCG for the placental or the choriocarcinoma or testicular carcinoma, insulin for the insulinoma. Then prostatic acid phosphatase for the prostate cancer, prostate specific antigen for the prostate cancer, also for the benign hypertrophy or of prostate, ALP for the bone metastasis. Neuron specific enolase for the neuroblastoma and small cell carcinoma of the lung. LDH is non-specific. It is for the lymphoma and the germ cell tumor. These are the tumor markers. Then some inhibitors of protein synthesis, prokaryotic protein synthesis. It is tetracycline, doxycycline, chloramphenicol, erythromycin. They inhibit the prokaryotic translation. The diphtheria toxin, ricin and cycloheximide inhibit the eukaryotic translation. ये highly rated topic है, इस बार आ सकता है, बहुत important है. It is related with the recently it is connected with the some terror activity, and it can be there in the exam. Ricin, mechanism of action of the ricin in the inhibition of translation. Ricin particularly remove the one adenine nucleotide from the ribosomal RNA, so it inhibits the translation, ricin. So these are the eukaryotic translation inhibitors, and the puromycin inhibit both. Puromycin inhibit both prokaryotic and eukaryotic translation process. Now see the tetracycline, doxycycline blocks the A site and prevent the attachment of amino acid tRNA to the A site. Chloramphenicol blocks binds to the 50S ribosomal RNA in the prokaryote and blocks the peptidyl transferase activity. Erythromycin also attaches to the 50S ribosomal unit, and aminoglycoside causes the misreading of the RNA. Diphtheria toxin act on the elongation factor 2. It causes ADP ribosylation of elongation factor 2. It causes the ADP ribosylation of elongation factor 2. Ricin removes one adenine nucleotide from the 28S ribosomal RNA. Cycloheximide blocks the 60S ribosomal unit. Puromycin inhibit both prokaryotic and eukaryotic translation. C. Tetracycline and doxycycline act on the 30S ribosomal unit. It prevents the attachment of amino acid tRNA to the A site, blocks the binding of amino acid tRNA to the A site. Chloramphenicol binds to the 50S ribosomal unit, inhibit the peptidyl transferase activity. Erythromycin binds to the 50S ribosomal unit and blocks the translocation. It blocks the translocation of peptidyl tRNA. Aminoglycoside, streptomycin, amikacin, they causes the misreading of the mRNA, inhibit the translation process. These are the prokaryotic inhibitors. Diphtheria toxin, it catalyzes the ADP ribosylation of elongation factor 2 and inhibit the translocation, prevent the translocation. This is important, diphtheria toxin. This is very, very important, top rated MCQ. The predicted MCQ, ricin removes one adenine nucleotide from the 28S ribosomal RNA and it blocks the translation, blocks the peptidyl transferase activity of the 28S ribosomal RNA. Cycloheximide binds to the 60S ribosomal unit, inhibit the peptidyl transferase, blocks the elongation. And puromycin, it is structurally similar to the tyrosine tRNA. It incorporates into a growing peptide chain, causes the premature truncation of protein synthesis. It binds with the 60S ribosomal unit, also 50S ribosomal unit. 60, 50 matlab both prokaryotic and eukaryotic translation inhibitor, puromycin. It is structurally same as tyrosinyl tRNA. So puromycin inhibit both prokaryotic and eukaryotic translation. See, this is the black coloration, this is the black staining. It is because of the alkaptone deposits. This black urine on standing and black pigment deposit in the cartilage and skin. Enzyme defect is homogenticide oxidase. homogentisate oxidase is defective. Disorder is alkaptonuria. Alkaptonuria, because of homogentisic acid excreted in the urine. On exposure to the air, on oxidation, it is turned into the black color. Name of the pigment is alkaptone. Tendency to develop arthritis in the latter ages often goes unnoticed because the turning into dark color urine takes time to convert into dark color. This is the staining of the cartilage and the sclera black because of deposition of the alkaptone. This is a Castle's necklace dermatitis because of the niacin deficiency, particularly when maize or the jawar as a staple diet. It is taken as a staple diet. This is classical 3Ds, diarrhea, dementia, dermatitis in the niacin deficiency. Zinc deficiency is periorifacial dermatitis. This is albinism. Enzyme defect is tyrosinase. Tyrosinase. There is generalized hypopigmentation. Disorder is known as albinism. Albinism. Disorder is known as albinism, generalized hypopigmentation. This is the actually self-mutilating activity in which the child is abnormal behavior, is with the abnormal behavior, and the aggressive behavior is there with self-mutilating activity. Head banging and biting of the finger and lips is there. So this is the Lesch-Nyhan syndrome. Lesch-Nyhan syndrome, also associated with the hyperuricemia. Lesch-Nyhan syndrome, because of the defect, enzyme defect, that is hypoxanthine guanine phosphoribosyl transferase. This is purine salvage pathway defect. Purine salvage pathway defect. Salvage pathway defect, and it is associated with increased uric acid level. Increased uric acid level because of affected purine salvage and increased PRPP level. This is self-mutilating activity in the Lesch-Nyhan syndrome. These are the different tests done on the done in the biochemistry in the laboratory. This is a Benedict test. Benedict test, which shows the color changes. Benedict test. It is done for the reducing sugar. It is done for the reducing sugar. Reducing sugar. This is the ketone body Rothera's test. Rothera's test, deep purple ring at the junction of two solution given by the ketone bodies, not given by the beta hydroxy butyrate. This is Hayes sulfur test, sulfur powder sink to the bottom. Sulfur powder test, sulfur powder test, Hayes sulfur test बोलते हैं, Hayes sulfur test. It is for the detection of the bile salt. It is done for the bile salt. Hayes sulfur flower test done for the bile salt. This is Fauchet test. This is pista green precipitate, indicates the Fauchet test, which is done for the bile pigment. Bile pigment. On the filter paper there is pista green precipitate, which indicates the positive Fauchet test, that is which is done for the bile pigment. This is heat coagulation test. Coagulum appears in the upper 1/3 part because of the denaturation, loss of secondary, tertiary and quaternary structure. Only primary structure remain intact. This is a heat coagulation test. Okay, so heat coagulation test, Fauchet test. This is Hayes sulfur test. This is Rothera's test. This is Benedict test. Benedict test is for the reducing sugar, Rothera's for the ketone bodies, except beta hydroxy butyrate. Bile salt के लिए Hayes sulfur test. The Fauchet test is for the bile pigment, and heat coagulation test for the detection of albumin in the urine. Bedside detection of albumin in the urine. These are the key differences between VDJ recombination, class switching, and the somatic hypermutation. See, this is before antigen exposure, that is VDJ recombination. It is primary. The aim is to produce the millions of antibodies. Millions of antibodies. It creates diversity. It creates number of antibodies to fight against the different antigen. This is before antigen exposure, and it changes occurs in the variable region. Region of the immunoglobulin. So it is before the antigen exposure, and it too creates the millions of antibodies. Okay, this is VDJ recombination, genetic rearrangement. It is known as genetic rearrangement. Class switching occurs after antigen exposure. It is in the constant region of the immunoglobulin M. Immunoglobulin M is converted into immunoglobulin GARE. After antigen exposure, it is in the constant region, class switching, in which antibody changes its class, changes antibody class from IgM to IgG or IgA or IgE. This is known as class switching in the constant region, because the constant constant region of the heavy chain which decides the class of the antibody. Okay, this is after antigen exposure. This is also after antigen exposure. Somatic hypermutation, a specific change or the mutation is done in the variable region. It is done in the variable region. It is after antigen exposure, and it increases the affinity of the antibody. Three processes, VDJ recombination to create diverse antibodies against the different antigen. Class switching, the IgM is converted into IgG or IgA or IgE, and somatic hypermutation, here affinity of the antibody, it is increase affinity of the antibody. This is known as the somatic hypermutation. So this is these are the important topics. The PYTs, PYQs से related PYTs generally, this involves the glycosaminoglycan mucopolysaccharidosis. This involves the glycogen storage disorder. This involves the lysosomal storage disorder, hyperlipoproteinemia, the lipoprotein, glycosaminoglycans, the vitamins, minerals, the inborn errors, rate limiting enzyme, the energetics of the different pathways, and the different important PYTs, for example, the electron transport chain inhibitors, uncouplers, and many important topics. So these are the important topics related with the FMG examination. Just revise what you read. मतलब आपने जो भी पढ़ा वो revise करो. Just go with your basic instinct, and best of luck all of you for your examination. So this is all for today. This is all about the all important points about the biochemistry. Thank you very much all of you. Best of luck. Thank you.